has been represented here. So we can see these areas where especially the interdigital spaces and the tips of the fingers will be missed while we are washing the hands. The 5 core components of the WHO multimodal hand hygiene improvement strategies are: we have to use alcohol-based hand rubs at the point of care, and access to safe continuous water supply, soap and towel should be provided, training and education to be given, observation and feedback, reminders in the hospital of their behavior, response to their awareness of being observed. So this Hawthorne effect also, this kind of observations also should be done. Automated electronic system to monitor hand hygiene complex. It's expensive, but potential ethical issues with tracking of individual activity, and no evidence is there for these kind of electronic systems. Consumption of hand hygiene products, alcohol-based hand rubs can be used to monitor hand hygiene complex. These are the 6 golden rules to improve hand hygiene. One is selection of appropriate alcohol-based hand rub. Rule 2 is the hand rub shall be easily available. Rule 3 is implement teaching and promotion of hand hygiene practices constantly in the institutes and create a hospital budget. Rule 5 is get senior staff to set a good example in order to motivate the junior staff. And rule 6 is have the patient to staff ratio well balanced. And these are the effective future strategies: provision of alcohol-based hand rubs, clean water, soap and disposable towels, staff education, monitoring of hand hygiene practices by wards, ICUs regularly, performance feedback, reminders in the workplace, promotion of a patient safety climate. These are the practices that we have implemented at NIMS: training and education, orientation given to all the residents before clinical posting, core curriculum classes were conducted, and continuous teaching to all the staff nurses covering all the standard precautions. Regular rounds of intensive care units were done, distribution of posters, feedback and hand hygiene practices, and observe World Hand Hygiene Day every year on May 5th by conducting lectures, quiz, elocution, and poster competition. This is a program that we have conducted recently in NIMS on May 5th of this year 2022 on World Hand Hygiene Day. And these are the classes that we have been taking but to create awareness of hand hygiene practices to the nurses of surgical ICUs, and also empowering the knowledge to all the nursing tutors of the medical college, nursing college. And this was the teaching that we have implemented in acute renal care unit regarding the hand hygiene practices and CLAPSI interventions. And ensuring availability of sterilium at every bedside in surgical ICU also was done by monitoring every day. And maintaining hand hygiene posters in the ICUs of NIMS. Infection prevention, it's in your hands. These are the references that I have used to present this lecture. Majority are the WHO guidelines. Thank you one and all for giving me this opportunity to present this topic. Thank you, sir. Thank you. Sir, can you use the mic? Sir, that's why I have represented here 4% chlorhexidine gluconate is available in the form of Bacto scrub. So that has to be used. It is a non-alcohol based detergent. We can use 4% chlorhexidine gluconate, which is available as a name of Bacto scrub.
Bacto scrub doesn't have any effect on the skin?
No, sir. It doesn't have any alcohol product. That's why it is specifically mentioned as non-alcohol based detergent that can be used for body bathing.
For psoriatic patients?
Yes, sir. You can use. You can use.
Psoriatic patients.
Yes.
Okay.
Any more questions? I can answer.
Good morning. This is a very important topic, madam, and you have extensively covered and told many valid points.
Thank you, sir.
I think all our colleagues here should try to clarify their doubts. Now, this was genuine doubt which was put forth because some of them may have sensitivity, but at the same time, See, the basic thing starts, infection control starts with cleaning our hands properly, because that is the main source of spreading the infection from one patient to the other patient and one source to the other source. So these are all, they look very simple, but what happens is in our day-to-day practice, we'll slightly become lethargic maybe at the end of the day, and we stop really taking care of this particular important aspect, and will ultimately we become the source of spreading the infection in the hospital. So all these measures what madam has presented should be strictly followed in all the areas. I know at times what happens will be, first patient will wash our hands, especially in ICUs, intensive care units, neonatal care units. First we'll wash the hands. By the time we go to the second patient, we may use the scrub there, whatever sterilization solutions are available. And by the time we go to the third patient, we may slowly start ignoring it. But I think these steps should be meticulously followed, and there are no shortcuts. This is what all of have to learn from the today's program, and the same thing you have to go back and convey it to your respective institutions and regularly see to that they are being practiced. What madam has shown the last few slides, the regular training program is equally important. Especially the new entrants will be there, new postgraduates will be coming, new students will be coming, new house surgeons, new nursing staff, and even the paramedical staff. All these people should be trained on regular basis. So this is a continuous program. It is not just one day attending a CME program like this and then closing it. It's not like that. It should be a continuous process in the institution, so that the best practices are followed meticulously or on day-to-day basis. Thank you.
Thank you, sir. Now I invite Dr. Neelima to give her next topic, biomedical waste management. She is associate professor from Department of Microbiology. Thank you, sir.
చేయాలా? Good morning, everyone. Just look at this picture, and I would like to interaction from the nurses especially. Look at this picture and tell me what are the mistakes in this picture. Can anybody please volunteer, and I'll wait for a minute. I want mainly the answers from nurses. Yeah, please. Somebody has. So sharps are going into red there. Okay, good. Then, any other mistakes can you point out it from this picture?
Good morning.
Yeah, somebody wants to.
Needle with syringe is wrong mistake. And
Needle with syringe is a wrong. Why? You can't dispose of along with the syringe?
We have to remove the needle, and after needle cutter, sharp instruments are collected in hypochlorous solution.
Okay.
and
So is it a
tin.
color coded bin? Is it a right one?
No,
Okay. So sharps should go in, not it cannot be put into a red bin. Okay.
Oh, yes.
Yes, and you can also see something swabs and gauze with the
Swabs.
blood. So
Gauze with
are those
gauze
can be
with
put in
blood.
red bin?
No, yellow.
Very good. So you know everything. So this is like a just so the talk will go like this. We'll deal with the definition, the sources, classification, the need for management, objectives, the process, and then we'll conclude. So what is biomedical waste? Biomedical waste means any waste which is generated during the diagnosis, treatment, immunization of human beings or animals or something with the research activities. So the sources of biomedical waste are major and minor. The major comes from the hospitals, nursing homes, etc., and the minor will be from the clinics and the other places. So what is the need for the biomedical waste management in hospital? So why do you have to do this? If you don't do it, you have several problems. So the things could be like it can lead to pollution, or it can end up in hospital-acquired infections or spread of diseases like hepatitis, tuberculosis, or the animals can be affected and in turn the humans can be affected. And the rag pickers, if it is not treated, the waste is not treated properly, the rag pickers, they can in turn be the source of transmission of the diseases or the infections. Who is at risk? So these are the people who are at risk: sanitation workers, medical, paramedical staff, patients and attenders, and the public. So what is the nature of the risk? One is the nosocomial infection. So the risk can be either reuse of the untreated biomedical waste, especially the plastic waste, or reuse of the expired medicines. Outside hospital, the risk is mainly for the waste handlers, to domestic animals, as well as this becomes a potential propagation to humans. Yeah, the type of waste and the health hazard. If it's a human or animal or soil waste, the health hazard could be all these infectious agents like HIV, HBV, HCV, so on. Sharps, mainly HIV, HBV, HCV. Cytotoxic, and the risk would be cancer. Chemical waste, poisoning, dermatitis, etc. So what are the objectives? You would like to minimize the production or generation of the waste. The main idea is recycle the waste, treat the waste, and adequate care while handling the waste, and safety precautions. So the waste which are not included in biomedical waste includes the hazardous chemicals, the radioactive, solid, lead acid batteries, and waste which is covered under e-waste. So we just run through this flow chart. So the waste is generated. At the point of source itself, it has to be segregated and then collected properly in a color-coded bin, transported, and then treated, and then disposed of. So these are the various rules which are under Environment Protection Act. First, it has come into play in 1986. Then there was modification in 98, 2003, 11, and the current guidelines what we are following is of 2016. So what changes have been from 98 to 2016? In 98, we had several categories, 10 categories were there, and the color-coded bags based on these waste categories. Whereas in 2011, they made it simpler, made it into 8 categories. 2016, even much simpler, it's just 4 categories. You have 4 color-coded bins, that is red, yellow, the white, and the blue. Yeah, black for the general waste, yes. So previously it was like this. So based on the waste, you have picked up. So I'll not go into those details. Let me just run through this. So we'll concentrate on the latest guidelines. So the stakeholders which are covered under biomedical waste, you have an occupier, an operator, and the prescribed authorities. So occupier could be your own institution, the hospital or the nursing home. Operator, the facility operators of the common biomedical waste management, which is involved with collection, reception, storage, transport, treatment, and disposal. The prescribed authority will be the Ministry of Ministry, okay? Several ministries are there, like state, central, and all that. So what is the duty of an occupier? So phase out all these chlorinated bags. Don't dispose of biomedical waste with the municipal waste. Establish the barcode system. Inform the authority if waste is not disposed of within 48 hours. Waste should be outsourced if it is within 75 kilometers radius. So now, as per the newer guidelines, at your own facility, you cannot go for the treatment or the disposal of the waste. So you should have a common facility, so where you're outsourcing. I think majority of you are also outsourcing, I believe. Yes? Yes. So what are the steps involved in the biomedical waste management? So I already told you, it has to be segregated at the point of generation itself. Pre-treat the waste, especially the laboratory waste. Collect and storage of properly segregated waste. Then the transportation, you should have dedicated trolleys to transport it to a central facility and then store it, not more than for 48 hours. If there is a delay sometimes, it has to be informed to the authorities. It has to be treated and then finally disposed of. So now we'll concentrate on the color-coded bins. Just focus on this because I will be giving few case scenarios based on these color-coded bins. So I said as per the 2016, we have only 4 color codes. So first we deal with the yellow. What all should be put in yellow? So human anatomical waste, animal waste, soiled waste, expired medicines, cytotoxic drugs, chemical waste, discarded linen, microbiological waste, other clinical lab waste. All these live attenuated vaccines also can be put into the yellow bag. So pre-treatment is required for this kind of waste. Coming to the red, it's infectious. So all recyclable and plastic items should be put in red bag. So like all your catheters, tubes, IV sets, Eurobag, pipette tips, gloves also should be put in red bag. Then your sharp containers. This is called as white, translucent, puncture proof it is. What all will be put? Mainly the sharps as well as metals also can be put into this. Next is the blue. All your glassware, the broken or discarded glass, your medicine vials, everything will be put into the blue. Blue can be a cardboard box. So based on your color-coded bin, the waste you have put in, that is how it is disposed of. Yellow, it is all infectious, they are non-plastic, hence it can be subjected to incineration. Whereas the red, it is all infectious but plastic. So how it should be disposed of? Either by autoclaving or microwaving. Here you cannot go for incineration. I think you understand why. Because plastic generate lot of toxic fumes, which in turn lead to cancers and all that. Next, the sharps, which are there in the white translucent, you can go for autoclaving or microwaving or followed by shredding. This blue, disinfection or the autoclaving. So all these can be recycled, the red, the white and the blue. So the hierarchy which we follow is reduce, reuse, recycle, recovery and landfill. Not only the waste which is generated, you should also concentrate on the packaging. So what should be taken care? So the biomedical waste bags and the sharps should be filled not more than 3/4 of the bag. It should not be like overloaded. Plastic bag should never be stapled. It should be tied in turn or sealed with a plastic tag. Color-coded bags printed with a biohazard symbol. I think you know how a biohazard symbol looks like. And then this barcode has become mandatory now. Previously there was no barcode system, but now it has to be barcoded also. Ensure that your barcode stickers are pasted as per the Central Pollution Control guidelines. Not only the packaging, the labeling should be very appropriate. It should have all these details like the date, the type of waste, quantity in kgs. I think you know how much waste will be generated per bed in an hospital. Any guesses? Per bed in a day. About 1 to 2 kg in our setup, okay? And if you take Western countries, the waste generated will be even huge. Type of waste, the quantity in kg, name and address of the hospital, the sender's number, and the receiver's details. This is how the biohazard symbol looks like. And the right side is the cytotoxic symbol. So you also have now a QR coding system. I think you all are aware of it, but still I'll just tell you how does it look like. So first 5 digits of the name, it indicates that it is of the healthcare facility from where it is. And next is the 6-digit PIN code, the 2-digit state code, and the 2-digit type of the healthcare facility it is. So this is how the QCMS will work. So you will have to package it properly. A label has to be given. It will be weighed, and then it will be outsourced. Yeah, this is how the trolley looks like where it can be stored. And the record keeping is also very important. I think every hospital should have a biomedical waste committee also, where the hospital administration, the head of the departments are involved, and they have to be meeting at least once in 6 months to look over the progress, where their continuous job is to continuously train whoever is there and also retrain the people who are already trained. Also, they have to take care of their health checkups, and also the all healthcare workers has to be vaccinated. All this can be taken care. And you can also have an audit being done for the biomedical waste, where you can have the rounds and see whether the waste is being discarded properly in the proper bins. You can have a format, I'll just share it. And this can be, and annually you can make your report, and it usually it has to be sent 30th, before 30th of June to your state pollution control board. And they in turn will make a report by 31st of July and then share it to the central. This is what it should be done. And especially this PPE, you should see that the person who is handling the waste, this has to be given to him because he is also at risk. So heavy duty gloves, not the normal gloves, heavy duty gloves, the gum boots, face mask, head cap, and the splash proof apron has to be given to him. So I'll just move on to the case scenarios if we are there. Yeah, time is still there. Yeah, I would like to interact, especially the people, nurses. Just look at this question. Okay, I'll read out. Laboratory personnel uses plastic apron. So plastic apron, non-plastic mask, latex gloves while processing an infectious sample. Tell the appropriate biomedical waste management. So I've given the options. You can choose the option. So plastic apron, mask is non-plastic, and the gloves. I think somebody please answer A, B, C, D. You can pick up something. Yes, I heard it as A. Yeah. Tell me, madam. C. You want to say gloves, mask,
Gloves.
apron, everything is in red. Why, madam? I told plastic will go to red, right? So, would you like to change your answer?
Gloves apron red.
Yes?
Mask in
Yellow. Okay.
no.
Yes, A is the correct answer. Just move on to next question. An intern was asked to transfuse whole blood for a patient in shock. After the transfusion is complete, how should the waste be disposed? Just look at these options. Yes. Uniformly it is C this time. Correct. Yeah, correct it is. This nursing sister finds half-used open cyclophosphamide glass vial. That means it's a cytotoxic kind of waste in a medical oncology ward. She wants to dispose it. Tell the appropriate method of disposal. Yes? I thought you'll be very quick this time. D? Yes. So, uniformly it is D, or you want to change your options? D? Sure? No? There's confusion? So you are confused because it is a glass vial. I know. Okay, good. That confusion is needed. But still you can focus that it is a kind of cytotoxic waste. I said, though it is a glass, if it is a cytotoxic waste, it should go into? Yes. So it is, everything is clear for you then. So I don't know whether we have time for this group task. If we want to go ahead, we'll, otherwise I'll stop it here. Can we go ahead or shall we stop it here? Go ahead? Okay. So we are having this, the audience, we can divide it into 4 groups. Those who have come from, not the NIMS people, the other people. Those color coded, yellow, one, I think the first 2 rows can go for the yellow. Next 2 rows, the red. And the next one, the white, and the one blue. We are not going with the general waste here, so we are just talking only about the medical waste. So I will give you the list of items here. So you will tell me in turn, it's a group activity. You will tell me like what all waste will go into the yellow, the first 2, and tell me the compliance rate. Just calculate and tell me. Whoever is given the red, you tell me what is the percentage. Similarly for the white and blue. So here I'll give you some 3 minutes time. I think that would be sufficient. So the gloves, just pick up whatever will go into the yellow and you calculate. Total 25 items are there. Similarly, red, what all will go into red, just see those items, calculate. So the denominator is common, it is 25 for every color coded bin. So lumbar puncture needle, so it's a needle. Central vein is catheter, plastic. Venflon stylet, I'm giving you the hints here. Stylet is again a sharp. Venflon, mask, non-plastic, metallic implant, I've told you where it will go. Sharp again the forceps, IV set, blood bag, nasogastric tube, syringe with the fixed needle. Just concentrate, it is not just syringe. We have two items here, one with the needle, the other one was only with the only syringe. Needle with cover, needle, just the needle cover, broken glass ampule, the Bactec bottle. Bactec bottle is a blood culture bottle. I think for the people who doesn't know, you have a plastic kind of bottle that is called as Bacti-Alert. Bactec is a glass bottle. So then, based on that, you can tell me. Cytotoxic bottle, expired medicines, broken glass ampule containing antibiotic, glass ampule containing diclofenac injection, stained cloth, stained cotton, stained plaster. So I'll just wait for some time once you are done, but only 3 minutes, not more than that. So I'll just give you how to calculate. You can just pick up your items, whatever color coded you are given. Like for example, if you're taking yellow, just count the number of items which are going into the yellow bin, and then the total number of items into 100. That gives you a compliance rate. Continue అన్నారు. I think so I should wind up. Okay. I think you all are ready, or you need some more time? You're ready? Areba, you're very quick. Okay. Yellow, can you tell me the percentages? How much? Total 8 items in yellow. So what will be the percentage? Okay, next. Red.
Eight.
8. So what will be the percentage? 8 by 25 into 100. So it becomes? You're not able to? Okay. Okay. It's 32, huh? Next. Next. The white and the blue. Yes, 9. 9 out of 25. And the blue? So yellow is 32, red is 32, white you said 9, that means you want to say 36 percentage. And then blue? Still calculating? Okay. We'll go ahead with the discussion. Let us see whether your percentages are correct or not, whether you got the right percentages or not. Okay, gloves into red, you all know. Lumbar puncture needle will go into white. Central venous catheter, because it's a plastic, it will go into red. The stylet is a sharp, so it will go into white. Venflon is a plastic thing, it will go into red. Mask, yellow. Metallic implant, I already told you, blue. Metal sharp forceps into white. IV set into red. Blood bag into yellow. Nasogastric tube into red. Syringe with fixed needle, so it will go into white. Only syringe will go into red. Needle with cover, because there is needle, though there's a cover, it will go into white. Only needle will go into white. Needle cover, plastic, so it will go into red. Broken glass ampule, I already told you, the glass ampules will go into blue cardboard box. The Bactec bottle, I told you, since it is a glass, it will go into blue. Cytotoxic drug, yellow. Expired medicines, yellow. Broken glass containing antibiotics will go into blue. Glass containing diclofenac, also blue. Stained cloth, yellow. Stained cotton, yellow. And POP, yellow. Okay? So you want to change your percentages now? Yes? Or you want to still keep your percentages the same? So you can count your yellows. First we started with yellow, no? How many yellows are there? 1, 2, 3, 4, 5, 6, 7 yellows, not 8. So you said 8. Red can also count. Red also 7. It's not 8. White, you people said 9, no? White is only 6. And blue, no answers. I didn't get any answers. So this is how you have to calculate your compliance rates. You'll have to count what is the number of items disposed and total number into 100. That gives. So yellow was 7, so the percentages will be 28. Red also same. So this is how. Overall will be 25%. This is how you can calculate your compliance rates. So you'll have to make rounds and see whether they are adhering, and you can calculate this and circulate it. You can make these audit forms. Somebody can record this, especially the infection control nurses. Okay? Whether it was disposed of appropriately or not. You can file it up. Coming to the conclusion, so biomedical waste is should be segregated at the point of generation itself. Adequate number of color-coded bins should be available. awareness posters should be displayed in all the wards. So general waste and BMW waste should never be mixed. And what percentage is the are the medical waste? So the major chunk is the general waste or the biomedical waste? Yes? General waste, sorry, general waste. So your medical waste is about 20% and the other chemical waste will be around 5%. So the hazardous waste is only 15%. But that 15%, if you don't take the precautions properly, then it will land up in a huge problem. So waste storage, transport and disposal should be done within 48 hours. Avoid chlorinated bags. Now the current guidelines says don't use them. Proper labeling is very important. So you ask them for the barcode labeled covers, then only it is acceptable nowadays. And also the person who is handling this waste, proper PPE should be given. That's it, these are the differences. So with this I would like to end the talk. Thank you. Yeah, if you have, you're welcome. Bactic is not a plastic, it is a glass bottle. Bacti Alert is a plastic bottle.
Yellow.
Bacti Alert should go, because it's a plastic, it should go to the red.
If we consider it as microbiological waste.
No, but that you will have to autoclave this and then put it in the color-coded bins.
Yes. That's what. Autoclave and then if it's plastic it goes into red.
Madam?
నా పెన్ డ్రైవ్ ఉంది ఇక్కడ మై పెన్ డ్రైవ్ వస్తే తీసుకొచ్చాను
I thank Dr. Neelima for her presentation on biomedical waste management. Now I request Senior Resident Dr. Sabanas to give her lecture on safe injection practices and needle stick injuries.
Good morning everyone, Dr. Sabanas, and today we are here to discuss safe injection practices and needle stick injury. So let us start with the case discussion. In 2008 in Nevada in an endoscopy center, doctors observed an increase in cases of HCV reported in patients. So this was reported to CDC, the Center for Disease Control. So after the investigation, it was found that unsafe injection practice was the reason for increase in HCV cases. So they were reported around 9 cases in a span of 2 months. Generally, it was about 2 to 3 cases per year, but they found 9 cases in a span of 2 months. So how did it happen? Initially, a new needle and syringe was used to draw a medication, and that was injected in an HCV infected patient. So after that, they thought that the same syringe with a new needle would be a safe practice, and they discarded only the needle, but the same syringe, and put a new needle and injected that into the same vial, the old vial, and drew a dose of medication, and then injected that into another patient. So this was the reason for an increase in HCV transmission. An outbreak of HCV happened. So this caused about 9 clinic-associated HCV cases, about 106 possible clinic-associated cases, with 63,000 potential exposures, costing about $16 to $21 million. So this tells us the importance of safe injection practices. So what are safe injection practices? They are providers should follow when they give injections. So this prevents infection from patient to patient, patient to provider, and provider to patient, and also most importantly prevents harmful needle stick injuries. So the prerequisite before administering and preparing medications, mainly for the nurses here in mind, always prepare medication using aseptic technique, disinfected the vial septum, and follow aseptic technique while assessing the central line and injecting any medication. And the rule 1, never reuse needles or syringes that have been used for any purpose, and vials with a single dose vial label on it, saline bags, and IV tubings. So these are the steps every healthcare worker should take for administration and preparation mainly of the medications. Okay. So the prerequisite, as we all know, before performing anything, we have to perform a hand hygiene. So never administer medications from a same syringe to more than one patient, even if the needle is changed. Use freshly opened 10 ml vials of normal saline for preparation of medications for individual patient. And never enter a vial with a used syringe or a needle. So these are the hand hygiene steps which we have already seen in the earlier class. Next, do not use medications packaged as single dose or single use for more than one patient, and do not use bags of intravenous solution as a common source of supply for more than one patient, and limit the use of multi-dose vials and dedicate them to a single patient whenever possible. Always use face masks when injecting material or inserting a catheter into epidural or subdural space. So these are some dangerous misconceptions present in our in the community, in the healthcare workers community, and today we are going to bust them. The first one is changing the needle makes the syringe safe for use. No, once they are used, both the needle and the syringe are contaminated and must be discarded. A new sterile needle and a new sterile syringe should be used for each injection and each entry into a medication vial. Syringes can be reused as long as injection is administered through an IV tubing. No, because syringes, needles, and this IV tubing, they are all a single interconnected unit. So distance from the patient, gravity, or infusion pressure does not ensure that small amounts of blood won't contaminate the syringe and the tubing, and hence it has to be changed. So it's a myth that if you don't see blood, if it's not visibly soiled in the IV tubing or syringe, then it is safe for reuse. No, like germs such hepatitis C and MRSA, they are invisible, they are microbes, right? So, but these can infect patients even when the patient present in microscopic quantities. That is what we have seen in the case of Nevada. Do not reuse syringes, needles, or IV tubings. And another myth is it's okay to use leftover medicine from use of single dose or single use. We are trying to save money, right? From vials for more than one patient. No, single dose or single use vials, they are named like that for a reason. So this must be used only for one patient at one time. Injection safety is every provider's responsibility. So what is this thing about single dose and multi-dose vial? So a single dose vial is approved for use in a single patient on a single time. So this is because they lack an antimicrobial preservative. So do not save the leftover medication from these vials. So harmful bacteria can grow and infect a person. So you have to discard a single dose vial every time after use. A multi-dose vial, on the other hand, this has some antimicrobial preservative in that, and hence will limit the growth of bacteria. Ideally, it is best to use a multi-dose vial for a single patient only. But in a resource-limited country, we are bound to use a multi-dose vial for more than one patient. So it's always better to use it at a single point of time for more than one patient, of course. Disinfect the septum each time you're drawing a medication, and use a new syringe and a new needle each time for each patient. And one more important thing is size does not matter. Just by seeing the size, a bigger bottle does not mean it is a multi-dose vial. A smaller bottle does not mean it is a single dose vial. You always have to read the label to know whether it is a single dose or a multi-dose vial. And multi-dose or a single dose, even if it is after expiry date, you have to throw them. So these are the injection safety steps for success according to CDC. Carefully read the label before the procedure. Check for the expiry date and If the single dose vial has been punctured, you have to throw it away. Double check the expiration date, and when there is a doubt about the expiration date, always better to throw it. During the procedure, aseptic technique, new needle, new syringe, be sure to clean your hand immediately after the procedure also, and disinfect the medication vial with spirit, and drop the medication in a clean medication preparation area. After the procedure, discard all the needles and syringes properly according to the BMW rules, and MDV should be discarded when beyond use date has been reached. Doses are drawn to a patient in treatment area, and anytime you can suspect that the vial sterility is in question. So at the end of the day, one day or the other, we are all going to be patients. So this is our responsibility. And knowing how to properly identify single dose and multi-dose vials will prevent infection and can save lives. So following basic safe injection procedures is not something to be taken for granted. There is too much at stake. Educate yourself and also those around you. And the only one rule you have to remember is one needle, one syringe, one time. Next, coming to the needle stick injuries. So how many needle stick injuries occur worldwide? The Department of Health Services in US reported about 6 lakhs to 8 lakh needle stick injuries each year. And CDC study estimates that 3,85,000 needle stick injuries to the hospital-based healthcare personnel occur each year. That is about more than 1,000 per day. And the WHO states that 37.6% of hepatitis B, 39% of hepatitis C, and 4.4% of HIV/AIDS in healthcare workers is because of a needle stick injury. Coming to Indian scenario, a study from Bihar states that 19.46 per 100 occupied beds per annum is the needle stick injury rate in our country. So what are the infections that can occur by sharps injury? Mainly, we have hepatitis B, HIV, and HCV. Apart from these, we do have other bloodborne pathogens. Of course, we don't really read about them, but they are present. So mainly HIV, HBV, and HCV are the main important three infections, and we will be discussing about them further. So what is the risk of seroconversion due to sharps injury from a known positive source? With HBV, it is 6 to 30%. So 30%, the risk increases if the healthcare worker is unvaccinated. So hence, we have to be vaccinated for hepatitis B. HCV, it's around 2%. HIV is around 0.3%. So what is the risk for HIV alone? Again, depends on the depth of injury. If it is percutaneous, there is an increased risk with a hollow bore needle, visibly bloody device, deep injury, or device in artery or a vein. If there is a mucous membrane, a large volume increases the risk. If it is a cutaneous, if a non-intact skin, it will be a risk. So how long can a hepatitis B, HCV, and HIV virus survive outside the human body? HBV survives for around 7 days outside the human body and can cause infection if it enters the body of a person who is not infected. HCV can survive for about 3 weeks on environmental surfaces at room temperature. HIV can survive in dried blood for about 3 days. So this is why it's important for the environmental cleaning. This focuses on environmental cleaning. So who is at risk? A study states that staff nurses, student nurses, and housekeeping staff are at the most important risk of needle stick injuries. So what kind of devices usually causes sharp injuries? Hypodermic needle, blood collection needle, needle used in the IV delivery system, scalpels. So how do they occur? CDC states that 35% are during sharps cleanup and disposal, 28% during manipulating the needle, 10% colliding with the coworker, and 0.6% is due to recapping of the needle. So have you noticed that 35% happen after the procedure has been done? So sharp safety, prepare to use the device the moment. We have to be prepared before giving an injection. So prepare to use the device the moment the sharp is first opened. Take precaution while using the sharp, take precaution during cleanup, and take precautions during disposal. So they are the three main parameters we have to be aware. Be prepared, be aware, and dispose with care. So be prepared. Of course, hand hygiene always comes first. Then you have to organize your equipments and use adequate lighting. Keep sharps pointed away from the user and plan ahead whom to give, what injection to give, and what you're going to do with the sharp after you're done with the injection. And if you need help, it's always better to ask for help. During the procedure, keep sharps visible, avoid distraction, and if you're carrying a sharp in your hand in the ward, it's always better you let the people around you know that you're having a sharp with you. And be aware of the staff nearby, and use predetermined neutral zone for placing or retrieving sharps. So after they are done, it's better you carry a tray with you where to keep the sharp rather than holding it in your hand. And alert others when sharps are being passed. Do not bend or break needles. This is a very important thing you have to do. Do not recap needles or scalpels, except when these are being done by a mechanical device or a one-handed technique. So this is the one-handed technique for recapping a needle. This is the recapping the needle with both hands is the commonest what we see in our hospitals with the student nurses, which causes a needle stick injury. So this is the one-hand technique for recapping a needle. Next, cleanup. As we have seen, cleanup is the important part where needle sticks are occurring. So what we have to do here, we should be accountable of our sharps. Do not disassemble needles from syringes by hand prior to disposal. That's what madam has told, right? We do not have to disassemble them. Use hemostat or forceps to move items when uncovering or checking procedure trays. And look for sharps equipment left behind inadvertently. And while disposing of sharps, inspect the container, keep hands behind sharps, never put hands or fingers into the sharp container, and if you dispose sharps with attached tubing, to be aware that it can recoil and lead to injury. Maintain control of both tubing and the device during the disposal. So visually inspect sharp container for overfilling. So replace the container when no more than 3/4 full. So which container will you use for sharps? The white puncture-proof container. Yes. So we have to see that it should not fill for more than 3/4. And if you find improperly disposed sharp in the work environment, what do? Handle it carefully. Do not pick it up with the hand. Always use a hemostat or a forceps to pick it up and then dispose it off properly. And what is your part in prevention? Adhere to the safe practices, support co-workers in safety practices, report injuries of blood or body fluid exposure, sharp injury, hazards, and near misses. You have to report them. And participate in training for devices and properly use sharp safety features, and participate in safe culture and device evaluation. So we have to assess the situation to determine the safest manner in which to perform a job or task. Watch for hazards or anything. And if the patient is like he's not going to be cooperative, it's better you ask for help before giving it off individually. Allow enough time to perform the job in a safe manner. Don't rush. You have to work efficiently, of course, but don't rush in giving injections. Rely on others to assist you if you need. Expect 0 injuries. Expect that you will reach our workplace goal and expect a positive outcome. Challenge yourself never to get a needle stick injury. So these are the prerequisites. Get a hepatitis B vaccination, wear gloves, and wash hands. Okay. So by chance you get an injury, ill luck. So what do? Provide immediate care. Wash the wound with soap and water. Do not squeeze the wound. This is what we generally observe. What they think is if we squeeze out the blood, then maybe the infected blood is going to come out. No, that will increase the blood supply circulation more if you're going to squeeze it out. So always wash the wound with soap and water. Do not use sterilium or anything. Just plain soap and water. Do not squeeze the wound or use antiseptics or caustic agents like bleach, and alert your supervisor. And what happens when you're stuck? And identify the source. And HIV, if it's HIV, you get an ELISA done. Hepatitis B, test for HBsAg. Hepatitis C for antibody. And if the source is unknown, it's better to test for all the 3 tests. And if you're exposed, you get an HIV antibody, HBV immune status, you get your anti-HBs titers checked. And if it is more than 10, we don't have to take for passive immunization. And anti-HCV status and ALT. Post-exposure prophylaxis will be next in detail in the next class. So now, final. Just a review, just a small test. Most needle stick injuries occur before, during, or after a procedure. Yes. So having sharps disposal nearby is one way to be prepared before beginning a procedure. Is better to keep it nearby, or is it better? Yes or no? Sharps disposal is always better to keep it near. Yes. So that you don't carry the injection to the whole across the ward and throw it at the end of the ward. It's always better to keep at least a small container or anything. You should use hemostat or forceps to move items when uncovering or checking procedure trays, waste materials, or bedding for exposed sharps. Better to use a hand or a hemostat? Forceps. Yes, true. Sharps disposal containers should be emptied when they are no more than 3/4 full. Yes. Needles should be removed from syringe or tubing before disposal. True or false? Yes or no? Should we remove the needle from the tubing before disposing it? Yes or no? Well, maybe it'll take a minute to discuss it again. Squeezing of the finger after needle stick injury is a good practice. False. Okay. Thank you.
I thank Dr. Sabanas for giving us enlightening her lecture with. Thank you. We'll wait for the program of inaugural function for the next 5 minutes. So if you have any doubts on this lecture, you can please pose your questions.
Yes.
Can you go to your presentation to the slide providers? Fifth or sixth slide.
Regarding?
Regarding using of the multi-dose vial for a single person, can you clarify on that? Because in the theater, we have a local xylocaine, which is a multi-dose vial.
Okay.
And what is your suggestion to use it? When we cannot use it for one person anyhow, that is a 30 ml vial,
Yes.
then it's a multi-dose vial.
Yeah.
And what is the safest way to draw the medicine? And apart from using a syringe every time.
Yes, sir. That is one
And
thing.
you are
It's
just suggesting to use even for the multi-dose vial only for one patient.
yeah,
What is
ideally,
the practicality?
yeah, ideally, that is what I have told. In a resource-limited country like us, it's not practical enough to say that a multi-dose vials also to be used for a single patient. That's why it's better. What we do, we have to follow proper aseptic techniques while using a multi-dose vial. So when we are using a multi-dose vial, of course, as you said, sir, the xylocaine, we can't use it for the same patient, right? We need only one time is needed for the patient. So what we have to do, we have to disinfect the septum each time we use. Take a new needle and new syringe for each patient. That is what we can do. Has a rubber septum, right?
That's what we are doing.
So, but what we see in the wards generally, they stick the needle is stuck in that vial, and they just take a new syringe and start taking it. So that is a practice which should not be followed. What we see in the multi-dose vials in the OTs and in the wards as well, we generally see to the rubber septum there is a needle stick to it. So that is what we are saying, which should not be done.
Sir,
Always better to take a new needle and a new syringe for every patient.
Good morning, sir. I'm also a clinician, so I know this type of practice. So what we have to do is, as she is told, we'll disinfect that area and we take a new syringe every time. And then sometimes what happens in a hurry, they open 2-3 xylocaines, like it's a big OT and like that. So we'll see that one is open and it is completed, and then we go to the next one. And we see the expiry date, all that, as anesthesia doctors, you know very well all that. So, but then if somebody is helping you also, they should practice all these things. So we have to disinfect it and take a new syringe and then dispose it off, just after the usage. And if for the same patient, if you're again using, let us take another syringe, and then use it and, like that. Don't keep it for some time, then it will be used for somebody else. I know, like you're all course directors and you're like teachers and like that. But these are the things which are observed often in the OTs and in the general wards. Several times, even in our own hospital also, you have this patient tray, and several times they keep the needles after diluting, after giving the IV antibiotics, ceftriaxone. They keep it. I don't know for what reason we keep it, but maybe thinking that we can reuse it like that. So after removing the blood sample and all that, they are disposing. But for the needles, after giving an antibiotic, the false sense of security that we can reuse it again. So all these things, I think we have to move forward, and then disposing, even after giving the injection to the patient, immediately we should dispose it out.
Needle and the syringe. That is
Apart from this, I think practically we are involved in these things now. So we can just label on the vial or the date of open. If it is used 1 week before, that's well and fine. Or end of the week, we can just discard the vial, I feel so.
Preload the syringes and label it and keep it in the fridge.
Good morning to all. Myself, Dr. K. Padmaja, Associate Professor in Department of Microbiology and Hospital Infection Control Officer and Organizing Secretary of this program. I wish a warm welcome to all the dignitaries, delegates, faculty, and my dear colleagues. I invite our beloved Director, Sir Dr. Ramurthy Garu, Nizam's Institute of Medical Sciences, to occupy the chair. I invite respected DME Sir Dr. Ramesh Reddy Garu. Yes. I request our Honorable Health Minister Garu, Mr. T. Harish Rao Garu, to give his overview of this hospital infection control program. Yes. I request our beloved Honorable Minister Garu to kindly inaugurate the lamp lighting of this hospital infection program. I request all the dignitaries to please join the lighting of the lamp. Yes. I request Lavanya to give her prayer song. Please join us, Lavanya.
Good morning, one and all. Ya kundendu tusharahara davala ya shubra vastravrita श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रकृतिभिः देवै सदा पूजिता सा मां पातु सरस्वती भगवती निशेष जाड्यापहा. Thank you.
I request our beloved director, sir, Dr. Ramurthy Garu, to give the overview of the program. Thank you, sir.
Good morning, ladies and gentlemen. Respected Honorable Minister for Medical Health and Family Welfare, Shri Harish Rao Garu, dignitaries on the dais, Commissioner Health and Family Welfare, Sweta Mohanty Garu, Telangana Vaidya Vidhan Parishad, Dr. Ajay Kumar Garu, Director of Medical Education, Dr. Ramesh Reddy Garu, my colleague and OSD to the CM on Health, Dr. Gangadhar Garu, faculty members in the audience, the attendees to this event. A very warm welcome to you all on behalf of the Nizam Institute of Medical Sciences. On this occasion, I extend a warm welcome to Honorable Mantri Garu to the Institute and also thank him on behalf of all of us, in particular the Department of Microbiology, for giving us this opportunity. Under his guidance and with a vision, this particular topic has been thought of. And to execute this, the guidance was extended by our Commissioner Madam, Dr. Ajay Garu. Dr. Gangadhar has taken an active lead. And of course, DME, Dr. Ramesh Reddy Garu, through the institutions under the DME, has ensured that the beneficiaries from various government medical colleges get the advantage of this particular program. Hospital infection control committees are the order of the day, more so with the bugs and the superbugs growing in the hospitals. It is important that we need to understand the infections which are coming to the hospital. At the same time, those which are acquired in the healthcare settings are equally to be understood and to be treated. According to one of the census, the incidence is something like 2 million with about 80,000 deaths annually. But I still feel this data must be skewed for a country of this magnitude, where we have healthcare facilities of different magnitudes. We have the specialty-oriented hospitals, super specialty hospitals, we have the district hospitals and the primary healthcare centers. So the magnitude of the hospital-acquired infections or the infections within the community are much larger and much more alarming than probably what has been published till date. There are many hundreds or thousands of lakhs of cases which are probably not registered. So the lack of documentation probably skews this data and does not give us a realistic picture. What is of importance as far as infections is concerned, of course, very well my colleagues, Dr. Padmaja and Dr. Nilima, before Sir's arrival, have covered two important topics. One of the hand hygiene, which is one of the most important as far as the prevention is concerned, and the biomedical waste disposal. These are important things which in the hospital setup are the ones which are responsible for, inoculating these organisms into individuals. I will not take much time because we would like to eagerly wait to hear our Mantri Garu. On this occasion, I congratulate the Department of Microbiology at NIMS and thank both the Commissioner of Health and Family Welfare, the Ministry of Health and Family Welfare, as well as the Director of Medical Education for giving us this opportunity of collaborating. I think it's a very essential and a very nice move by the healthcare agencies, the DME and also the Commissionerate of Health and Family Welfare. Such kind of collaborative programs should be held more often so that we have a collaboration between the various government institutions, NIMS, Osmania, and Gandhi Hospital. I think we must have such kind of frequent sessions for different sections of our staff to make them aware as far as the infection and the infection control, which is one of the primary objectives of healthcare today. With these few words, I thank again all the attendees who have taken pains to come here to update their skills and to exchange their experience and knowledge with the audience here, the faculty especially for taking out their time from the busy schedules. Once again, I thank our Honorable Mantri Garu. Sir, thank you very much for paying a visit to our institution. And thank you for giving me this opportunity. Thank you.
Thank you, sir, for your valuable speech. Next, I invite our respected DME, sir, Dr. Ramesh Reddy Garu, to give his valuable speech over this program. Thank you, sir.
Honorable Minister, Sri Harish Rao sir, Commissioner Family Welfare, Sweta Mahanti Garu, the Dean of and the In-charge Director of NIMS, Ramurthy Garu, Commissioner TVP, Dr. Ajay Kumar Garu, HOD of Nephrology and OSD to Honorable Minister, Honorable CM, say Dr. Gangadhar Garu, and all my colleagues who have come from various hospitals and the faculty of NIMS. This is a very important and I feel it is a game changer in the days to come as far as management of our hospitals is concerned. As we know that in the last 7 years after the state formation, there is a significant change in our hospitals by getting them equipped with infrastructure, manpower, and especially after Honorable Minister Sir has taken over, there are a lot of changes, and with his suggestions, we are moving forward in a very positive direction. But there will be certain roadblocks, especially in places like this, infection control, which happens to be one of the most important aspect in the overall outcome in a hospital. If you want to have a positive outcome, ultimately the patient who goes out without any complications is a reflection of what healthcare we are providing. And for that, the infection control is one of the important aspects, and keeping that in mind, the Honorable Minister Sir, he has advised us that this should be effectively implemented at every hospital level, not only in teaching hospitals, even the secondary hospitals also, up to the primary healthcare level. Everywhere the proper standard protocols have to be followed. And for this, we are very thankful to the management of NIMS, especially the microbiology and the other departments who have devised this 2 days curriculum to have a reorientation for our infection control officers and infection control nurse, whom we have identified from various teaching hospitals and who have gathered here today. And the next goal for all of you is, it is not just an ordinary CME. There is a lot of responsibility on you. You have to go back and train the other personnel in the institution on all the good practices, what they have to implement, so that we can have an effective infection control mechanism in your own institutes. So I hope these 2 days will be very useful to all of you, and you will take a lot of knowledge which you acquire here to the respective institutions, and let's hope that in the days to come, we are going to have a very good infection control policy from not only the operation theaters, ICUs, wards, everywhere. And that will automatically reflect on the antibiotic policy also in our hospitals. Because as we all know, without knowing the organism so many times, we'll be just using empirically the antibiotics, which itself is a burden on the state exchequer also. We are using such costly antibiotics which may not be really useful for that patient. So obviously these are all interrelated things, and we should now look it in a different perspective and see to that all these are standard procedures are implemented in all our hospitals. And I'm sure our Honorable Minister Sir will give us more enlightenment into this particular aspect, and all of us collectively should see that this is taken forward and effectively implemented in all our hospitals. And again, I would like to thank the Nizam's Institute management for organizing this so in such a beautiful fashion here, and we thank you, sir. Thank you.
Thank you, sir, for your valuable speech. Next, I invite our Commissioner Health and Family Welfare, Srimati Shweta Mohanty Madam, to give her valuable speech over this program.
Thank you. గౌరవనీయులు మంత్రివర్యులు శ్రీ హరీష్ రావు గారికి, డిఎంఈ గారికి, కమిషనర్ టిఎస్వివిపి గారికి, ఈ ప్రోగ్రామ్ ది హోస్ట్ డీన్ నిజామ్స్ ఇన్స్టిట్యూట్ ఆఫ్ మెడికల్ సైన్సెస్ గారికి, డాక్టర్ గంగాధర్ గారికి, ఈ సభకి వచ్చిన అందరికీ నా హృదయపూర్వక నమస్కారం. I welcome the initiative of doing this hospital infection prevention and control program. But elane ipudu Pradina nunchi Dr. Padmaja and other senior doctors have been taking this training program. As a layman and as Commissioner of Health, I will say a few things. మా అందరికీ తెలుసు కి గత 2-3 వారంలో కొన్ని ఇన్సిడెంట్స్ జరిగింది కొన్ని హాస్పిటల్స్లో, అండ్ దాంట్లో మంత్రి గారు ఇచ్చిన ఆదేశాల ప్రకారంగా చాలా డీటెయిల్డ్గా ఎంక్వైరీ చేయడం జరిగింది. దాంట్లో ఒక 2-3 విషయాల గురించి నేను మాట్లాడతాను. ఈ విషయాల గురించి మాట్లాడిన ముందు నేను నా పర్సనల్ ఎక్స్పీరియన్స్ చెప్తాను. ఒక 2017లో కేసీఆర్ కిట్ వచ్చిన తర్వాత ప్రతి ఒక్క గవర్నమెంట్ ఆసుపత్రిలో కొత్తగా ఒకటి డ్రైవ్ పెట్టడం జరిగింది కి తప్పనిసరిగా డెలివరీ అయితే ప్రభుత్వం ఆసుపత్రిలో అవ్వాలి. రెండవది ఎక్కువ వరకు డెలివరీ నార్మల్ చేయడానికి ఒక ప్రయత్నం చేయాలి. దానికి ముందు మేము చూస్తే గవర్నమెంట్ హాస్పిటల్కి రావటానికి చాలా భయంగా ఉండేది. అంటే అసలే వాళ్ళు చూస్తారా లేదా, మాకు సరిగా సర్వీస్ ఇస్తారా లేదా, అంటే 1 or 2 చిల్డ్రనే ఉంటారు, తో అందుకని ఎందుకు అంత కష్టపడాలి, మేము ప్రైవేట్కే వెళ్ళిపోతాను. బట్ అప్పుడు మేము 2016 తర్వాత ఈ ప్రోగ్రామ్ మొదలు చేసిన తర్వాత మేము చూసాము కి సర్వీసెస్ అంత బాగా అయిపోయింది కి ఎవ్రీబడి స్టార్టెడ్ గోయింగ్ టు గవర్నమెంట్ హాస్పిటల్. ఇప్పుడు మేము చూస్తే మా దగ్గర తెలంగాణలో 60%కి ఎక్కువ డెలివరీస్ మాకు గవర్నమెంట్ హాస్పిటల్లో అవుతాయి. ముందు మేము చూసేది దాదాపు ఒక 30%-20% ఉండేది. పర్సనలీగా ఐ వాజ్ కలెక్టర్ వనపర్తి దెన్. నా హాస్పిటల్లో అయితే వీ యూస్ టు హ్యావ్ 40 deliveries per month. But once KCR kit started, the deliveries became 200 per month, and that progress continued. So dantlo we have been doing Telangana's birth cohort prakaramga 60% deliveries memu government hospital lo chestunamu ante daniki artham ki memu prati oka loose end tie chesamu. Infection control gani, hospital staff ki, paramedical staff ki training gani, staff nurses ki training gani, and finally medical officers ki placement, gynecologists ki placement. Ivi anni tie up chesi tarvata we have been able to achieve such great results in the field of maternal health. మీ అందరికీ తెలుసు that ముందు where our maternal mortality was one of the lowest in the country, ఇప్పుడు మేము maternal mortality లో చూస్తే we are in the parameters we rank highest in the sense that we have least number of maternal deaths. So ఇవి అన్ని మేము చూస్తే what we understand is hospitals as a unit are very, very capable to do any kind of target-driven program as per the vision of the government. But what is happening is that konni chotalo, because of some kind of carelessness, we are having to face so many issues. Now, carelessness lo, of course, what is required is always training, retraining, refresher training, so that everybody is aware of what are the latest guidelines, and secondly, nobody forgets what they already know. So training is a very important part of ensuring that skills remain within the facility. The second part that I want to talk about is about respectful care. ఇప్పుడు ఒక హాస్పిటల్కి వెళ్ళినప్పుడు a layman like me, for example, who is not a doctor, ఒక చాలా రెస్పాన్సిబిలిటీ అండ్ ఒక చాలా నమ్మకంతో ఆ డాక్టర్తో లేకపోతే ఆ స్టాఫ్ నర్స్కి వీ విల్ ఆస్క్ ఫర్ సమ్ కైండ్ ఆఫ్ హెల్ప్. అప్పుడు అంత బాధలో ఉన్నప్పుడు వీ ఆల్సో ఎక్స్పెక్ట్ ఆర్ వీ వుడ్ వాంట్ సమ్ కైండ్ ఆఫ్ రెస్పెక్ట్ ఇన్ ద ట్రీట్మెంట్. ఈ రెస్పెక్ట్ ఇన్ ద ట్రీట్మెంట్ కొన్ని చోటలో వీఆర్ మిస్సింగ్. So I request the entire government hospital, the entire setup to basically keep this in mind. Ki not only is it our duty to treat, but also there must be some respect in treating our patients. Somewhere, because of some small incidents in the state, we get a very bad name. So therefore, I request everybody to not only concentrate on, of course, the quality aspects of the medical part, but also the non-medical part, which is equally important. Okay, relationship between a doctor and a patient, a relationship between a nurse and a doctor is also equally important. So therefore, these were the two things that I feel that we should focus on. This hospital infection prevention and control program is extremely important. Memu kuda prati chotalo we will continue it as per Honorable Minister's instructions. And I request online and offline, whoever is attending, to kindly, of course, refresh your knowledge in whatever you already know. So, ee avakasham ichina andariki na dhanyavadalu. Thank you.
Thank you, madam, for your enlightening words about the program. Now I request our Honorable Minister for Health and Family Welfare, Sri T. Harish Rao Garu, sir, to give his valuable words.
ప్రజెంటేషన్ ఉందా అమ్మాయి ఏమన్నా పెట్టుకున్నారా ప్రజెంటేషను? నిమ్స్ ఇన్ఛార్జ్ డైరెక్టర్ గౌరవనీయులు రామ్మూర్తి గారు, కమిషనర్ ఫ్యామిలీ వెల్ఫేర్ శ్వేతా మహంతి గారు, డైరెక్టర్ మెడికల్ ఎడ్యుకేషన్ రమేష్ రెడ్డి గారు, కమిషనర్ వైద్య విధాన పరిషత్ డాక్టర్ అజయ్ గారు, మన ముఖ్యమంత్రి గారి కార్యాలయంలో ఓఎస్డీగా ఉన్నటువంటి డాక్టర్ గంగాధర్ గారు, మన నిమ్స్ సూపరింటెండెంట్ సత్యనారాయణ గారు, అండ్ 30 టీచింగ్ ఆసుపత్రుల నుంచి వచ్చినటువంటి డాక్టర్లు, స్టాఫ్ నర్సులు, మీడియా మిత్రులు అందరికీ నమస్కారం. 30 మంది ఉన్నారమ్మా? 30 టీచింగ్ హాస్పిటల్స్ అందరు వచ్చారా? సో 30 మంది స్టాఫ్ నర్సులు ఒకసారి చేతులు ఎత్తండి. ఐ వాంట్ టు కౌంట్ చేయమ్మా గంగాధర్ ఫాస్ట్గా. 30 ఉన్నారా? If anybody is absent, we'll call them. 30. Perfect. Very good. So 30 doctors, if you don't mind, please. Count, Gangadhar. Unnara? Very good. Full marks to Ramesh Reddy. So గతంలో ఎప్పుడూ లేని విధంగా ఒక రీఓరియంటేషన్, కోర్స్ మనం చేయడం లేదని కాదు, మనకు తెలియదని కాదు, కానీ మన రాష్ట్రంలో నిమ్స్లో ఇన్ఫెక్షన్ కంట్రోల్ అనేది చాలా బాగా చేస్తున్నారు. బెస్ట్ ప్రాక్టీస్ మన నిమ్స్లో ఉంది కనుక రాష్ట్రంలోని అన్ని ఆసుపత్రుల్లో ఉండేటువంటి సిబ్బందికి ఈ హాస్పిటల్ ఇన్ఫెక్షన్ ప్రివెన్షన్ అండ్ కంట్రోల్ సిస్టమ్ మీద, మేనేజ్మెంట్ మీద ఒక ప్రోగ్రాము, రీఓరియంటేషన్ ప్రోగ్రామ్ ఈరోజు మనం ప్రారంభించుకుంటా ఉన్నాం. ఇది 2 రోజుల పాటు ఈ శిక్షణ ఉంటుంది. మీ అందరికీ కూడా ఇక్కడే IHFWలో మీకు అకామిడేషన్ కూడా ఏర్పాటు చేయడం జరిగింది. మేము మీ అందరితో కూడా రిక్వెస్ట్ చేసేది ఏంటంటే కొంచెం సీరియస్గా మీరు ఈ బెస్ట్ ప్రాక్టీసెస్ను మీరు నేర్చుకోగలిగితే, అలవాటు చేసుకోగలిగితే మనం చాలా వరకు ఇన్ఫెక్షన్ను నిరోధించుకునేటువంటి అవకాశం ఉంటుంది. ప్రపంచవ్యాప్తంగా కూడా చూసినప్పుడు అభివృద్ధి చెందిన దేశాల్లో ఇన్ఫెక్షన్ రేటు ఈజ్ అరౌండ్ 7%. అండ్ ఇప్పుడు అభివృద్ధి చెందుతున్న దేశాల్లో చూస్తే ఇన్ఫెక్షన్ ఆల్మోస్ట్ 10% ఉంది. సో డెవలప్డ్ కంట్రీస్లో 7, డెవలప్మెంట్ అవుతున్నటువంటి దేశాల్లో 10% ఇన్ఫెక్షన్ అనేది ఉంది. సో మన రాష్ట్రంలో కూడా ఈ ఇన్ఫెక్షన్ను మినిమైజ్ చేయడానికి, ఇంకా బాగా తగ్గించడానికి బెస్ట్ ప్రాక్టీసెస్ను అడాప్ట్ చేద్దామని చెప్పి మనం కొన్ని నిర్ణయాలు తీసుకోవడం జరిగింది. ఇందులో 3 టైర్ సిస్టమ్ అని మన డిపార్ట్మెంట్ అంతా కూడా కూర్చొని ఒక 3 టైర్ సిస్టమ్ను మనం ఏర్పాటు చేసుకోవడం జరిగింది. ఏంటి ఆ 3 టైర్ సిస్టమ్ అంటే, మొట్టమొదటిది ప్రతి హాస్పిటల్లో కూడా ఈ ఇన్ఫెక్షన్ కంట్రోల్ కమిటీ ఒకటి ఫామ్ చేయమని చెప్పాం. ఎవరుంటారు ఈ కమిటీలో? ఒకటి సూపరింటెండెంట్ గారు అండ్ మైక్రోబయాలజీ హెచ్ఓడి గారు అండ్ అదర్ హెచ్ఓడిస్, అదేవిధంగా నర్సింగ్ సూపరింటెండెంట్. వీళ్ళందరూ కూడా ప్రతి సోమవారం కూర్చొని మీ థియేటర్లో మీ దగ్గర ఇన్ఫెక్షన్ ఎట్లా ఉంది, కరెక్ట్గా మేనేజ్ అవుతుందా లేదా అనేటువంటిది ప్రతి సోమవారము ఈ రివ్యూ మీటింగ్ ఒకటి చేసుకొని ఇన్ఫెక్షన్ కంట్రోల్ను మీరు అసెస్ చేయాలి అని ప్రతి మండే మీటింగ్ పెట్టుకునే విధంగా హాస్పిటల్ స్థాయి కమిటీ ఒకటి మనం ఏర్పాటు చేసుకోవడం జరిగింది. ఇక రెండవది వచ్చేసి థియేటర్ వైజ్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్, ఇన్ఫెక్షన్ కంట్రోల్ స్టాఫ్ నర్స్, వీరిద్దరిని కూడా స్పెసిఫిక్గా మనం పెట్టుకుంటున్నాం. ఎవరు ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్ అంటే మోస్ట్లీ ఫ్రమ్ మైక్రోబయాలజీ డిపార్ట్మెంట్ ఆర్ అనస్థీషియా డిపార్ట్మెంట్ ఉంటారు. అండ్ ఒక స్టాఫ్ నర్స్ను డెడికేటెడ్గా మనము ఇన్ఫెక్షన్ కంట్రోల్ స్టాఫ్ నర్స్గా ఆ ఆసుపత్రిలో ఒకరిని పెట్టి వారిద్దరిని మనము ఈరోజు ట్రైన్ చేస్తూ ఉన్నాం. ఎవరైతే ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్గా ఒక డాక్టర్ని పెట్టుకున్నామో ఆ డాక్టర్ గారిని, ఇన్ఫెక్షన్ కంట్రోల్ స్టాఫ్ నర్స్గా ఎవరినైతే మనం హాస్పిటల్లో నియమించుకున్నామో ఆ స్టాఫ్ నర్స్ గారికి ఇద్దరికి కలిపి ఈరోజు ఈ 2 రోజుల శిక్షణా కార్యక్రమాన్ని హైదరాబాద్లో నిమ్స్లో మనం ప్రారంభించుకుంటున్నాం. సో మీరు ఎంత ఎఫెక్టివ్గా నేర్చుకోగలిగితే మీ హాస్పిటల్ అంత భద్రంగా ఉంటుంది, అంత ఎఫెక్టివ్గా మీ హాస్పిటల్లో ఈ ఇన్ఫెక్షన్ను మనం కంట్రోల్ చేసుకోవచ్చు. ఎంత బాగా చేసినా 7 to 10% ఇన్ఫెక్షన్ ఉంది అనే మనకు రిపోర్ట్స్ చెప్తున్నాయి. వరల్డ్ వైడ్ WHO చెప్తున్నది ఇట్ ఈస్ అరౌండ్ 7 to 10%. సో హౌ బెస్ట్ వీ కెన్ మినిమైజ్, హౌ బెస్ట్ వీ కెన్ ప్రివెంట్ అనేదే చాలా చాలా ముఖ్యమైనటువంటిది. ముఖ్యంగా ఇది ఏమవుతుందంటే దీర్ఘకాలిక రోగాలతో ఉన్నటువంటి వాళ్ళకు ఇన్ఫెక్షన్ ఎక్కువ ప్రోన్ ఉంటారు, వాళ్ళు ఇన్ఫెక్షన్ ప్రోన్ ఉంటారు. కిడ్నీతో కానీ, లివర్ ప్రాబ్లంతో కానీ, ఇంకా డయాలసిస్ పేషెంట్స్ కానీ, ఇంకా హార్ట్కి సంబంధించి కానీ, లంగ్స్ సంబంధించినటువంటి వాళ్ళు, క్యాన్సర్ సంబంధించినటువంటి వాళ్ళు కొంచెం ఎక్కువగా ఈ ఇన్ఫెక్షన్ బారిన పడేటువంటి అవకాశం ఉంటుంది. ముఖ్యంగా మీరందరూ టీచింగ్ హాస్పిటల్స్ నుంచి వచ్చారు. సో అన్ని టీచింగ్ హాస్పిటల్స్ ఈ రాష్ట్రంలో మనకు 30 టీచింగ్ హాస్పిటల్స్ ఉన్నాయి. సో 30 టీచింగ్ హాస్పిటల్స్కి ఈరోజు మనం ట్రైనింగ్ ఇస్తూ ఉన్నాం. సో మా ఐడియా ఏంటంటే ముందు టీచింగ్ హాస్పిటల్స్, దెన్ ఫాలోడ్ బై వైద్య విధాన పరిషత్, దెన్ ఫాలోడ్ బై డైరెక్టర్ ఆఫ్ హెల్త్, అందరికీ ఇద్దామని ట్రైనింగ్. ముందు టీచింగ్ హాస్పిటల్స్తో ఈరోజు స్టార్ట్ చేస్తున్నాం. 2 days మీద అయిపోయిన తర్వాత అజయ్ గారికి నంబర్ ఆఫ్ హాస్పిటల్స్ ఎక్కువ ఉంటాయి కనుక వైద్య విధాన పరిషత్లో అవసరమైతే 2 phases ఆ 3 phases పెట్టి వైద్య విధాన పరిషత్ కంప్లీట్ చేసుకుంటాం. తర్వాత డైరెక్టర్ ఆఫ్ హెల్త్, మన ప్రైమరీ హెల్త్ సెంటర్స్ ఏదైతే ఉన్నాయో చాలా చోట్ల అక్కడ కూడా డెలివరీస్ జరుగుతూ ఉన్నాయి, స్మాల్ సర్జరీస్ కూడా జరుగుతూ ఉన్నాయి. సో ఆ ప్రైమరీ హెల్త్ సెంటర్స్ కూడా సేమ్ కైండ్ ఆఫ్ ప్రోగ్రామ్, రీఓరియంటేషన్ ప్రోగ్రామ్ను 3 భాగాలుగా చేసుకుంటున్నాం. టీచింగ్ హాస్పిటల్స్, వైద్య విధాన పరిషత్, దెన్ ఫాలోడ్ బై ప్రైమరీ హెల్త్ సెంటర్స్. ఇది 3 దశలుగా జరుగుతుంది. ఇలా మొదటి దశ మనం ప్రారంభం చేసుకుంటా ఉన్నాం. నేను ఇందాక రమేష్ రెడ్డి గారితో, శ్వేత గారితో కూడా అదే అంటున్నా. బై ఛాన్స్ ఎవరైనా మిస్ అయితే, అందుకే మీరు ఎంతమంది వచ్చారని నేను చెక్ చేయమన్నా. ఏదైనా ఒక హాస్పిటల్ మిస్ అయితే కూడా అందరికి కలిపి మళ్ళీ చివరి రోజు పెట్టమన్నా. ప్రతి హాస్పిటల్ వాళ్ళు ట్రైనింగ్ వచ్చేదాకా ఈ ట్రైనింగ్ జరుగుతూనే ఉంటుంది. నో ఆన్లైన్ బిజినెస్, ఇట్స్ ఓన్లీ ఫిజికల్ ట్రైనింగ్. ఖచ్చితంగా అందరు రావాల్సిందే. మిస్ అయిన వాళ్ళు ఉంటే మా గంగాధర్ అటెండెన్స్ తీసుకోవాలి, నోట్ చేయాలి గంగాధర్. మిస్ అయిన వాళ్ళందరి కోసం మళ్ళీ ఒకరోజు 2 రోజులు ట్రైనింగ్ పెడతాం. లాస్ట్ బ్యాచ్ వాళ్ళు వచ్చినాకనే ఇడిచిపెట్టు, అప్పటిదాకా మాత్రం లేనే లేదు. సో ఎవ్రీ హాస్పిటల్ హ్యాస్ టు అండర్గో దిస్ ట్రైనింగ్. సో అంటే మనం మనం అల్టిమేట్లీ మెడికల్ ఫీల్డ్ అనేది ఎప్పుడూ మనం నేర్చుకుంటూ ఉండాలి. ఇట్స్ అన్ అప్డేషన్ ఆల్వేస్. కొత్త రీసెర్చ్ జరుగుతూ ఉంటుంది, కొత్త ప్రొసీజర్స్ వస్తూ ఉంటాయి, కొత్త ఎక్విప్మెంట్స్ వస్తూ ఉంటాయి, బెస్ట్ టెక్నాలజీస్ వస్తూ ఉంటాయి. ఇట్స్ ఎ కంటిన్యూయస్ లెర్నింగ్. మీరు ఎట్లాగూ చేస్తూనే ఉంటారు. సో ద బెస్ట్ ప్రాక్టీసెస్ను మనం నేర్చుకోవడం ద్వారా ప్రజలకు మనము మంచి వైద్యాన్ని అందించేటువంటి వెసులుబాటు కలుగుతుంది. సో దాంట్లో భాగంగానే తప్ప ఇది నథింగ్, ఇది ఏదో మనం చేయకూడదో లేదా కష్టమైంది దాని కానే కాదు. మనం వీఆర్ అప్డేటింగ్ అవర్ స్కిల్స్, అప్డేటింగ్ ద న్యూ టెక్నాలజీస్, న్యూ ట్రెండ్స్. అది మనం మన ఆసుపత్రిలో మన ప్రజలకు అందించేటువంటి ఒక ప్రయత్నం మనం చేస్తూ ఉన్నాం. నేను ఈ ట్రైనింగ్ కూడా నేను రమేష్ రెడ్డి గారితో, రిజ్వీ గారితో కూడా ఏం చెప్పినంటే ఇది ఎవ్రీ 2 years పెట్టమని చెప్పాం. ఫర్ సమ్ రీజన్ ఏమవుతుంది, మీలో ఒకరు ఈరోజు అసిస్టెంట్గా ఉన్నారు, రేపు అసోసియేట్ కావచ్చు, రేపు ప్రొఫెసర్గా ప్రమోషన్ రావచ్చు, లేదా మీరు ట్రాన్స్ఫర్ కావచ్చు, లేదా ఒక రిటైర్ కావచ్చు. సో మరి మళ్ళీ మీ బ్యాచ్ మారుతుంటుంది. సో ఈ రీఓరియంటేషన్ కూడా పార్ట్ ఆఫ్ కరికులంలో ఎవ్రీ 2 years ఈ ప్రోగ్రామ్ జరుగుతూనే ఉండాలి అని కూడా ఒక నిర్ణయం తీసుకున్నాం. ప్రతి 2 సంవత్సరాలకు ఒకసారి జరిగితే, ఒకవేళ మిగతా కంటిన్యూ అయినా కూడా ఇంకేదైనా అప్డేషన్ ఉంటే అప్డేట్ చేసుకుంటాం. ఒకవేళ చేంజ్ అయ్యి ఉంటే కొత్త వాళ్ళు కూడా నేర్చుకునేటువంటి అవకాశం ఉంటుంది. సో ఇది కంటిన్యూస్గా చేయాలని చెప్పి కూడా చెప్పాం. ఈరోజు మరి ఈ ప్రోగ్రామ్ అనేటువంటిది డెఫినెట్గా మన ఆసుపత్రులను మరింత బలోపేతం చేయడానికి ఇంకా ఎక్కువగా మనకు ఉపయోగపడుతుంది. ముఖ్యంగా ఇన్ఫెక్షన్ అనేది ఆపరేషన్ థియేటర్స్లో కానీ మన డెలివరీ రూమ్స్లో మీరు అక్కడ కూడా కొంత ఇన్ఫెక్షన్ అప్పుడప్పుడు మనం చూస్తూ ఉంటాం. డయాలసిస్ వార్డులు ఈ మధ్య ఆల్మోస్ట్ ఎవ్రీ టీచింగ్ హాస్పిటల్ ఈజ్ హ్యావింగ్ ఏ డయాలసిస్ సెంటర్. ఈ డయాలసిస్ పేషెంట్స్లో కూడా మనకు వాళ్ళు వాడేటువంటి వాటర్, దాన్ని ఏమంటాం, ఆర్ఓ వాటర్లో ఏదైనా చిన్నపాటి ఇన్ఫెక్షన్ ఉన్నా, ఆ పరిసరాల్లో ఏదైనా ఇన్ఫెక్షన్ ఉన్నా కూడా వాళ్ళు ఎక్కువగా ఇన్ఫెక్షన్ ప్రోన్ ఉంటారు కనుక అక్కడ కూడా మనం చాలా జాగ్రత్తగా చూసుకోవాలి. అంటే పర్టికులర్లీ ఈ లేబర్ రూమ్స్ కానీ, ఆపరేషన్ థియేటర్స్ కానీ, డయాలసిస్ సెంటర్స్లో ఎక్కువ ప్రాబబిలిటీ ఉంటుంది కనుక అక్కడ మనం చాలా జాగ్రత్తగా, మీరు ఎవరైతే ఈరోజు ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్, ఇన్ఫెక్షన్ కంట్రోల్ స్టాఫ్ నర్సులు ఇక్కడికి వచ్చారో మీరు వీటి పట్ల చాలా జాగ్రత్తగా ఉండాలి. ఆ హాస్పిటల్లో ఎక్కడైనా బై ఛాన్స్ ఏదైనా ఇన్ఫెక్షన్ వచ్చిందంటే యూ విల్ బీ ఎట్ ఫాల్ట్. యు ఆర్ ద ఆఫీసర్, యు ఆర్ ద స్టాఫ్ నర్స్, యూ నీడ్ టు టేక్ ద రెస్పాన్సిబిలిటీ. సో మీరు ఆ బాధ్యతను మీరు తీసుకోవాలి. ఇన్ ద ప్రాసెస్ ఇంకేదైనా మీకు సపోర్ట్ అవసరం ఉంటే కూడా మీకు మీ సూపరింటెండెంట్ గారిని కూడా అందుకే పెట్టినాం. ఇన్ఫెక్షన్ ఒక కమిటీ పెట్టి మీ హాస్పిటల్ సూపరింటెండెంట్ని కూడా పెట్టాం. ఈరోజు మీరు ఏ టీచింగ్ హాస్పిటల్ అన్నా చూసుకోండి, ఎక్సెప్ట్ ఐ థింక్ ఈ మెటర్నిటీ టీచింగ్ హాస్పిటల్ తప్ప అవుట్ ఆఫ్ 30 ఆల్మోస్ట్ 27-28 హాస్పిటల్స్లో ఏ హాస్పిటల్లో చూసినా మీ దగ్గర 2 కోట్ల రూపాయలకు తక్కువ డబ్బు లేదు మీ సూపరింటెండెంట్ కంట్రోల్లో. యువర్ సూపరింటెండెంట్స్ are having almost 2 crore rupees which they can spend on their own without any permission. ఆరోగ్యశ్రీ కింద, హెచ్డిఎస్ కింద చాలా డబ్బు విడుదల చేస్తూ ఉన్నాం మేము. 35% ఏదైతే మనం ఆరోగ్యశ్రీ కింద హాస్పిటల్ సూపరింటెండెంట్ కంట్రోల్లో పెట్టిన డబ్బు ఉందో, కొన్ని హాస్పిటల్స్ అయితే 5 కోట్లు 6 కోట్లు కూడా ఉన్నాయి. నేను సిద్దిపేట టీచింగ్ హాస్పిటల్ ఏదో సడన్గా విజిట్ చేస్తే 2 crores ఉన్నాయని చెప్పినాడు నాకు. 2.5 crores 2 crores ఉన్నాయని చెప్పినాడు. సో ఎంత ఆరోగ్యశ్రీ కేసెస్ చేస్తూ ఉంటే అంత డబ్బు పెరుగుతూ ఉంది. బాగా పర్ఫార్మెన్స్ పెరిగింది మన టీచింగ్ హాస్పిటల్స్లో. ఆరోగ్యశ్రీ కేసెస్ బాగా చేస్తున్నారు, నీ జాయింట్ రిప్లేస్మెంట్ చేస్తున్నారు, ఆల్ కైండ్స్ ఆఫ్ సర్జరీస్ కూడా ఈ మధ్య ఇంప్రూవ్ చేసినారు. మీకు అన్ని రకాల ఎక్విప్మెంట్ కూడా మేము ప్రొవైడ్ చేస్తూ ఉన్నాము. అండ్ సూపరింటెండెంట్స్ ఆర్ ఎట్ లిబర్టీ. వాళ్ళకి ఎక్కడ కూడా మీరు ఏదో గవర్నమెంట్ పర్మిషన్ తీసుకోండి, డిఎంఈ పర్మిషన్ తీసుకోండి అని కూడా చెప్పట్లేదు. జిల్లాలోనే మీ హాస్పిటల్ ఇంట్రెస్ట్లో, హాస్పిటల్లో మీ రివ్యూలో ఏది అవసరం ఉంటే దాన్ని మీరు ప్రొక్యూర్ చేయండి, అన్ని రకాలుగా ప్రజలకు మంచి వైద్యం ఇవ్వండి అని చెప్పినాం. అయితే ఎందుకు మీకు చెప్పే ప్రయత్నం చేస్తున్నా అంటే, బికాస్ యాజ్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్ ఏవైనా కొంత మీరు ఎక్విప్మెంట్ కానీ ఇంకేదైనా స్ట్రెంథెన్ చేసే విషయంలో ఉంటే మీరు మీ సూపరింటెండెంట్స్కి చెప్పి మీరే ఇమీడియట్గా దాన్ని అటెండ్ చేయడానికి మీకు ప్రాబిలిటీ ఉంది. అదేవిధంగా మీ ఎక్విప్మెంట్స్ కూడా ఎక్కువ కొనుక్కోమని చెప్పాం. థియేటర్లో వాడే ఎక్విప్మెంట్స్ కూడా తక్కువగా ఉంటే, షార్టేజ్ ఉన్నప్పుడు ఏమవుతుందంటే ఫాస్ట్గా మీరు దాన్ని స్టెరిలైజ్ చేయడంలో ఎక్కడన్నా చిన్న పొరపాటు జరిగినా కూడా ఇట్ ఈస్ లీడింగ్ టు ఎ బిగ్గర్ ప్రాబ్లం. అందువల్ల మీరు సఫిషియంట్ నంబర్ ఆఫ్ ఎక్విప్మెంట్ను కూడా కొని పెట్టుకోండి. మీ దగ్గరే అది చిన్న కాస్ట్, పెద్ద డబ్బు కూడా కాదు. దట్ మనీ ఈజ్ అవైలబుల్ విత్ యువర్ సూపరింటెండెంట్స్. సో ఎంత ఎక్విప్మెంట్ కావాలంటే అంత ఎక్విప్మెంట్ కూడా కొని పెట్టుకోండి మీరు. సో దట్ ఎక్కడ కూడా వీఆర్ నథింగ్ లెస్ దాన్ ఎనీ కార్పొరేట్ హాస్పిటల్. మంచి ఎక్స్పీరియన్స్డ్ డాక్టర్స్ ఉన్నారు, బెస్ట్ ఎక్విప్మెంట్ ఈ మధ్యకాలంలో క్యాథ్ ల్యాబ్లు, ఎంఆర్ఐ మిషన్లు, సిటీ స్కాన్లు, ది బెస్ట్ ఎక్విప్మెంట్ అంతా కూడా కొనడం జరుగుతూ ఉంది. కొనడమే కాదు, మనం ఈ మధ్యకాలంలో ప్రాజెక్ట్ మేనేజ్మెంట్ యూనిట్ ప్రారంభించినాం. అంటే ఎక్విప్మెంట్ మేనేజ్మెంట్ పాలసీ. ఏదైనా ఎక్విప్మెంట్ ఖరాబ్ అయితే బహుశా మీకు ట్రైనింగ్ అయి ఉంటుంది, మీ సూపరింటెండెంట్స్కి అయి ఉంటుంది ట్రైనింగు. మీరు జస్ట్ ఆన్లైన్లో క్లిక్ చేస్తే కంపెనీ వాళ్ళు వచ్చి 24 గంటల్లో దాన్ని రిపేర్ను చేయాలి, 24 గంటల్లో దాన్ని అటెండ్ చేసే టెక్నాలజీ తెచ్చాం. పాత రోజుల్లో ఏముండేది, ఎక్విప్మెంట్ ఖరాబ్ అయితే సూపరింటెండెంట్ గారు డిఎంఈకి లెటర్ రాయాలి, డిఎంఈ గారు టీఎస్ఎంఐడిసికి లెటర్ రాయాలి, బయోమెడికల్ ఇంజనీర్ రావాలి, ఆయన ఎస్టిమేట్ అయ్యాలి, అది శాంక్షన్ కావాలి, అది రిపేర్ అయ్యే వరకు పుణ్యకాలం పోతుండే, 3 నెలలు అవుతుండే. ఇప్పుడు ఇంకా అది ఇట్ ఈస్ జస్ట్ ఎ ఫోన్ కాల్ అవే. మీరు ఎక్విప్మెంట్లో ఏదైనా చిన్న రిపేర్ వస్తే లైక్ ఏ ప్రైవేట్ కార్పొరేట్ హాస్పిటల్ ఒక ఈమెయిల్ కొట్టచ్చు, లేదా ఒక ఫోన్ చేస్తే కంపెనీ వాళ్ళు వచ్చి 24 గంటల్లో దాన్ని అటెండ్ చేయాలి అని దాదాపు సంవత్సరానికి 20 కోట్ల రూపాయలు ఖర్చు పెట్టి ఎక్విప్మెంట్ మేనేజ్మెంట్ పాలసీ ఒకటి మనం అందుబాటులోకి తెచ్చాం. ఆయా కంపెనీలతోనే అంత కాస్ట్లీ ఎక్విప్మెంట్ పెట్టినప్పుడు ఎఫెక్టివ్గా దాన్ని ఉపయోగించుకోవాలి. సో దాన్ని కూడా మనం తీసుకురావడం జరిగింది. సో మీరు అట్లా బెస్ట్ ఎక్విప్మెంట్ తీసుకొస్తున్నాము. అవసరమైన థియేటర్లో అవసరమైన చిన్నపాటి ఎక్విప్మెంట్ కూడా మీరు ఎన్ని సెట్స్ అవసరం ఉంటే డిపెండింగ్ ఆన్ యువర్ వర్క్ లోడ్, డిపెండింగ్ ఆన్ ద థియేటర్, డిపెండింగ్ ఆన్ ద డిపార్ట్మెంట్, మీరు అవసరమైన అన్నీ కూడా మీ సూపరింటెండెంట్స్తో మాట్లాడి సఫిషియెంట్గా ప్రొక్యూర్ చేసి పెట్టుకోండి. ఈవెన్ మార్చురీస్ కూడా ఈ మధ్య మేము ఆధునీకరించాలని 30 కోట్ల రూపాయలు శాంక్షన్ చేసి ఫ్రీజర్స్ కానీ, మార్చురీ ఎక్విప్మెంట్ కానీ, మార్చురీలో నైట్ టైంలో కూడా పోస్ట్ మార్టం చేసే విధంగా లైటింగ్ కానీ అన్నీ కూడా స్ట్రెంథెన్ చేసే కార్యక్రమం కూడా చేస్తూ ఉన్నాం. అంటే మేము ప్రభుత్వం దృష్టికి వచ్చిన ప్రతి చిన్న విషయాన్ని కూడా మైన్యూట్గా దాన్ని అడ్రస్ చేసే ప్రయత్నం చేస్తున్నాం. ఒకరోజు శ్వేత గారు నేను పేట్లబుర్జి హాస్పిటల్ పోయినాం. పేషెంట్స్తో మేము మాట్లాడే ప్రయత్నం చేస్తే అన్నీ బాగున్నాయి, మాకు అన్ని ఫెసిలిటీస్ ఉన్నాయని చెప్పారు. బట్ ఎక్సెప్ట్ ఒక చిన్న కారణం చెప్పినారు, 1 స్కాన్ వీఆర్ గోయింగ్ అవుట్ సైడ్. ఒక స్కాన్ను టిఫా స్కాన్ పేరు మీద ప్రైవేట్లో వెళ్ళి మేము స్కాన్ చేసుకుంటున్నాము అని మా దృష్టికి వచ్చింది. ఇన్ఫ్యాక్ట్ అక్కడ జరిగింది యాక్చువల్గా ఏంటి, అందరికీ టిఫా స్కాన్ అవసరం లేదు, కానీ అది అందరూ జాగ్రత్తలో భాగంగా అందరూ వెళ్తున్నారు. 3-4 స్కాన్లు చేసినప్పుడు ఒక స్కాన్ మాత్రం టిఫాకి వెళ్తున్నారు. ఎందుకు వెళ్తున్నారు అన్నప్పుడు హై ఎండ్ అల్ట్రాసౌండ్ మిషన్ మా దగ్గర లేదు అని అక్కడున్న సూపరింటెండెంట్ మాలతి మా దృష్టికి తీసుకొచ్చింది. దెన్ ఇమీడియట్లీ నెక్స్ట్ డే మేము అందరం కూర్చున్నాం, వీ హ్యాడ్ ఎ రివ్యూ అండ్ ఇప్పుడు మేము ఒక డెసిషన్ తీసుకున్నాం. ఏంటమ్మా 45, 48 హౌ మెనీ వీఆర్ బయింగ్ 56. నెక్స్ట్ డే రివ్యూ చేసి 56 హై ఎండ్ అల్ట్రాసౌండ్ మిషన్లు కొనాలని చెప్పి ఆర్డర్ ఇచ్చేసాం. సో అవి ఎక్కడో విదేశాల నుంచి రావాలి, ఒక 45 రోజుల్లో వస్తాయన్నారు. మరి 56 మిషన్లు వస్తాయి సరే, మరి మనుషులు, మరి రేడియాలజిస్టులు కావాలి కదా. కొన్ని చోట్ల అవైలబుల్ ఉన్నారు, కొన్ని చోట్ల లేరు. దానికి కూడా ఇట్లాంటి ట్రైనింగే పెట్టినాం. బహుశా అది కూడా స్టార్ట్ అయిందో రేపు ఎల్లుండో స్టార్ట్ అయింది. ఒక 4 మిషన్లు ముందే తెప్పించి ఇప్పుడు నేషనల్ మెడికల్ కౌన్సిల్ కూడా కేంద్ర ప్రభుత్వం నుంచి కూడా గైనకాలజిస్ట్ కెన్ డూ దిస్ టీఫా స్కాన్ హై అండ్ అల్ట్రాసౌండ్ను వారు ఆపరేట్ చేయొచ్చు అని ఒక అనుమతి ఉంది మనకు. కాకపోతే ప్రొవైడెడ్ షీ హ్యాస్ టు అండర్గో ద ట్రైనింగ్. అందుకే నిన్నటి నుంచి గాంధీలో, పేట్లబుర్జ్లో, కింగ్ కోటిలో ట్రైనింగ్ కూడా స్టార్ట్ చేసినాం. ఈ హై అండ్ అల్ట్రాసౌండ్ మిషన్స్ పెట్టి అన్ని మన ఎంసీహెచ్ హాస్పిటల్స్ నుంచి, మన టీచింగ్ హాస్పిటల్స్ నుంచి ఒక గైనిక్ డాక్టర్ను మనం ట్రైన్ చేసి ఆవిడ ఇంకా ఈ టిఫా అవసరమైన వాళ్ళకు కూడా గైనకాలజిస్టే చేస్తారు. ఇంకా మీరు బయటకు పోవాల్సిన అవసరం లేదు. ఒక్క స్కాన్ కూడా ఇంకా ప్రైవేట్లో చేయకూడదు. ఒక గర్భిణీ స్త్రీ మన ఆసుపత్రికి వస్తే అన్ని రకాల పరీక్షలు, అన్ని రకాల స్కానింగ్లు, అంతేకాకుండా మనము ఆఫ్టర్ పోస్ట్ డెలివరీ వరకు కూడా పూర్తి బాధ్యత మనమే తీసుకొని మనం చేద్దామని. ఈ మధ్య ఇంకో నిర్ణయం కూడా తీసుకున్నాం. డిశ్చార్జ్ అయిన తర్వాత పేషెంట్ ఇంటికి వెళ్ళేటప్పుడు అవసరమైన మందులు కూడా మనమే ఇద్దాం. అది 1 వీకా, 10 డేసా, 3 డేసా, వాట్ ఎవర్ ద రిక్వైర్డ్ మెడిసిన్ యాజ్ ప్రిస్క్రైబ్డ్ బై ద కన్సర్న్ డాక్టర్. సో అవి కూడా మనమే ఇచ్చి పంపిద్దాం పేషెంట్కు. సఫిషియంట్ స్టాక్ మెయింటైన్ చేయండి. ఈ ఔషధి అనే ఒక ప్రోగ్రామ్ తీసుకొచ్చి 3 నెలలకు అవసరమైనటువంటి మందులను ప్రతి హాస్పిటల్లో కూడా మీరు స్టోర్లో పెట్టండి అని చెప్పాం. మీ ఫార్మసిస్టులకు ట్రైనింగ్ ఇచ్చినాం. మీరు అనుకోకండి మీకు ఒక్కరికే ట్రైనింగ్ ఇచ్చినామని. ప్రతి హాస్పిటల్లో ఉండే ఫార్మసిస్ట్ని కూడా ఇక్కడికి పిలిచి 2 డేస్ ట్రైనింగ్ ఇచ్చాం. ఆన్లైన్లో, డిజిటల్లో వాళ్ళు బాగా ట్రైన్ చేసి మీకు ఆ కంప్యూటర్లో చూపించాలి. ఒక డ్రగ్ ఒకవేళ 3 మంత్స్ స్టాక్ మీ హాస్పిటల్లో లేదంటే ఇట్ విల్ బ్లింక్ ఇన్ ఎ రెడ్ మార్క్ ఇట్ విల్ బ్లింక్. సో దట్ స్టాక్ తగ్గిందంటే మళ్ళీ ఆవిడ ఇండెంట్ పెట్టాలి, షీ షుడ్ ప్రొక్యూర్ ద రిక్వైర్డ్ డ్రగ్స్. సో అట్లా ఈ ఔషధి అనే ఒక ప్రోగ్రామ్ తీసుకొచ్చి ఆసుపత్రుల్లో అవసరమైన మందులు 3 నెలల స్టాక్ ఖచ్చితంగా మెయింటైన్ చేసే విధంగా వాళ్ళకు మొత్తం ఫార్మాసిస్టులకు టీచింగ్ హాస్పిటల్స్, వైద్య విధాన పరిషత్ యాజ్ వెల్ యాజ్ ప్రైమరీ హెల్త్ సెంటర్స్ వాళ్ళకు కూడా ట్రైనింగ్ ఇస్తూ అట్ సైడ్ స్ట్రెంథెన్ చేస్తూ ఉన్నాం. ఎక్విప్మెంట్ మేనేజ్మెంట్ పాలసీ తెచ్చి దాన్ని స్ట్రెంథెన్ చేస్తూ ఉన్నాం. పోస్ట్ మార్టం రూమ్స్ను వాటిని స్ట్రెంథెన్ చేసే ప్రయత్నం చేస్తూ ఉన్నాం. లైక్ ఇప్పుడు టిఫా స్కాన్ లాంటిది లేదు మన గవర్నమెంట్లో, పాపం ఇబ్బంది పడుతున్నారు. వెంటనే 50కి పైగా టిఫా స్కాన్ మెషిన్లు కొని వాటిని మనం ప్రొక్యూర్ చేసే ప్రయత్నం చేస్తున్నాం. సపోజ్ ఇప్పుడు ఈ ఇన్ఫెక్షన్లో 1-2 చోట్ల మనకు సమస్యలు తలెత్తినాయి, దెన్ అలర్ట్ అయిపోయి ఆ సమస్యను అక్కడికే అడ్రస్ చేయకుండా రాష్ట్రం మొత్తం కూడా మనం బలోపేతం చేసుకుందామని చెప్పి ఇవాళ అన్ని ఆసుపత్రుల్లో కూడా ఒక ఇన్ఫెక్షన్ ఆఫీసర్ను, ఇన్ఫెక్షన్ స్టాఫ్ నర్సును పెట్టి అందరికీ ట్రైనింగ్ ఇచ్చే కార్యక్రమం తెచ్చాం. ఇంకా ఇదే కాకుండా మన డాక్టర్ గారు ఇంకో సలహా ఇచ్చినారు. ప్రైవేట్ కార్పొరేట్ హాస్పిటల్స్లో ఎయిర్ శాంప్లర్స్ అని కొంత ఎక్విప్మెంట్ ఉంటుంది. ఆ ఎయిర్ శాంప్లర్ పెడితే అదే సక్ చేసి ఆ థియేటర్లో ఏమైనా ఇన్ఫెక్షన్ ఉందా లేదా అని చెప్పగలుగుతుంది. అవి కూడా ప్రొక్యూర్ చేస్తే బాగుంటుంది అని చెప్పారు. దెన్ ఇమీడియట్లీ ఐ సెడ్ వాట్ ఈస్ ద నంబర్ యూ రిక్వైర్ అంటే రమేష్ రెడ్డి గారు ఒక 50 అన్నట్టున్నారు, అజయ్ ఒక 110 ఏదో కావాలన్నారు. సో ఆ నంబర్ ఫైనల్ చేస్తే నెక్స్ట్ వీక్ కల్లా ఎయిర్ శాంప్లర్స్ కూడా ఆర్డర్ ఇచ్చేసి అన్ని థియేటర్లలో కూడా ఎయిర్ శాంప్లర్స్ మేము ప్రొక్యూర్ చేసి మీకు ఇచ్చేస్తాం. సో టెక్నాలజీ ఇద్దాము, ట్రైనింగ్ చేద్దాము, మీకు అవసరమైనటువంటి అన్ని రకాల వనరులను ఇచ్చి అద్భుతంగా పనిచేద్దామన్నదే ఆలోచన. ఇట్స్ నాట్ దట్ మీకేదో డబ్బు లేకుండా, ఎక్విప్మెంట్ లేకుండా ట్రైనింగ్ ఇవ్వడమే కాదు. డబ్బు మీ చేతుల్లో పెడతాం, ఎక్విప్మెంట్ అవసరమైంది మీకు ప్రొక్యూర్ చేస్తాం, టెక్నాలజీ మీద మీకు ట్రైనింగ్ కూడా ఇస్తాం. ఇప్పుడు మనకి వీఆర్ నథింగ్ షార్ట్ ఆఫ్ ఎనీ కార్పొరేట్ హాస్పిటల్. ఇవాళ ఏ కార్పొరేట్ హాస్పిటల్లో ఏ ఫెసిలిటీస్ అయితే ఉన్నాయో అవి స్లోగా మనం అన్నీ పొందుపరుచుకుంటున్నాం. డైట్లో మనం ఇంప్రూవ్ చేసుకున్నాం. మేము డైట్ ఇంతకుముందు 40 రూపీస్ ఉంటే వీ మేడ్ ఇట్ డబుల్, 80 రూపీస్ డైట్ చేసినాం. శానిటేషన్ కాంట్రాక్ట్స్ని కూడా ఆల్మోస్ట్ 50% ఎన్హాన్స్మెంట్ ఇచ్చాం. బెటర్ శాలరీ, మోర్ నెంబర్ ఆఫ్ వర్కర్స్, లెట్ us ఎన్ష్యూర్ ద బెటర్ క్వాలిటీ. సో సంఖ్య పెంచినాము, జీతం పెంచినాం, క్వాలిటీ పెంచండి అని చెప్తున్నాం. సో దాన్ని కూడా మీరు డ్రైవ్ చేయగలిగితే శానిటేషన్ ఇంప్రూవ్ చేసి, డైట్ ఇంప్రూవ్ చేసి, మెడిసిన్ ప్రొవైడ్ చేసి, ఎక్విప్మెంట్ ప్రొవైడ్ చేసి, ఎక్విప్మెంట్ మేనేజ్మెంట్ పాలసీ తీసుకొచ్చి, ఇన్ఫెక్షన్ కంట్రోల్ పెట్టి స్టాఫ్ను కూడా ఇచ్చేసే కార్యక్రమం కూడా చేస్తున్నాం. ఫర్ ఎగ్జాంపుల్ ఇప్పుడు ప్రైమరీ హెల్త్ సెంటర్స్లో డాక్టర్స్ లేరంటే ఒక 1000 మంది డాక్టర్లను ఐ థింక్ బై నెక్స్ట్ 10 days ఒక 1000 మందిని పర్మనెంట్గా పిహెచ్సిలో మేము డాక్టర్స్ను రిక్రూట్మెంట్ ఆర్డర్స్ ఇవ్వబోతా ఉన్నాం. మీ టీచింగ్ హాస్పిటల్స్ లైక్ ఇప్పుడు మన 30 టీచింగ్ హాస్పిటల్స్లో రాష్ట్రంలో దాదాపు 1140 అసిస్టెంట్ ప్రొఫెసర్లు ఖాళీగా ఉన్నాయని మేము ఒక లెక్కకు తీసుకున్నాం. నిన్ననే క్లియర్ కూడా చేసినాం. ఈ 1140 అసిస్టెంట్ ప్రొఫెసర్ పోస్టులకు వచ్చే 2 రోజుల్లో నోటిఫికేషన్ ఇస్తాం. ఇన్ నెక్స్ట్ 2 days వీఆర్ గోయింగ్ టు గివ్ ద నోటిఫికేషన్. ఇవి కూడా ఒక 2 నెలల్లో ఐ థింక్ 2 to 3 monthsలో ఈ 1140 అసిస్టెంట్ ప్రొఫెసర్ పోస్టులను కూడా ఫిలప్ చేసి మీ దగ్గర ఖాళీలు లేకుండా కూడా పూర్తి స్థాయిలో నింపేస్తాం. సో మీకు ఎనఫ్ మ్యాన్ పవర్ ఆల్సో వీఆర్ గివింగ్. ఎవ్రీథింగ్ వీ వాంట్ టు గివ్, వీ వాంట్ టు సపోర్ట్. బట్ ఫైనల్గా మాకు కావాల్సింది అత్యుత్తమ సేవలు. అంటే ఆ సేవలకు కొలమానం పబ్లిక్ సాటిస్ఫాక్షన్. నా సాటిస్ఫాక్షన్ మీ సాటిస్ఫాక్షన్ కాదు, ఆసుపత్రికి వచ్చే పేషెంట్ సాటిస్ఫాక్షన్ ఈజ్ ఇంపార్టెంట్. సో అది మనకు చాలా ముఖ్యమైనది. ఎండ్ ఆఫ్ ద డే ఇవన్నీ ప్రొవైడ్ చేసిన తర్వాత కూడా మనకు కావాల్సింది ఏముంటుంది? మన రిలేషన్షిప్, పేషెంట్ డాక్టర్ రిలేషన్షిప్, పేషెంట్ స్టాఫ్ నర్స్ రిలేషన్షిప్ ఈజ్ వెరీ ఇంపార్టెంట్. ఇఫ్ యూ గో టు ఎనీ కార్పొరేట్ హాస్పిటల్ వాళ్ళు చాలా పలకరింపు, కొంత ఆత్మీయంగా ఉంటుంది. ఎంత స్ట్రెస్లో ఉన్న డాక్టర్ కానీ స్టాఫ్ నర్స్ కానీ కొంత ఆత్మీయమైన పలకరింపు, ప్రేమపూర్వకంగా మాట్లాడడము, హ్యాండ్లింగ్ విత్ పేషెంట్ ఈస్ వెరీ వెరీ ఇంపార్టెంట్. ఐ థింక్ మీరు ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్సు, ఇన్ఫెక్షన్ కంట్రోల్ స్టాఫ్ నర్సే కాదు, కొంచెం మీరు ఈ హాస్పిటల్లో మేనేజ్మెంట్లో కూడా కొంత మార్పు రావాలి. అఫ్ కోర్స్ వీ హ్యావ్ అవర్ ఓన్ ప్రాబ్లమ్స్. వీఆర్ నాట్ లైక్ కార్పొరేట్ హాస్పిటల్స్. కార్పొరేట్ హాస్పిటల్లోనేమో హైలీ ఎడ్యుకేటెడో, డబ్బున్న వాళ్ళు, హై క్వాలిటీ ఆఫ్ లైఫ్, లివింగ్ స్టాండర్డ్స్ ఉన్నటువంటి వాళ్ళు వస్తారు కనుక దేర్ ఇట్ ఈస్ లిటిల్ ఈజీ. మన దగ్గరికి వచ్చేసరికి చాలా పేదవాళ్ళు, కొంత చదువుకోనటువంటి వాళ్ళు, అట్టడుగు వర్గాల ప్రజలు వస్తున్నప్పుడు కొంత మనకు డిఫికల్టీ ఉంటుంది. ఇట్స్ నాట్ దట్ ఈజీ. మీరు అద్భుతంగా చేయగలుగుతారు కార్పొరేట్ హాస్పిటల్కి పోగలితే. కానీ ఇక్కడ మన దగ్గరికి వచ్చే పేషెంట్ వేరు, వాళ్ళ లైఫ్ స్టైల్స్ వేరు, వాళ్ళ లివింగ్ స్టాండర్డ్స్ వేరు. వీ హ్యావ్ అవర్ ఓన్ ప్రాబ్లమ్స్, బట్ స్టిల్ వీ హ్యావ్ టు ఓవర్కమ్. దానిపై మనం ఓవర్కమ్ కావాలి, ఎడ్యుకేట్ చేయాలి. మరి అటువంటి ప్రజలకు సేవ చేయడంలోనే అద్భుతమైనటువంటి సంతృప్తి, ఒక ఆనందం కూడా మనకు దొరుకుతూ ఉంటుంది. సో ఆ దిశగా కూడా మనం ప్రయత్నం చేయాలి. ప్రభుత్వంగా మేము ఒకటొకటిగా చేస్తూ వస్తున్నాం. బట్ మీ నుంచి కూడా మేము ఆశించేది చాలా, మనం పేషెంట్స్తోని ఒక మంచి ఎన్విరాన్మెంట్, హోమ్లీ ఎన్విరాన్మెంట్ ఇవ్వగలగాలి. మన పలకరింపు అనేది మన దాంట్లో కూడా, ప్రతి సమాజంలో కూడా దెర్ విల్ బి గుడ్ అండ్ బ్యాడ్. కానీ దురదృష్టం ఏంటంటే సమాజంలో ఆ 99% గుడ్ తీసుకోదు, కానీ ఆ 1% బ్యాడ్నే చాలా పెద్ద ఎత్తున ప్రచారం చేస్తూ ఉంటారు. ఇన్ఫ్యాక్ట్ మన దగ్గర ఉండే పేషెంట్స్, మన ఇన్ పేషెంట్స్ ఎంత, మన డైలీ అసలు అవుట్ పేషెంట్ ఎంత, మనం చూసినప్పుడు ల్యాక్స్ ఆఫ్ పీపుల్, విల్ బి హ్యాండ్లింగ్ విత్ ల్యాక్స్ ఆఫ్ పీపుల్. కానీ ఆ లక్షల మందిలో కొన్ని 98-97% బాగా ఇంటికి వెళ్తూ ఉంటారు. ఆ 1-2%లోనే మనకు కొంచెం ఇబ్బంది ఉంటుంది. దాన్ని ఇంకెట్లా మినిమైజ్ చేయగలుగుతాం. ఇన్ఫ్యాక్ట్ మొన్నేదో నేను రివ్యూ చేస్తూ ఉంటే మదర్ మోర్టాలిటీ రేటు, ఇన్ఫాంట్ మోర్టాలిటీ రేట్ డ్రాస్టిక్గా తగ్గింది. ఒకప్పుడు అసలు లెక్కపత్రం ఉండేది కాదు. ఒకప్పుడు ఎక్కడో ఉండేది తెలంగాణ. కానీ మనం ఒక 400-500 crores ఖర్చు పెట్టి ఎంసీహెచ్ హాస్పిటల్స్ తేవడము, లేబర్ రూమ్స్ను స్ట్రెంథెన్ చేయడము, డాక్టర్స్ రిక్రూట్మెంట్ చేయడము, కేసీఆర్ కిట్ తీసుకురావడము. ఇన్ ఫ్యూచర్ ఆఫ్ కోర్స్ వీఆర్ బ్రింగింగ్ న్యూట్రిషన్ కిట్ ఆల్సో. అట్లా బాగా స్ట్రెంథెన్ చేసిన తర్వాత ఈవెన్ వీ హ్యావ్ బైపాస్డ్ తమిళనాడు స్టేట్. తమిళనాడును కూడా బైపాస్ చేసి ఇండియాలోనే 2వ స్థానంలో ఉన్నాం మనం. మదర్ మోర్టాలిటీ రేట్లో వీఆర్ ఇన్ నెంబర్ 2. ఈ మధ్య కాలంలో ఇంకా ఇంప్రూవ్ అయినాం. ఈ ఇయర్ నేను ఎప్పుడో మేము స్టాటిస్టిక్స్ చూస్తూ ఉంటే లాస్ట్ 6 monthsలో పోయిన సంవత్సరం కంటే చాలా తగ్గించగలిగినాం ఈసారి. అంటే బర్త్ ప్లానింగ్ చేస్తున్నారు. బర్త్ ప్లానింగ్ చేసి ఎవరైనా కొంచెం క్రిటికల్గా ఉంటే వీఆర్ సెండింగ్ దెమ్ టు ఏ బెటర్ హాస్పిటల్, టెర్షరీ కేర్ పంపుతున్నాం, టీచింగ్ హాస్పిటల్ పంపుతున్నాం. నంబర్ ఆఫ్ టీచింగ్ హాస్పిటల్స్ కూడా బాగా పెరిగినాయి. నంబర్ ఆఫ్ డాక్టర్స్ కూడా బాగా పెరిగినారు. లైక్ ఎ టౌన్ లైక్ ఎ జగిత్యాల్, మంచిర్యాల్, గోదావరి ఖని, సూర్యాపేట, నల్లగొండ, కొత్తగూడెం, అక్కడ కూడా మనకి ఇలా ప్రొఫెసర్స్ ఉన్నారు. గైనిక్ డిపార్ట్మెంట్లో ప్రొఫెసర్స్, అసోసియేట్ ప్రొఫెసర్స్ రావడం వల్ల బాగా మనం స్ట్రెంథెన్ చేసుకోగలిగినాం. అవైలబిలిటీ కూడా పెరిగింది. ఈ మధ్యకాలంలో మనం ట్రైనింగ్స్ కూడా ఇచ్చాము స్టాఫ్ నర్సెస్కు. వాట్ వీ కాల్ దట్, మన స్టాఫ్ నర్సెస్ స్పెషలైజ్డ్ ట్రైనింగ్ కోర్స్ కూడా స్టార్ట్ చేశాం. మిడ్వైఫరీ కోర్స్ కూడా స్టార్ట్ చేసి మిడ్వైఫరీ ద్వారా చాలా ఫ్రెండ్లీ ఎన్విరాన్మెంట్ తీసుకొస్తున్నాం. ఇప్పుడు ఈ సెప్టెంబర్లో కూడా ఇంకొక 140 మిడ్వైఫరీస్ ఆర్ కమింగ్ అవుట్ ఎండ్ ఆఫ్ దిస్ మంత్. ఇంకో 140 మంది సంవత్సరంన్నర పాటు ట్రైనింగ్ పూర్తి చేసుకొని ఇంకో 140 మంది బయటకు రాబోతూ ఉన్నారు. వాళ్ళందరినీ కూడా ఎక్కడెక్కడైతే లోడ్ ఎక్కువ ఉందో అక్కడ పోస్ట్ చేయడము, ఎక్కడైతే గైనిక్ డాక్టర్ షార్టేజ్ ఉందో అక్కడ వాళ్ళని కూడా పోస్టింగ్ ఇచ్చి మిడ్వైఫరీ దాన్ని కూడా ఎక్కడో యూరోపియన్ కంట్రీస్లో ఉండేటువంటి దాన్ని, అడ్వాన్స్డ్ డెవలప్డ్ కంట్రీస్లో ఉండేటువంటి మిడ్వైఫరీ సిస్టమ్ను ఇండియాలోనే ఫస్ట్ టైం తీసుకొచ్చిన రాష్ట్రం తెలంగాణ రాష్ట్రం. గవర్నమెంట్ సెక్టార్లో తీసుకొచ్చి అద్భుతంగా సేవలు, మెరుగైనటువంటి సేవలు అందిస్తున్న రాష్ట్రాల్లో మన తెలంగాణ రాష్ట్రం. లైక్ అట్లా ద బెస్ట్ ప్రాక్టీసెస్ వేర్ ఎవర్ వి సీ, ఎక్కడ ఏదైనా చదివినా ఒక రాష్ట్రంలో బాగా జరుగుతుందన్న స్లోగా మన ప్రజలకు దాన్ని అందించడానికి అడాప్ట్ చేసుకొని చక్కగా మనం ముందుకు పోతూ ఉన్నాం. సో మీకు కూడా యూఆర్ ఆల్ ఇన్ టీచింగ్ ఫీల్డ్. ఇవాళ మంచి ప్రమోషన్స్ వస్తున్నాయి. గౌరవ ముఖ్యమంత్రి గారు జిల్లాకు ఒక మెడికల్ కాలేజ్ పెడితే 7 ఏళ్ళకి 8 ఏళ్ళకి ప్రొఫెసర్లు అయిపోతున్నారు మీరు కూడా. ఒకప్పుడు ఇంకా రిటైర్ అయ్యే ముందు ఏదన్నా ప్రమోషన్ ఇవ్వండి అని మా రమేష్ రెడ్డి గారిని అడుగుతున్నాం, ఇంకెవరిని అడిగితే అవుట్ ఆఫ్ టర్న్ ప్రమోషన్ ఇచ్చి లైఫ్లో రిటైర్ అయ్యే ముందు ప్రొఫెసర్ రిటైర్డ్ అని ఉండాలి అని కూడా అడిగిన సందర్భాలు ఉన్నాయి. టిల్ ద రిటైర్మెంట్ వాళ్ళకి అసలు ప్రొఫెసర్గా ప్రమోషనే వచ్చేది కాదు వాళ్ళ సర్వీస్లో. కానీ ఈరోజు 7 ఏళ్ళకి 8 ఏళ్ళకి ఒక్కొక్కరు ప్రొఫెసర్లు అయిపోతున్నారు. వాళ్ళు ఊహించిన దానికంటే వేగంగా ఇండియాలో ఏ రాష్ట్రంలో రావడం లేదు. అసిస్టెంట్స్ ఆర్ బికమింగ్ అసోసియేట్స్ ఆర్ బికమింగ్ ప్రొఫెసర్స్ అండ్ ప్రిన్సిపల్స్, సూపరింటెండెంట్స్. ఫాస్ట్గా ప్రమోషన్స్ వస్తున్నాయి. ఆపర్చునిటీస్ కూడా బాగా పెరిగినాయి. అంటే మనకు కూడా ఒక సాటిస్ఫాక్షన్ ఉంటుంది లైఫ్లో. ఏదో కొంత మనం గ్రోత్ ఉన్నప్పుడు న్యాచురల్గా మనలో ఒక పాజిటివ్ ఎనర్జీ డెవలప్ అవుతుంది. ఆ పాజిటివ్ ఎనర్జీ అనేది అల్టిమేట్గా బెటర్ ట్రీట్మెంట్ కోసం, బెటర్ మేనేజ్మెంట్ కోసం అది ఉపయోగపడాలి, ప్రజలకు ఉపయోగపడాలి. మనం ఎంతసేపు ఒకే పోస్ట్లో మొనాటనీగా పనిచేస్తుంటే ఎక్కడో మనకేదో మొనాటనీ వచ్చి ఇంకా రోజు అదేనా అన్నట్టు అవుతుంది. బట్ యు ఆర్ గెట్టింగ్ క్విక్ ప్రమోషన్స్, మీకు ఎలివేషన్స్ వస్తుంది. అందులో వచ్చే పాజిటివ్ ఎనర్జీని ఆసుపత్రి కోసం, ఆసుపత్రికి వచ్చే పేషెంట్స్ కోసం, ప్రజల కోసం మీరు ఉపయోగించగలిగితే అంతకు మించిన మాకు సంతోషం ఏం లేదు. సో ఇంకా కూడా అన్ని డిపార్ట్మెంట్స్ని కూడా స్ట్రెంథెన్ చేయండి. మేము కూడా ఏం చేస్తున్నామంటే ఇప్పుడు ప్రతి వ్యవస్థలో ఉన్నట్టు మన దగ్గర చాలా మంచి వాళ్ళు ఉన్నారు, డెడికేటెడ్గా పనిచేసే వాళ్ళు ఉన్నారు, అసలు చేయని వాళ్ళు కూడా కొంతమంది ఉన్నారు. మరి ఎట్లా దీన్ని మానిటర్ చేయాలి? అందరిని ఒక ఘాటన కడితే ఎట్లా? దెర్ ఆర్ గుడ్ పీపుల్, దెర్ ఆర్ బ్యాడ్ పీపుల్. అందుకే ఈ మధ్య ఒక డిజిటల్ ప్లాట్ఫామ్ ఏమన్నాను, డాక్టర్ వైస్ ఒక ప్రొఫెసర్ గారు, ఒక అసోసియేట్ ప్రొఫెసర్ గారు, ఒక అసిస్టెంట్ ప్రొఫెసర్ గారు ఎంత ఓపీ చూశారు, ఎన్ని అవర్స్ వారు డ్యూటీలో ఉన్నారు, ఎన్ని సర్జరీస్ చేశారు, ప్రొసీజర్స్ చేశారు అని వాళ్ళ పర్ఫార్మెన్స్ని అదే మానిటర్ చేస్తుంటుంది. ఇంకా అప్పుడు కూడా ఈజీ అవుతుంది. మనకేమవుతుందంటే ఒక డిపార్ట్మెంట్లో కొంతమంది బాగా పనిచేసే వాళ్ళు ఉన్నారు, ఒకరిద్దరు అసలే పని చేయట్లేదు. వాళ్ళ వల్ల ఏమవుతుంది, పని చేసేటోళ్ళు కూడా డిమోటివేట్ అవుతున్నారు. అదే వాళ్ళు పని చేయకుండా వాళ్ళకి ప్రమోషన్ వస్తుంది, పని చేయకుండా వాళ్ళకి జీతం అంతే రావట్టే, మరి నేను ఎందుకు పని చేయాలనే అభిప్రాయం కూడా వస్తున్నది కొంతమందికి. అది రావద్దంటే ఎవ్రీవన్ హ్యాస్ టు వర్క్. అది వర్క్ అంటే మన బాధ్యత, అది మన ఉద్యోగ ధర్మం, మన వృత్తి ధర్మం. అది వాట్ వీఆర్ టాకింగ్ ఈజ్ దట్ ఈస్ అవర్ రెస్పాన్సిబిలిటీ మోరల్లీ అండ్ యాజ్ ఎ జాబ్. సో అది మనం తప్పకుండా చేయాలి అందరం కూడా. సో దాన్ని మరి ఇంకా బెస్ట్ మేనేజ్మెంట్, బెస్ట్ ప్రాక్టీస్ మేము కూడా చేయాలి కదా. బాగా చేసిన వాళ్ళకు తప్పకుండా మేము రాష్ట్ర అవతరణ దినోత్సవం రోజో, స్వాతంత్ర దినోత్సవం రోజో, గణతంత్ర దినోత్సవం రోజో మేము మిమ్మల్ని గౌరవించాలి. ది బెస్ట్ డాక్టర్గా మిమ్మల్ని మేము చేయగలిగితే ఇట్స్ ఏ మోటివేషన్. మీలో ఒక ఏం కోరుకుంటారు? ఎవరైనా సమాజంలో గౌరవాన్ని కోరుకుంటారు, ఒక గుర్తింపును కోరుకుంటారు. బాగా చేసిన వాళ్ళు ఒక మంచి మాట, ఒక అభినందన వాళ్ళలో ఇంకా గౌరవాన్ని పెంచుతుంది, ఇంకా వాళ్ళను మోటివేట్ చేయగలుగుతుంది. సో అది దాని విషయంలో ఉంటాం. అండ్ అట్ ద సేమ్ టైం యూ షుడ్ నాట్ ఫైండ్ ఫాల్ట్ విత్ అస్. ఎవరన్నా తప్పు చేస్తే మాత్రం కఠినంగా కూడా చర్యలు తీసుకోక తప్పదు. ఐఎమ్ సారీ టు సే. మరి ఎందుకంటే వ్యవస్థలో ఏమవుతుంది, మనం ఎంత బాగా పనిచేసినా ఒకరిద్దరు వ్యక్తుల వల్ల మొత్తం వ్యవస్థకు చెడ్డ పేరు రావద్దు కదా. మన దగ్గర 1,00,000కు పైగా ఉద్యోగులు ఉంటారు మన హెల్త్ డిపార్ట్మెంట్లో. అవర్ స్టాఫ్, అవర్ స్ట్రెంగ్త్ ఈజ్ ఎ మోర్ దాన్ 1,00,000. ఈ 1,00,000 మందిలో 99,900 మంది బాగా పనిచేసి ఒక 100 మంది పనిచేయలేదనుకో, 1,00,000 మంది చెడ్డ పేరు ఎందుకు రావాలి? 1,00,000 మంది ఎందుకు ఆ మచ్చను అంటించుకోవాలి, మనం మరకను ఎంత అంటించుకోవాలి? అవసరమైతే ఆ 100 మంది మీద కఠినంగా చర్య తీసుకొని 1,00,000 మంది యొక్క గౌరవాన్ని పెంచే విధంగా పనిచేయాలన్నది నా ఆలోచన. సో ఆ 1%, 0.1%, 0.2% కోసం 99% మంది ఉద్యోగస్తులకు చెడ్డ పేరు రాకూడదు. ముఖ్యమంత్రి గారు మనకి ఇంత బడ్జెట్ ఇచ్చినారు, 11,400 కోట్ల రూపాయల బడ్జెట్ ఇచ్చారు, హెల్త్ బడ్జెట్. యు నో లాస్ట్ టైం వాట్ వాజ్ అవర్ బడ్జెట్? ఇట్ వాజ్ అరౌండ్ 5,600. దిస్ టైమ్ అవర్ బడ్జెట్ ఈస్ డబుల్డ్, ఆల్మోస్ట్ 11,400 crores. ఇంత బడ్జెట్ ఇచ్చినారు, రిక్రూట్మెంట్ చేయమన్నారు, బెస్ట్ ఎక్విప్మెంట్ తీసుకోమన్నారు. ఇంత బాగా ముఖ్యమంత్రి గారికి మనకు సపోర్ట్ చేసినప్పుడు వీ హ్యావ్ టు పర్ఫామ్, వీ హ్యావ్ టు ఇంప్రూవ్ అవర్ సర్వీసెస్. మనం బాగా చేయగలిగితే అంతకంటే ఇంకోటి ఏముండదు. సో ఫైనల్లీ మీరందరూ కూడా ఈ 2 days ట్రైనింగ్కు ఏదైతే వచ్చినారో, బాగా మీరు స్టూడెంట్ డేస్లో ఎట్లయితే క్వరీస్ ఇచ్చినారో, డౌట్స్ ఎక్స్ప్రెస్ చేసినారో, తెలియకపోతే తెలిసేదాకా అడిగి ఎలా తెలుసుకున్నారో కొంచెం బాగా తెలుసుకునే ప్రయత్నం చేయండి. డోంట్ థింక్ దట్ నాకు అన్నీ తెలుసు అని అనుకోకుండా ఫిజికల్గా కూడా వెళ్ళండి, థియేటర్స్లోకి వెళ్ళండి. ఫిజికల్గా హౌ దే ఆర్ టేకింగ్ ద స్వాప్ తీసుకునేటప్పుడు కూడా ఎలాంటి జాగ్రత్తలు తీసుకోవాలి, ఆ స్వాప్ను కూడా ఎట్లా మెజర్ చేయాలి, దాని ప్రాక్టీసెస్ ఎట్లా ఉంటే బాగుంటుంది. ఎందుకంటే మీ మీద మొత్తం ఆసుపత్రి ఆధారపడుతుంది. ఎక్కడన్నా ఒక పొరపాటు ఒక ఆసుపత్రిలో, ఒక థియేటర్లో జరిగితే టోటల్ హాస్పిటల్ విల్ గెట్ బ్లేమ్డ్. టోటల్ హాస్పిటల్కి బ్యాడ్ నేమ్ వస్తుంది, వ్యవస్థకు బ్యాడ్ నేమ్ వస్తుంది. మీరు ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్గా, ఒక నర్స్గా మీరు జాగ్రత్తగా ఉంటే ఆసుపత్రి మొత్తం భద్రంగా ఉంటుంది. ఆసుపత్రికి వచ్చే వైద్యులు, ప్రజలు అందరూ కూడా మరి చాలా జాగ్రత్తగా చక్కగా ఇంటికి పోయేటువంటి అవకాశం ఉంటుంది. సో దిస్ ఈజ్ వెరీ వెరీ ఇంపార్టెంట్ ట్రైనింగ్. ఇది చాలా అతి ముఖ్యమైనటువంటి ట్రైనింగ్. దయచేసి మీరు అందరూ కూడా చక్కగా ఈ ట్రైనింగ్లో నేర్చుకొని మీ ఆసుపత్రిని జాగ్రత్తగా చూసుకుంటారని. మరి ఇన్ఫెక్షన్ కంట్రోల్ డెవలప్డ్ కంట్రీస్లో 7% ఉందన్నారు. మనం లెట్ us ప్రూవ్ వీఆర్ లెస్ దాన్ 7. మేము 7% కంటే తక్కువ ఉంటుంది మా తెలంగాణ రాష్ట్రం అన్నంత గొప్పగా మీరు చెయ్యండి. ఆ ప్రాసెస్లో మీకు ఇంక ఎలాంటి సపోర్ట్ కావాలన్నా ఇస్తాం. ఇందాక నేను చెప్పినట్టు ఎయిర్ శాంప్లర్స్ పంపిస్తాం, థియేటర్ ఎక్విప్మెంట్ మీరు పూర్తి స్థాయిలో కొనుక్కోండి. అదేవిధంగా మీరు వేసుకునే గౌన్స్ కానీ థియేటర్ లోపలికి వెళ్ళేటప్పుడు మీరు చేంజ్ చేసుకున్న డ్రెస్సెస్ కూడా దాని స్టెరిలైజేషన్ ఎట్లుంది, దాన్ని ఎట్లాగో వాష్ చేస్తున్నారు. చాలా చోట్ల మెకనైజ్డ్ ల్యాండ్రీస్ కూడా ఇచ్చినాం, అక్కడ కూడా పొరపాటు అవుతుంది. అదే గౌన్ 4 సార్లు వేసుకొని పోతే మరి అది బయట అనలే వేస్తున్నారు, అది ఎంతవరకు కరెక్ట్గా ఉంటుంది, అదేంటి, ఆ ఎక్విప్మెంట్ ఏంటి, ఆ స్టెరిలైజేషన్ యూనిట్ ఏంటి, థియేటర్లో ఇంకేమేం ప్రాబ్లమ్స్ ఉన్నాయి అన్నిటిని కూడా నేను ఐఎమ్ నాట్ ఏ డాక్టర్, బట్ మీ నుంచి విన్నది నేర్చుకున్న దాని నుంచే చెప్తున్నాను నేను. సో వాటన్ని జాగ్రత్తలు కూడా ఇంకేమేమి ఉన్నాయో నిమ్స్ ఇస్ ద బెస్ట్ ప్రీమియర్ ఇన్స్టిట్యూట్. వాళ్ళు మీకు మా సూపరింటెండెంట్ మా రామూర్తి గారు, మా ఇన్ఛార్జ్ డైరెక్టర్ గారు చాలా మంచి డాక్టర్, వెరీ ఎక్స్పీరియన్స్డ్ డాక్టర్. అండ్ ఇక్కడ ఉండే మా మైక్రోబయాలజీ డిపార్ట్మెంట్ కూడా బాగా స్ట్రాంగ్ ఉంది. వాళ్ళందరూ కూడా మీకు కావాల్సిన పూర్తి సహకారం ఇస్తారు. కాకపోతే కొంచెం 2 days మీరు కూడా బాగా కాన్సన్ట్రేట్ చేయండి. కొంచెం 4 o'clock వెళ్ళిపోవాలి లేదంటే హాఫ్ డే లీవ్ అనుకోకుండా ఈ 2 days మాత్రం పూర్తి స్థాయిలో దృష్టి పెట్టి మీరు తద్వారా మంచి ఉత్తమమైనటువంటి సేవలు అందించాలని కోరుకుంటూ ఈ ట్రైనింగ్కి వచ్చిన మీ అందరికీ ధన్యవాదాలు. థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir, for your valuable and inspirational speech. Next, I invite our medical superintendent, sir, Satyanarayana Garu, to give his valuable speech. Now, I invite our senior residents to hand over the bouquets to all our dignitaries on the dais. Dr. Neha, please hand over the bouquet to our Honorable Minister T. Sri Harish Rao Garu, sir. I invite Dr. Bushra to hand over the bouquet to our DME, sir, Dr. Ramesh Reddy Garu. I invite Sabanas to hand over the bouquet to our beloved director, sir, Dr. Ramurthy, sir. I invite Dr. Amreen to hand over the bouquet to Dr. Shweta Mohanty, madam. Sorry, ma'am. Next, I invite to hand over the bouquet to our TVVP, sir, Dr. Ajay, sir, Ajay Garu. Dr. Gangadhar, sir, please accept the bouquet, sir. Thank you, sir.
Hello. Check 1 2. Hello. Check. Check.
Good morning, everybody. Thank you, Padmaja, for giving this opportunity. So after a very inspirational, wonderful oration like speech by our Honorable Health Minister, so everybody has addressed about the patient safety. So how to take care of the, how not to give hospital-acquired infections to our patients. But at the same time, healthcare workers are also very important. So we should not get any infections from the patients, like from the bloodborne pathogens. And till recently, COVID was a great threat to all of us. And tuberculosis, from time immemorial, we all know that healthcare workers definitely have, a lot of risk of acquiring tuberculosis and other bloodborne pathogens, airborne pathogens like influenza and other, other infections are also quite possible. But then, very important and very, scary for the healthcare workers are the bloodborne pathogens, and especially from the needle stick injuries. So let us, if we are equipped and if we are confident about this, then we can deliver, good care very confidently. Because having chosen this profession, this occupation, that we have definitely a threat and we have a risk. But then how to encounter it and how to empower. And I'm sure, most of you are, senior faculty in the respective medical colleges. So you all should be, encountering this needle stick injuries in your day-to-day practices. And then most of you may be having a lot of experience managing it. So could I please know how many of you have encountered a needle stick injury? Okay, sir. I mean, it is not only your personal. What I feel is, did you manage a healthcare worker on this topic? So, anybody else? So, how many are doctors here? Okay, right. So, who will be managing your, needle stick injuries? Because these are inevitable. Okay, even if you take a blood sample, also, there is a risk. Okay, so who takes care of them? So, those of you who have come here, you may be a doctor or you may be a nurse. I think you should be, willing to help. And most important of all is to ready to accept it, ready to listen to the healthcare worker who is inflicted by the needle stick injury. Generally what they say is, I am not sure about it, I refer you to somebody. So then 50% of the emotion, anxiety increases for the healthcare workers. So we should be ready to help and stand for them and listen to that and then take an approach. Actually, it is not that difficult. Okay, so let us start dealing with the topic. So I would like to give you a case scenario wherein a student nurse sustained a needle stick injury while testing blood sugar in a known HIV positive patient, and 20 gauge needle it was, and there was a visible blood on that, and she was trying to recap it, and then this is a common scenario. So after doing the blood sugar, they will be recapping it, and then they get the needle injuries. Okay, so this is what exactly happened, and the student was not vaccinated for hepatitis B. So most important is, for HIV there is no vaccine. For HCV there is no vaccine. What we have is hepatitis B vaccine is available. So just by the time they are getting recruited, we give a health checkup, and then we say that she is fit to, to fit means blood pressure is okay, no anemia, nothing, HIV, HBsIg, HCV is normal. So then she's fit. But no, to be fit to be a nurse or to be a medical student or to be a medical doctor, to work in an OT or in an ICU or anywhere, that you should be vaccinated for hepatitis B. Further to that is if their titers are good or not. So now hepatitis B has become part of the universal vaccination program at birth. So on the left, what do they give? BCG. And on the right, they give hepatitis B. 0 dose. Okay, 0 dose at birth. So most of these children who are born, and then are joining a medical college or joining, most of them must have had. But the antibody titer may not be appropriate. There may be a fall in the antibody titer. So this is the best time is when they are joining as a nurse or joining as a nurse, as a student, or joining as a medical student or as an employer. That is the best time to check the titer and then give them a booster if the titer is less than 10 international units. Okay, so look at the titer, and if it is very good, something like 100 like that, okay, you are well to join. Otherwise, take a dose. And hepatitis B, the beauty is that it is one of the best vaccines. It is a recombinant. It can be given even to the pregnant ladies. Okay, so if somebody is joining when they are pregnant, still they can take it if their titer is less, and that will take care of during their delivery also. Okay, hepatitis B vaccine, and the efficacy is so beautiful, so wonderful. With the first dose itself, they get 80% protection, and in the second dose, 95, and if with the third dose, it is 3 doses. Okay, so that is about the immunization. So, this unfortunate student did not take the hepatitis B vaccine also, and several times they may not be aware also. So when you are evaluating a needle stick injury, one is these who got inflicted is one, and second thing is what is the source. So the source is in a 45-year-old HIV man who was on antiretroviral therapy for 6 years and on multiple regimens because he had a lot of side effects, and his CD4 is reasonably good, that is 414 cells. Okay, so this is one good part. That means his virus is suppressed and he has a good immunity. That means his viral load is not too much. That she's not going to get the infection so easily. So this is a typical case scenario. Then we go to the what is post-exposure prophylaxis? It is a situation where HIV has a chance to get into someone's bloodstream after after the exposure, and we are going to give a prophylaxis. So there are 2 kinds of exposures. One is occupational exposure, other is non-occupational exposure. So what are the 3 bloodborne pathogens that are likely to get the healthcare worker afflicted with that? That one is HIV, HBsAg, and the HCV. HIV has least chance of infecting a healthcare worker, but the stigma associated with this so much that we thought we will first deal with that. And coming to the definitions, occupational exposure refers to exposure to potential bloodborne pathogens. Non-occupational exposure, it is outside the work setting, that is sexual assault and rape, and we are not going to discuss about that. And post-exposure prophylaxis refers to the comprehensive management given to minimize the risk of infection following potential exposure to bloodborne pathogens. So, many people think what to give, what treatment to be given. It is, it doesn't start with that. It starts with listening to the healthcare worker. So somebody should volunteer, should listen to that and document, write, and go to the source, and then see whether the injury is real or not, and what exactly happened. So analyze it. Is the source having a bloodborne pathogen at all? Hepatitis B positive or not? HCV positive or not? Or HIV positive or not? And then analyze it and then take a decision. Not just administering the medication. So a percutaneous injury, that is a needle stick injury, or a cut with a sharp instrument, and a contact with the mucous membrane of the, like a splash into the eye or mouth, contact with non-intact skin, that is abraded skin. Many of the women, nurses, we all will be doing our work at home and then going there. Sometimes we do the cutting, we do the cooking, everything, and then go there. So there is a possibility of abraded skin on the hands is quite possible. Then contact with intact skin. If it is for a prolonged period, then also it comes under occupational exposure and a risk to them. Because some surgeon, especially heart surgeons and all, they'll be operating, and there is sometimes, they get wet, prolonged surgery, splashes, all these things do happen. And then they can't abandon the surgery also. They go on and then they continue the surgery, and then then you have to evaluate, is it intact skin, how long is it, is the patient HIV positive, HBsAg positive, HCV positive. So all these things come under the definition of an occupational exposure. So any direct contact to a concentrated virus in a laboratory facility also, so it is not only the clinical people, it is also the laboratory people also can get exposed. And human bite, sometimes very rarely these things can happen, like an aggressive patient may bite a healthcare worker, that also comes under the occupational exposure to the pathogens. So there are some fluids which are potential for the risk, like blood, semen, vaginal secretions, CSF, synovial fluid, pleural fluid, pericardial fluid, amniotic fluid, and other body fluids contaminated with visible blood. And there are some kind of fluids like tears, sweat, urine, feces, saliva, sputum, and vomitus. So these do not cause the infection to the healthcare workers. So somebody is cleaning toilets, there's a splash, then I'm going to get, so that doesn't happen. Okay, we need to counsel, and we should be knowing that what can cause an infection to the healthcare worker, and what cannot cause an infection to the healthcare worker. This we should be sure about it. So who are usually at risk? It is the nurses who report the most frequent exposure, followed by the postgraduate students and consultant physicians, surgeons very often in the operation theaters, phlebotomists, and non-laboratory technicians, technologists also can get these, they are at risk. Okay, and long work hours, sleep deprivation, and among the medical trainees result in fatigue, and sometimes it is associated with threefold increase in the risk of needle stick injuries. So work practices which increase the risk of the needle stick injuries include recapping of needles. This is a very, very frequent one. So this is very, very important. And performing activities involving needles and sharps in a hurry, and handling and passing needles or sharps after usage. So previously what used to happen is that there used to be a kidney tray. Okay, whenever you're giving an injection, you load it, you keep it sterile, and then take it to the patient area. Okay, those practices are forgotten. I think they have to be reintroduced so that the doctor is is safe, and also the patient is safe, and then you can take it in a clean tray and then go to the patient, and you mix the injection, prepare the injection in a specific area which is clean, and then take it to the patient area, administer, and then bring it back. So if, this is a very interesting and important move that has started, that we are concentrating on infection control and infection prevention. So if, I think this suggestion also can be given to them, so that we can reintroduce the use of these kidney trays, and then take it to the patient area, and we can deliver very safely. And handling and passing needles or sharps after usage, and failing to dispose of used needles properly in a puncture-resistant sharps. I think that is covered in the injection safety. And poor healthcare waste management. I think that is also covered by Dr. Neelima very beautifully. And ignoring universal work precautions. I think the standard precautions they named it as now. So those have to be imbibed. See, our profession is different. We are different. We have a work ethics, and we have a work code, and we need to follow that, and we should be proud of it. There are no shortcuts about it, because not only the patient, I think the doctors also are going to get affected if at all we don't follow all that. And Risk for transmission and management regarding HIV, the CDC estimates around 5 lakh needle stick injuries in every year, and as of 2010, 57 cases of documented HIV seroconversions happened, but all happened before 1995 because they were not aware of the concept of post-exposure prophylaxis. So, coming to the seroconversion after occupational exposure, as far as HIV is concerned, percutaneous it is 0.3%. That means after 1,000 needle stick injuries, 3 are likely to get it, and that becomes 0 if you give a post-exposure prophylaxis. Okay, mucous membranes it is 0.09%, but the intact skin is very low, so less likely less than my mucous membrane. So if it is an intact skin, the chance of getting an HIV infection, even if it is a prolonged exposure, is negligible. The risk for infection increased with exposure to larger amount of blood. If it is a blood transfusion, then there is a chance of 90% the person getting HIV. That is why the blood safety mechanism has improved. The HIV testing for the blood before transfusion has increased. So transfusion associated HIVs have drastically come down now with the blood safety mechanisms that are developed. And a device visibly contaminated with a patient's blood, and a procedure involving direct venous or arterial puncture of the patient, if there is a needle stick because of that, or deep injury to the healthcare worker, these cause an increased risk of HIV to the healthcare worker. Risk for infection is increased if the source patient has high viral load. If the patient is already on antiretroviral therapy, then the chance of healthcare worker getting the infection is definitely less. Okay, but if the patient is not taking it properly and on irregular treatment, and if this viral load is again high and his CD4 is very low, then the chance of getting a resistant virus getting into the healthcare worker is highly possible. So we should be aware of it. That is why when we prescribe the medication, it is not just prescribing the medication straight away. It is talking to the patient, with healthcare worker, going to the situation and then asking the witness, talking to the patient, and then understand his records, and then prescribing that gives a complete care. So this depends, all this evidence is built after realizing on the primate model for the SIV infection. Then dendritic cells at the site of inoculation infected during the first 24 hours after the mucosal exposure, and the dendritic cells interact with the T cells, and there is extensive viral replication, and over the next 24 to 48 hours, they migrate to the regional lymph nodes, and virus is detectable in the peripheral blood within 5 days. So this is the evidence, and theoretically PEP given immediately after exposure may prevent or inhibit the systemic infection by limiting the proliferation of the virus in the initial target cells and the lymph nodes. So the goal is to abort the irreversible systemic infection. Even if the infection is prevented, the suppression of the initial viremia could attenuate the future progression of the HIV infection. So even though it is a deadly virus, so there is a way to stop it by giving a post-exposure prophylaxis. The PEP efficacy is decreased if we delay in initiating the PEP, or shortening the duration of the PEP, or inappropriate choice of antiretroviral therapy. Okay, but just one drug, that is Zadovudin itself, has decreased the risk of acquiring the infection after a needle stick injury by 81%. But now we are giving how many drugs? 3 drugs. The chance is almost 0. But the fear is 100%. The chance is much less, but the fear is so much. The stigma associated is so much. So the post-exposure prophylaxis is most effective if implemented as soon as possible. And the similar studies looked at duration of the PEP. If PEP is given for 28 days, there is 100% protection. So PEP does not replace the PPA does not replace the exposure avoidance. Like for example, staff training is important, sharp disposal is important, universal precautions are also very, very important. So what are the key elements in the management of post-exposure management? So wound and the skin site which is exposed should be washed with soap and water. Many people will be cleaning it with bleaching, with the sterilium, all these things. So what is most important is cleaning it with the soap and water. And mucous membranes which are exposed should be flushed with water. And no evidence of benefit in using these antiseptics and caustic agents like bleach and all these things. Okay, and key elements of post-exposure next step is the exposure reporting. So someone should document it. Okay, there should be a health record. Just not giving, just by writing on a small slip and you get this medication, you pop in the tablet. That doesn't happen. So you need to document date and time of the exposure, details of the procedure being performed, and details of the exposure, and details about the exposure source, and the exposed person, details about the exposed person. Exposure source means the patient who is HIV positive or HBsAg positive or HCV positive. That should be documented, and what medication they were on, what is the immune status, as much as possible. If if there is nobody, only nurse garu unnaru duty lo, so she has taken all the details. So how much ever is possible, you take that much details. Okay, on these categories like time, date, and details what procedure was done, and details of exposure, and details of ఏ పేషెంట్ నుంచి వచ్చింది, ఆ పేషెంట్ పేరేంటి, సిఆర్ నెంబర్ ఏంటి, లేదా వాట్ ఎవర్ ఐడి నెంబర్, and all these things have to be noted down, and details about the exposed person. So what happened to this exposed person? See, this patient may be, this healthcare worker may be already HIV positive. Who knows? This becomes a medical legal issue. So that is why it is important to take the details of the healthcare worker details also, and then immediately test some samples. What samples have to be done? Hepatitis B, surface antigen, and HIV rapid test if possible, and then or ELISA, then HCV testing. All these also have to be sent, even before the starting of the post-exposure prophylaxis. So evaluation of the exposure source. The source person should be evaluated for infection status with an approved rapid HIV antibody test. See, once what happened, the patient has come with a lymph node into the CT room and ultrasound room, and then guided aspiration was done, and there was a needle stick injury to the doctor. So when he looked at the records, there is no HIV status of the patient. So what the doctor has done, he is a very smart guy. He has first taken the post-exposure prophylaxis, then he got the HIV test done. So what is the possibility? Most probably it is a lymph node, most probably because of a tuberculosis. Tuberculosis is one of the age-defining illnesses. So he thought that much far and he has taken it. Then after popping the tablet, then he came to me. Then I spoke to the patient, and I took the consent, and then sent a rapid test for the HIV. Fortunately, that was negative. And then we have done then ELISA also, and then that also has come negative. Then we have reassured the doctor, and he has taken by the time 3 days of antiretroviral therapy. We have allayed his fear. I said he has got a lymph node tuberculosis just like that. He's a diabetic, he got it, so you don't need to worry. Okay, some people are so anxious, sometimes they do take. So what you have to do is, you have to evaluate the source, you have to evaluate the doctor also. At the same time, the doctor's test was all done. HIV, HBsAg, HCV, and one hemogram for him, and a kidney test, whatever, renal functions and all done, liver function was done. He's already popped in the tablet. So let us see how he fares, and whether we need to change the medication, then we'll see. So that is sometimes, one can think like that. Because in India, the HIV prevalence is quite high compared to the other countries. So if the clinical scenario is like that, if you go and examine the patient, you will understand there is a likely. So, but luckily there is something called rapid test. You take the consent from the patient, that is the source, and then you do the test. Then you will, most of the there will be clarity in the situation, and then you can go ahead and take the decision. So it need not always be a physician only. So there should be team. There should be a team like post-exposure prophylaxis team, which can work for about 2 months, and then the team can change. Then that way, we all will start having an experience. Okay, so all are healthcare workers only. So all can be leaders, right? So empowering, somebody is on leave, okay, somebody is not well, only they should take care is not right. So I think better to have a small team which can work for 2 months, have a small protocol. It need not be very very complicated protocol. It can be a very simple protocol. If at all somebody comes with this, what to do. So something like that for the hospital, one page, if we can develop and stick it somewhere, and I think we can solve it easily. Everybody's so scared. Maybe maybe have to follow up, all these things. But then the poor person, the healthcare worker, will be left, not attended to. That should not happen, because sometimes some of these nurses, they come after 1 week. I had a needle stick injury from that person. Now I got the report of the HIV and it is now positive. I feel very sad for them. Fortunately, the percentage of seroconversion is so less, so we reassure, and sometimes after 7 days, what do? You cannot do anything. Only you keep them under follow-up, look at them after 12 weeks, and then see if they are, usually fortunately they are, they don't seroconvert, and then at least from that episode they should learn. So the exposed individual should be tested for pre-existing HIV. So we should also look for their HIV status. So immediately talk to them very nicely and reassure them, do their HIV test, HBsAg test, HCV test, look for their anti-HBs antibody titer, reassure them, and if it is HIV positive source, then give them post-exposure prophylaxis. So factors that affect the transmission. If it is a hollow bore needle, and if it is containing blood, you have done a venipuncture and then taken out, that means that hollow bore will have lot of blood. So the person going to get, have a higher chance. Then when the needle is being placed inside a vein or artery, definitely it is carrying the virus. And severity of injury. If it is a deep injury, then it is highly, the chance of getting it is high. And the amount of blood involved, how much blood has gone inside, is also very important. Amount of virus in the patient is, if the patient is not on antiretroviral therapy, then there is a chance of a patient having high viral load, and the chance of getting the HIV transmission is much high. Then next is the counseling. The counseling is the most important part is the counseling. Okay, one day one nurse has come and one doctor has come and she said, I want about an hour time. I want to sit with you and talk to you. She spoke, she was talking about her pregnancy, likely to become pregnant, but then what is the effect of antiretroviral therapy? So many things. She had so many doubts, and then someone has to hear all that and then reassure them. Most important is counseling and assessing the source and assessing the exposure and coming to a proper conclusion. Several times when you analyze what happens, actually the exposure is 0. Okay, so we should not write the treatment right away and then this is the post-exposure prophylaxis of the institute. You just take it. But if we go there and talk to them, they sometimes will be wearing glove and they will be saying, I am not very sure whether the needle stick has happened or not also. Something went in but it did not touch. But if you examine, there is nothing. So sometimes when you go and analyze the records, the patient is not HIV positive also. So counseling is the most important part, and then to tell them that we are there with you, that we'll take care of you, is the most important part. And someone should take the leadership about, for this month or for this 6 months or this 2 months, I'm going to take care of all the needle sticks of the hospital, or I'm going to train, or we're going to be like a team. This is very, very important. And provide psychological support, explain the need for post-exposure prophylaxis, address the issue of compliance and possible side effects. So no drug is without any side effects. So we are going to give this medication, these are likely side effects. And if at all you have this, then we'll change the antiretroviral. So this type of reassurance is very, very important. The next important is, then comes the post-exposure prophylaxis. Many people say, write the medication, that's it. No, it is not. There's a lot of anxiety in the healthcare worker after a needle stick injury. So that should be addressed first. And what is the current post-exposure prophylaxis that is being given is a tenofovir with emtricitabine with raltegravir or dolutegravir. So now the treatment is raltegravir for those who are pregnant and dolutegravir who are pregnant. Okay, so the alternate, we should always have an alternative. Okay, so if the patient is allergic to raltegravir, or patient has got a renal dysfunction, then you cannot give tenofovir and lamivudine. Then you need to have a backbone. Then that time you can go for zidovudine with lamivudine with PI based regimen, that is protease inhibitor, like you give lopinavir, ritonavir, or you can give atazanavir, ritonavir, and you have several combinations. It is not just one regimen. Previously, they used to give zidovudine and lamivudine with lopinavir and ritonavir. Why zidovudine with lamivudine is not being given is because it can cause anemia. Okay, so many of the nurses, nursing students are already anemic. So it can cause severe bone marrow suppression also. So they shifted to tenofovir with lamivudine or emtricitabine with API based regimen. So 2 drugs versus 3 drugs. Do we need to give 2 drugs? They used to call it as a simple regimen, and the 3 drugs as expanded regimen. So previous studies have suggested that 2 drugs may be more effective than 3 due to better tolerability and less side effects. They need to balance this with the risk of exposure and the risk of transmission of the resistant virus. So if you give 3 drugs, then you will cover the resistant virus also. If you're giving 2 drugs, then you will have less side effects. So you need to assess whether the exposure is high or is the exposure low. And depending on that, you decide how to give the post-exposure prophylaxis. So the WHO also now recommends the tenofovir-based regimen, and tenofovir with lamivudine, with lopinavir, with ritonavir, okay, or atazanavir with ritonavir is being given. For how long is to be given? 28 days is the duration to be given. Okay. So at least 50% of the healthcare workers, after starting the post-exposure prophylaxis, they will complain with some adverse effect or or other. So 33 to 50% will stop taking the PEP because of side effects. So we have to reassure them, if it is a minor side effect, then they can continue. Otherwise, we need to change to, we have alternative regimens that can be given. So there are some medications which should not be given. Nevirapine previously is being given. It is being completely discontinued. Efavirenz we used to give before. It can cause the CNS side effects like anxiety, weird dreams, all these things. So patients the healthcare worker is already anxious. If you give efavirenz, they're likely to have bad dreams, and then tolerance is much less. But if you have any side effects, you have no other option, then maybe you can prepare the healthcare worker and then give them. And abacavir has a risk of hypersensitivity, and the D40 and DDI are completely toxic and is being discontinued. And the older PIs, they are, sometimes the tolerability problems may be there, like diarrhea, and meraveric is not being given at all because it only works for some strains of the HIV virus. And duration of PEP should be 4 weeks, 28 days, and healthcare worker will need close follow-up and management of the side effects. And first, we should assess them again after 72 hours, again after 2 weeks, and we need to do the renal function test, liver function test, and also the blood counts, that is CBP. And after HIV antibody at 4, you need to look for the antibody if they are getting converted at 4 to 6 weeks, 12 weeks, and 6 months. And if they are negative, then declare them that they are completely negative and take out their fear. So once an exposure happened, all this post-exposure prophylaxis happened, the likelihood of secondary transmission is extremely remote, and important to modify the behavior of the healthcare worker and then give appropriate counseling and training. So what is our country, NACO is telling about the post-exposure prophylaxis. The preferred regimen is tenofovir with lamivudine with dolutegravir. But if the healthcare worker is pregnant, then you need to give tenofovir with lamivudine with efavirenz or with a PI-based regimen, that is lopinavir, ritonavir, or you can give atazanavir and ritonavir. So what about the hepatitis B and hepatitis C? We know now the immunization for HPV is very, very effective, and but if at all the titers have come down, or if the healthcare worker is not vaccinated at all, then we need to treat them with two things. One is giving vaccine immediately. Okay, hepatitis B vaccine immediately, and also administering hepatitis B immunoglobulin. So it protects passively, and at the same time, healthcare worker can be given active immunization by starting the hepatitis B vaccination schedule, which includes 3 doses: 0, 1, and 6 months. Okay, it is a recombinant vaccine. It can be given even to the pregnant, and it has least number of side effects, and the best part is it is very, very effective. With first dose there is 80%, with the second dose they have a protection of around 95%, and third dose with more than 95% protection with hepatitis B vaccination. So in this scenario you need to give both the active and also passive. Clinician should evaluate the source of hepatitis B virus by testing the hepatitis B surface antigen, and clinician should initiate the hepatitis B vaccine series. The 3, first dose should be given and should not delay in the decision of vaccinate while testing for hepatitis B surface antigen. So before the results come, you give the first dose. Clinician should administer the prophylactic hepatitis B immunoglobulin, and there are so many sources in the in the internet. Only thing is, one should stand there and should lead and should take the leadership and be ready to treat and reassure the healthcare worker. And they should initiate hepatitis B vaccine series, and if the source is at high risk of hepatitis B infection, then the clinician should proceed as if the source is HBsAg positive. Okay, and both the first dose of hepatitis B vaccination and also immunoglobulin should be administered in less than 24 hours of exposure, and HBIg should be administered within 7 days. If they come after 7 days, there is no use if you give a passive immunization. So it is better if you give it within 24 hours post-exposure, and it is demonstrated to be effective 70 to 90%. But the best would always be, taking the nurse at the, and administering the vaccine before inducting them as a student nurse or as a nurse into the hospital. And there is no effective treatment for hepatitis C after the exposure. So what is the dose of hepatitis B? Immunoglobulin is 0.06 ml per kg intramuscularly. See, sometimes you may not remember. You can just look at your phone, understand, procure it, administer, and also plan to give a vaccine. So for HCV screening of the should be offered in accordance to WHO guideline, and individuals should be counseled on the risk of acquiring HCV and be referred to a specialist care if seroconversion occurs. And currently research has identified no effective prophylaxis for HCV infection, and immunoglobulin antivirals are not recommended for HCV post-exposure prophylaxis. How to prevent? Use gloves, goggles if it is a high exposure procedure, and wash hands after the exposure, and be careful when handling and disposing sharps, and use safety devices to prevent the needle stick injuries, and dispose of used syringes and sharp instruments in a sharp container. So I think what we can again bring back is this kidney tray, so that your patients are safe and your healthcare worker is safe and your colleagues are also safe. Several times what happens, they will be carrying a needle and then be inadvertently giving the needle stick injury to their colleagues and to their friends. So these are the guidelines, and thank you very much. Any question? Sir? Interference, there is no role, sir. There is no role. HCV, how many days they are likely to get? The 6 weeks. There is no screening test immediately. What we can do is, for the healthcare worker, we need to screen, see if they have already infected or not. That is what we can do. So the chance of getting is, I mean, you must be knowing the rule of the, 3. I mean, 30% for hepatitis B, 3% HCV, and 0.3% for the HIV. And it has become negligible with the advent of the post-exposure prophylaxis for HIV. For hepatitis B, vaccination is anyway there. For HCV, there is nothing. So if there are no questions, thank you.
Thank you, Dr. Subbalakshmi Madam, for enlightening us with your lecture. Now I invite Dr. Neha Singh to present her topic on personal protective equipment. Thank you.
So good afternoon, everyone. I'm Dr. Neha, and I'll be talking about the personal protective equipment used in the healthcare system. So what is PPE or personal protective equipment? The PPE refers to a specialized clothing or equipment worn by an employee for protection against the infectious material. Okay? The objective of using the PPE in healthcare setting is to protect the skin and the mucous membrane of the healthcare worker from the exposure to the blood and body fluid and from the healthcare worker hand to the patient during the sterile and invasive procedure, and it also protects the patient from contracting infection from the healthcare worker. So the selection of the appropriate PPE must be based on the following parameters, such as type of the anticipated exposure, such as touch, splashes, or spray, or large volume of blood and body fluid that might penetrate the clothing. Next is the type of isolation precaution applied, that is the selection of PPE, which is determined by the Next is the type of isolation precaution which is applied, that is the selection of the PPE, which is determined by the route of transmission of organism and category of isolation precaution applied to the patient, such as standard, contact, droplet, and airborne. And then comes the durability of the PPE, for example, whether a gown or apron is needed to be selected for PPE, or if a gown is selected, whether it needs to be fluid resistant, fluid proof, or neither. So then comes the fit. So PPE must be fit the individual user accurately. Then comes the appropriate use of PPE. So PPE should be used appropriately, that is used only when a particular indication exists in the protected environment, and should not be worn outside that area, and must be removed before leaving that area. Then comes the training, which should be given to all healthcare workers about the indication of PPE use, procedure of don and remove PPE safely, and sequence of donning and doffing. And at last, the disposal or reuse of the PPE. So here various PPE used in the healthcare service and gown are gloves, gown, apron, mask, respirator, footwear, and the eye protector. So gloves protect the hands, gown and apron protect the skin and clothing, mask and respirator protect the mouth, nose, and respirator also protect the respiratory tract from the airborne infectious disease, and goggles protect the eyes, and the face shield protect the entire face. And now we will see them one by one. So coming to the gloves, gloves can protect both patient and healthcare worker from exposure to the microorganism that may be carried by the hands, and it is used as a part of standard precaution and also the droplet precaution. So various indication of the glove use are before a sterile procedure, anticipation of a contact with blood or body fluid regardless to the existing of the sterile condition, and including contact with non-intact skin and mucous membrane, and also contact with the patient during the contact precaution. So there are some indication of removal of glove also. So as soon as the glove are damaged, they should be removed, and after the contact with the blood or body fluid, non-intact skin and mucous membrane, it should be removed, and after the contact with the patient and their surrounding or a contaminated body site. And where there is an indication for hand hygiene, it should be removed. So there are some clinical situations also where use of glove is not recommended, such as for routine patient care activities like for measuring the blood pressure, temperature and pulse, and some giving injection, and during maintenance of IV cannula, provided there is no blood leakage. There is no recommendation of glove use. And then giving the oral medication and serving food also, it is not recommended. And during bathing, giving care to the patient, and also while they are transporting patient, we should not use the glove. And for routine entry into the isolation room, if contact with the patient and or environment is not anticipated, glove should not be used. And while using computer keyboard, writing in the patient chart and replacing the linen for the patient bed, it is not used. So coming to the hand hygiene and the glove use. So appropriate hand hygiene such as hand rub or hand wash should be performed before wearing gloves to prevent the possible cross-contamination of the glove with the healthcare workers' flora in case of glove damage or improper use. So hand wash after glove use should be done to reduce the cross-contamination, and glove must be changed between the patient contact and between the separate procedure on the same patient. And no hand hygiene should be performed over the gloved hand, and when removed, glove should not be washed, decontaminated or reprocessed for any reuse purpose, and it should be disposed of in the appropriate waste bin. So can anybody tell me what is the appropriate waste bin for the gloves disposal? Sorry? Red bin. So here the steps of donning and doffing of the gloves are being shown. So steps of donning are like take out the gloves from its cover and touch only a restricted surface of the glove corresponding to the wrist and don the glove, and to avoid the touching of the skin of the forearm with the gloved hand, turn the external surface of the glove to be donned on the folded finger of the gloved hand and thus permitting the glove on the second hand. And one's gloved hand should not touch anything else that is not defined by indication and condition of the glove use. Now coming for the doffing, pinch one glove at the wrist level to remove it without touching the skin of the forearm and peel away from the hand, thus allowing the glove turn inside out, and then hold the removed glove in the gloved hand and slide the finger of the ungloved hand inside between the glove and the wrist and discard them. So this is the type of gloves according to their use with the clinical situation. So non-sterile gloves are used for the procedure where there is a risk of transmission of infection from the patient to the healthcare worker for example, venipuncture, emptying a urinary catheter bag, etc. And then sterile gloves is used for procedure where sterile environment is required. That is for all the surgical and the aseptic procedures. And reusable utility gloves are indicated for non-patient care activities such as handling or cleaning contaminated equipment or the surface. So this slide is showing the different types of gloves according to their physical matter. So latex glove is used for as a general purpose glove. Vinyl gloves are made up of polyvinyl chloride and are used for handling the cytotoxic drugs. And nitrile gloves are used in procedure involving high risk exposure when high barrier precaution is needed. And the rubber gloves are generally purpose heavy duty or household type glove and are used for the environment cleaning and decontamination. Then comes the face mask and the respirator. So respiratory protection reduces inhalation of aerosol and therefore it is essential when there is a risk of transmission of droplets. So there are two types of PPE available for the respiratory protection, that are face mask and the respirator. So coming to the face mask include surgical mask which is fluid resistant and isolation or procedure mask which is not fluid resistant. So surgical masks are loose fitting, single use item that cover the nose and the mouth, and they are as a part of standard precaution and also provide protection from the respiratory secretion. And when using a surgical mask, the following measures should be considered. Like disposable mask should be discarded or changed after 4 to 6 hours or used or earlier if it becomes soiled or wet. And these are for single use only and so never be reapplied for the after the removal. And mask should not be left dangling. Here you can see mask should not be left dangling around the neck, which is a common practice observed among the doctors. And touching the front of the mask while wearing should be avoided. And mask should not be worn with a beard or unshaven face. And hand hygiene should be performed before donning of the mask or discard and used mask. Now coming to the respirator, a respirator is a device to protect the wearer from inhaling the particulate matter, including airborne microorganisms, fumes, vapor, and gases. So there are two main categories of respirator. Air purifying respirator, which forces the contaminated air through a filtering elements. Most of the hospital use respirator fall into this category. For example, N95 respirator. And then comes the air supply respirator, in which an alternate supply of fresh air is delivered. So coming to the types of respirator, there are many types of respirator defined in many ways, such as National Institute of Occupational Health and Safety defines the respiratory based on their resistance to oil and ability to filter to airborne particles. Then there is a European standard EN 143 which defines the various classes of particle filter that can be attached to a face mask, and then the European standard EN 149 which defines various classes of filtering face pieces. So these are the different types of respirator according to oil resistant property as per as NIOS. This is according to European standard EN 143 and this is according to the European standard EN 149. So coming to N95 respirator, it is the most common respirator used in the healthcare facilities, and it refers to a half mask air purifier respirator with a National Institute of Occupational Safety and Health approved N95 particulate filter. It is a negative pressure respirator because the pressure inside the face piece is negative during the inhalation and compared to the pressure outside the respirator. An N95 mask should be removed or changed once in 8 hours or earlier if it gets clogged and if it gets wet or dirty on the inside, or if it is deformed or torn, it should be changed. And the use must be follow the correct technique of donning and doffing the N95 respirator, otherwise, it may not provide the adequate respiratory protection. So here the techniques of donning of a respirator is depicted. So what we have to do, first we have to perform the nose clip, and by gently bending at the center of the panel and hold the respirator in one hand and pull out bottom panel to form a cup, and then turn the respirator over the exposed headbands, and after the cup respirator under the chin and pull the strap over the head, and locate the lower strap below the ears and upper strap across the crown of the head, and adjust the top and the bottom panel for a comfortable fit. And using the both hands, mold the nose clip to a shape of the lower part of the nose to seal the respirator of on the face should be fit checked prior to the wearing in the work area. So coming to the fit testing and the fit checking. In order for an N95 respirator to offer a maximum desired protection, it is essential that the wearer should be trained and the mask is properly fitted to the wearer. So there are two types of testing method. The first one is fit testing and the other one is fit checking. So for the fit checking, the healthcare worker must perform the fit checking every time they put the N95 respirator to ensure that it is properly fit. So and no clinical activity should be undertaken until a satisfactory fit checkup has been achieved. So fit check ensures the respirator is sealed over the bridge of the nose and mouth, and there are no gaps between the respirator and the face. So fit checking includes the following steps such as placement. The respirator is placed on the face and tied over the head and the base of the neck, and then sealing, where the respirator is compressed to ensure a seal across the face, cheek and the bridge of the nose, and the positive pressure seal, which means to seal the respirator, is checked by the gently exhaling. If the air escapes, then the respirator needs to be adjusted. And the negative pressure seal of the respirator is checked by gently inhaling. So positive pressure of the seal is checked by exhaling, as well, and here the negative pressure of the seal of the respirator is checked by gently inhaling. And if the respirator is not drawn inwards the face of the air, inwards the face, or the air leaks around the face seal, the respirator is readjusted as the process is repeated, and if still not proper, then the respirator should be checked for any defect and the damage. Next, coming to fit testing. Fit testing is done to identify which size and style of N95 respirator is suitable for an individual, and to train the healthcare worker on how to don and doff N95 respirator. So fit testing should be performed at the commencement of employment at areas of high risk for airborne infection and at a regular interval annually as recommended by the National Institute of Occupational Safety and the Health. So types of fit tests are qualitative fit test and the quantitative fit test. There are 3 approved quantitative fit tests, which are control negative pressure method, laboratory test chamber method, ambient aerosol condensation nuclei counter method, which is the most common method. Next comes to apron and the gown. These are the protective clothing such as apron or gown, which are routinely used upon entering the room of the patient, requiring the contact precaution and also during the sterile aseptic procedure. They should be worn by the healthcare worker when there is a contact with the patient, materials or equipment which may lead to contamination of skin, uniform or the other clothing with the infectious agent. Or if there is a risk of contamination with blood and body substances and any secretion or excretion is also there, then it should be worn. So coming to the apron, single-use plastic apron are recommended for the general use when there is a possibility of spray or spill to protect the clothes that cannot be taken off. And once the task is performed, they must be removed immediately after use by tearing the neck strap and waist tie and gently rolling it inwards to minimize the contamination of microorganism during the disposal. And here donning and doffing of gown is seen. Here the gown are used to protect the healthcare worker exposed body area and to prevent contamination of clothing with the body substances and other potentially infectious materials. And for donning, the gown should be fully covered, torso from neck to knee, arms to end of the wrist, and then wrapped around the neck. It should be fastened back to neck and the waist. And once the task is performed, the gown must be removed immediately after use by unfastening the gown ties, and then the gown is pulled away from the shoulder and the neck, and then the gown is turned inside out and folded and rolled into an appropriate waste bin, and finally hand hygiene should be performed. So here different types of gown and their uses are depicted. So plastic apron is disposable and fluid resistant, and it is used for single use only, and it should be worn when there is a risk of exposure to blood or body fluid, and also during the contact precaution. And gowns are also for single use and disposable and worn to prevent the soiling of the clothing during procedure or patient care activities that are likely to generate splashing or spraying of body or the body fluids. And full body gown is a fluid resistant and for single use and worn when there is a risk of contact of the healthcare worker's skin with the patient broken skin, and also when there is a risk of exposure to large amount of body substance. Then comes the protective eye or the face wear. So protective eye wear such as glasses, goggles or face shield are used to protect the mucous membrane of the eyes, nose and the mouth, and it prevents the exposure of the blood and or body fluid that may be splashed, sprayed or splattered into the face during the clinical procedure. And eye wear must be worn during the procedure that are likely to generate droplets or aerosol of the blood or high risk body fluids. Now coming to the sequence of donning and doffing of PPE, the purpose of PPE use can be fulfilled only when they are worn in a correct sequence. That is, donning and removing in the correct sequence, that is doffing, and proper steps are followed for each of the PPE while the donning and the doffing. The Center of Disease Control and Prevention recommended sequence of donning and doffing have been described as. So for donning, first hand hygiene should be performed, following by the wearing gown, mask or respirator, goggles or face shield, and at last gloves. And for doffing, first glove should be removed, followed by goggles or face shield, gown, mask or respirator, and after doffing, hand hygiene should be performed. So where to remove PPE? So the location of removing the PPE will depend on the amount and type of the PPE worn and the category of isolation precaution a patient is on. And if only gloves are worn as PPE, it is safe to remove and discard them in the patient room only. And when a gown or a full PPE is worn, the PPE should be removed at the doorway or in an anteroom. And if respirator is worn, then it should be always be removed outside the patient room and when the door is closed. And hand hygiene should be performed for all the PPE when all the PPE is removed. So coming to the disposal of PPE. So goggles, face shield, splash-proof apron, plastic coverall, gloves should be discarded in foot-operated red bins. And mask, whether triple layer surgical mask or N95 mask, head cover, shoe cover, disposable linen gown, non-plastic cover, all should be discarded in the yellow bin. So PPE used in the healthcare setting, the final thoughts. There are few final thoughts before ending today's presentation. Remember, PPE is available to protect us from the exposure of infectious agent during the healthcare. So it is important that we should know what type of PPE is necessary for us and any procedure we perform, and also what we are using in a correct way. So thank you for your attention.
audio friends, kindly check the audio, please. Audio, it is not properly coming. Audio friends.
Thank you, Dr. Neha, for your excellent presentation. Now I invite Dr. Bushra to give her lecture on isolation and contact precautions. Any doubts regarding PPE? Because in recent time of COVID, I think you are all aware of this, how to use the personal protective equipment, how to don and doff. It's a very important part of your standard precautions. I think all are aware of it, and if you have any doubts, we are ready to take the questions. And you also can give your own experiences of how is it continuously available at your work site, or do you face difficulties, that kind of things. Yeah, usually we need to based on international standard guidelines, we need to have a protocol to have the quality of the PPE. There are guidelines in the literature which we have gone through. Probably we may show you even if necessary at the end of the sessions. Like based on those guidelines, we try to verify, and then we have produced to our surgical stores what is the quality of the fabric that you need to use them, and there are certain specifications for it especially. So usually surgical stores will take care of all these kind of things exactly, and but it's the microbiologist finally who has to suggest what kind of quality of fabric you need to use, especially during the procedures when you are using this PPE. Yes, yes. Yeah, the quality has to be assessed definitely. It's not that all kind of things we cannot use. We need to assess the quality, check it, and then use the PPE. Usually, a hospital infection control committee should be there in place. So the committee should be given these kind of questions. Like then there will be a need or a discussion committee meetings will be held. What to do? These kind of things can be brought into limelight. Thank you. Yes, sir. Can it be replaced with cloth gown? Fabric gown. So is it, you are saying that it's difficult to get the PPE? Can you repeat, sir?
No.
Yes. Okay, you say that kind of. No, but I think it's compulsory, sir, to have the PPE because it should be impervious, one thing. But without that, how can you, you cannot go without that.
No, during the routine surgeries also,
Yes.
is it mandatory that you need to use the PPE kit?
Definitely, sir. Definitely. It's mandatory.
When the surgery lasts for 3 to 4 hours like that.
As per the guidelines which we have gone through and which latest we have presented the lectures, it's important to have PPE, sir, even during surgeries, which will help to avoid transmit the infections.
Or is it recommended that you use the PPE kit where aerosolization is more, or during the intubation, or otherwise at the tracheostomy, or an airway surgeries have been done, or otherwise also, like if you are operating on an ear, do we need to use the PPE kit?
Sir, anywhere, wherever you're performing the surgeries, standard precautions should be followed as per the hospital infection policies and procedures, sir.
Okay, thank you.
Thank you. Which one, sir? Yes, yes. Over a period of time, even at NIMS, there was a scarcity for PPE equipment, but in a slow process, all these supplies were replaced in a correct way, and so we were able to use it. Pardon? Sure. Every surgery, they are using the PPE. Yes. Yes. Fine. Yeah. Yeah, this problem was there, but still we need to try at least with certain standard precautions at that point of time with limited resources. That's the only way how we can correct ourselves at that point of time. Yes. Fine. Yeah, these kind of things can be represented. Yeah, sure. Supplies are not there. Okay. Fine. Yeah. Fine. That's the reason why we need to have a constant awareness of these kind of educational things, which will help to repeatedly come into picture and at least make us the provision of these things in a slow run. Yes. Sure. Fine. Thank you. I request Dr. Bushra to continue her lecture.
Good afternoon, everyone. I'm Dr. Bushra, Senior Resident. Today I'm going to highlight on the isolation and contact precautions. So since the start of this day, you'll be like well versed with the words like hand hygiene, personal protective equipment and all. So we'll be dealing with the common words, but we have to look to in what situation we are following this. So I need you to follow in what situation we are following all these things. So what is the definition of isolation precautions? So these are the special precautionary measures, practices and procedures which are used in the care of patients with a contagious or communicable diseases. So what are the isolation precautions to be followed? So it comes like hand hygiene, personal protective equipment, the routine and terminal cleaning, patient care equipment and articles, linen and laundry, and patient transport and patient placement. So all these things will be dealt further. So what are the type of isolation precautions? We are having standard precautions, and the one is called as transmission-based precautions. So in the transmission-based precautions, we are having contact, airborne, and droplet precautions. So what are standard precautions? So previously, it is called as universal precautions. So it was recommended in 1987 to be followed to the healthcare workers when you are dealing with the bloodborne pathogens. But in 1996, it was this concept has been expanded to say it as standard precautions, but not the universal precautions. So it is intended to prevent the transmission of the common infectious agents to the healthcare personnel, even to patients and visitors in healthcare settings. So coming to definition of standard precautions, it applies to all patients receiving care in the hospitals regardless of their diagnosis or presumed infectious status. So in this scenario, we are considering each and every secretion of the patient as infectious, and we need to follow as standard precautions. So because any patient's blood is infectious, his body fluids, secretions, and except sweat, and when there is a non-intact skin, and when there is exposure with the mucous membrane. So all the standard precautions, it recommends the use of PPE. So standard precaution, it needs what? And hand hygiene. Since the start of the lecture, we are well versed with this hand hygiene. So it need to be followed as a standard precaution, I say, because either the plain or antiseptic containing soap and water and use of alcohol-based products can be that do not require water should be followed as a standard precaution, hand hygiene. So we need to follow where? So before and after touching a patient contact, and After removing the gloves or any PP, and after touching the blood, body fluids, secretions, and contaminated items. So coming to PP, so the selection of PP, if you want to go as a standard precaution, you need to keep in mind to what kind of patient you are interacting with and the likely modes of transmission. And if you are following PP, you also be keep in mind that there is a designated bin for a proper PP. So coming to gloves, so gloves are used whenever you see there is a risk of that I may touch the blood which is infectious. So you need to wear gloves. And the gloves should be changed when it is heavily contaminated, and we need to perform hand hygiene before and after the removal of the gloves. And disposable gloves should not be used, reused, okay? So gowns, whenever there is a risk of splashes or sprays which are contaminated, so you need to go with the gown so that our working clothes are not infected with this infectious material. So coming to mask and eye protection, so again, whenever the splashes or sprays of body fluids you are exposed to, you need to go with the mask and eye protection. And yeah, I want to highlight one point here. Whenever you're into a sterile technique, wherever you're inserting a catheter like that, you need to follow PP, that too most importantly mask, because an healthcare personnel may be in harboring any infectious pathogen in the nasopharyngeal. So we don't want a patient is getting affected from us. So we don't want any infection from the healthcare workers to patient, okay? So whenever there is a patient with a likely mode of transmission with a droplet transmission to us, so in that case is also we need to go with the PP. So standard precautions even include the safe injection practices. We need to keep in mind that we should protect ourselves from the needles and other sharp instruments, and to prevent ourselves that any infectious material is falling onto our mucous membrane. And so safe injection practices has been dealt previously. So I want you to follow it as a standard precaution. So coming to environmental measures, so we need to clean and disinfect all the non-critical surfaces in the patient care area, and the frequently touched surfaces in the patient care areas. So what all the disinfectants you want to use, you can go with this Environmental Protection Agency, where all the registered disinfectants and detergents are mentioned. So the coming to the patient's equipment, so we need to clean and maintain the each and every medical equipment and instruments which are going according to the manufacturer instructions. Coming to textile and laundry, so whatever the laundry you have collected from the patient care, so make sure that you don't shake the items or handle them in any way, because it may aerosolize the infectious agent. So we need to even avoid contact with one's body and personal clothing, and we need to keep all the soiled elements in a designated bin. So this is a 2007 guidelines for the isolation precautions. Apart from all these things, what are 3 new elements which are added to the standard precautions? That is respiratory hygiene or the cough etiquette, and safe injection practices and use of mask for the insertion of the catheters, central lines, or whenever you are going and injecting and drug into the spinal or epidural areas. So these are the 3 new elements we need to be followed as a standard precaution. So what do you mean by respiratory hygiene, where you need to follow? So 3 elements in it are, so we need to educate the healthcare workers, patients and visitors, and we need to post signs in appropriate languages, and the very important thing is source control measures. So what is source control measures in a respiratory hygiene is, we need to cover the nose and mouth whenever somebody is coughing or sneezing, or use a tissue paper when nothing is available, and you need to dispose of the tissue in a proper bin, and we need to do a hand hygiene. And we can recommend placing a surgical mask onto the person who is coughing. And we need to keep a spatial separation ideally of more than 3 feet. So these are the elements which comes under the respiratory hygiene. So as I told you, safe injection practices. So one thing is that, which was highlighted since morning, is reinsertion of used needles into a multiple dose vial or solution container like a saline bag. So we see this commonly practiced where we keep on injecting the injections into a saline bag. So that should be avoided. And use of single needle to administer the intravenous medication to multiple patients. So these are the safe injection practices which is followed as standard precaution. So as I told you from the starting, like we need to use mask for the special lumbar punctures. Because the face mask will limit the dispersal of the oropharyngeal droplets during the central venous catheter placement and placement of catheter or injection into a epidural space. So coming to water transmission based precautions, these are the precautions which are added along with the standard precautions which is need to be followed when a suspected patient is having an infection or colonization with the epidemiologically important pathogens like MRSA, VRE and MDROs. So what are three elements in the transmission? There should be a source of the infectious agent, there should be a susceptible host with the portal of entry, and there is a mode of transmission of the agent. So what are the three basic routes of transmission? I say it's the contact, droplet and airborne. I'll be dealing with the contact. There are other modes of transmission. There is a vector borne, and the common environmental sources or vehicles includes foodborne even or waterborne and medications like with contaminated IV fluids. So coming to contact precautions, here it may be through the direct contact or indirect contact. So the name only indicates direct means direct contact with the surface, body surface to the other surface. There is a physical transfer of microorganisms from an susceptible host and an infected organism, infected person. So coming to indirect contact, where contact of a susceptible host with the contaminated intermediate objects, like when there is a contaminated instruments and needles or dressings. So this is what happened recently. So I need to you to follow this contact transmission to be keep in mind. So what are the precautions? So we said this is a contact bone transmission is there with the organisms. So in what scenarios this to be followed? So whenever you see gastrointestinal cases, whenever the patient is having any respiratory infections, skin and wound infections with profuse discharges, and whenever is person said to be colonized with the multiple drug-resistant bacteria. So what are the contact precautions to be followed? It applies even when there is an excessive wound drainage, uncontrolled secretions, and pressure ulcers, back draining body fluids, and fecal incontinence, which is mostly overlooked, fecal incontinence or other discharges from the body. So it suggests an increased potential for extensive and environmental contamination, and there is a risk of transmission of infected organism to the host. So these are the specific agents and the circumstances, like the MDROs, like MRSA, that is methicillin resistant Staph aureus, vancomycin resistant enterococci, and the vancomycin intermediate and resistant Staph aureus, and extended spectrum beta lactamases. So these are in boom, where you need to follow the contact precautions. So the other infectious agents are there. You can go through this later. So mostly this is a list where you need to follow the contact precautions. So what are the precautions you're going with this kind of patient? So you are told that your patient is infected or colonized with an MDRO. So what should come into your mind? These are all the precautions. So you need to keep a patient singly in a single patient room is preferred usually. But most of the times it is not possible, I know, where you can do a cohorting of the patient with the same organism, but not with the different MDROs. Why? So we can place a patient colonized with an MRSA but not with MRSA with VRE, because there is a chance of that a vancomycin resistant enterococci can transfer its vancomycin resistant genes to Staph aureus. So there you land up again treating the both colonization together. So you need to keep in mind that cohorting of the patients with the same infection is followed, but not with the different MDROs. So you're not even having the cohorting option. What are you going to do? So I need to discuss with the infection control personnel, knowing the risk and risk assessment. So where you're keeping your infected patient with the normal people or non-colonized patients. So in conditions where you're going with this, where the roommate has no immunosuppression or broken skin or an underwent surgery or indwelling lines or renal failure, or when the patient is not having any draining wound. And the special to keep in mind, if your infected patient is having VRE or MDR GNB, means MDROs, that patient should not have any fecal incontinence. Why? Can anybody tell me? The patient with VRE or MDR GNB should not stay in a room with if he is having a fecal or urinary incontinence, because there is a chance of environmental contamination we need to look for. Okay. So coming where there is a multiple patient sharing rooms, so in this unavoidable situations, there should be more than 3 feet spatial separation between the bed is advised, and the curtains between the beds. So as I told, even the contact precaution need an hand hygiene and the gloves. So whenever you are in contact with your patient, you need to follow the hand hygiene and gloves whenever you see any infectious material. Coming to gown, you need whenever you are entering a room where you are separated patient with the contact precautions, you need to keep in mind that you need to wear gown. If there is a possible thing that your clothes are may get contaminated with the patient things, you can use a gown. Coming to patient transport, you need to take your patient somewhere, the patient who is colonized. So in that cases, you need to limit the patient transport only to medically important purposes. And when you know that patient is infected, you need to cover the area which is having an excess chance of transmission to others. And we need to perform even hand hygiene before taking that patient. And we need to wear a proper don a clean PP to handle the patient to the transport. So coming to patient care equipment, where you need to, according to standard precautions. So here we say use a dedicated equipment. What do you call dedicated equipment? So you need to have a separate stethoscope, separate blood pressure cuff to each and every patient. So most of the time it is not possible. What you can do, an alternative is that you can use and disinfect that equipment before using to the other patient. Environmental measures, as I said, these need to be looked after where there is a frequent high touch areas like door knobs, bed rails, bedside tables, commodes, and lavatory surfaces, and blood pressure cuffs and equipment surfaces. So these are the special areas we need to go with. The environmental measures are handling bedpans, flushing of toilets, cleanup of the spillage, and specimens handling. So here you need to differentiate between detergents and disinfectants. So whenever your things are visibly with an organic material, then you need to go with a detergent. Next, after that, you can use a disinfectant to kill the infectious agent. So this is the stopboard telling that visitors that they need to report to a nurse station before they are entering into a patient who are colonized with this MDROs and all. They need to get instructions that what are the possible sources of transmission. There they have to go again. Even the visitors has to be told that they need to wear a proper PPE. So an important thing regarding the Clostridium difficile diarrhea, where you need to clean with an sporicidal agent, usually bleach. So coming to discontinuation, so you have isolated the patient, you have followed all the precautionary measures. So when you are going to stop it, so it is usually recommended according to the pathogen specific recommendation we see. So where we need to follow the natural disease status of the disease. Whenever you feel that the patient infecting with certain infection, so he is no more transmitting the infectious organism, there you can discontinue. So this hospital healthcare infection control practice advisory committee says that even though you follow all these contact precautions, it is undefined, but generally we can reasonably can discontinue these precautions In a patient with MDRO, where you can stop it, like is whenever the patient has not received an antimicrobial therapy for several weeks, especially when when the patient is not having any draining wound or profuse secretions, and when there is no evidence of transmission from that patient to others, so he's no longer like transmitting, is not that infectious, you can discontinue. And when there are 3 or more surveillance cultures regarding for the target MDRO is negative, or 2 cultures may be negative when they have taken a proper antibiotic course. So for most of the infections, the duration, I said, you need to follow the natural history of that infectious process. But in some diseases like where you're dealing with the pharyngeal or the cutaneous diphtheria, so their culture as well as their antigen test should be negative. But in case of respiratory syncytial virus, it is enough that he is symptomatically resolved. So for the other diseases, like if you're dealing with a TB patient, there you need to again refer to the state laws and regulations and healthcare facility policies. But in a situation where you call the immunocompromised patients, where the viral shedding persists for prolonged periods of time, like even it may take weeks, months or years. So here the transmission may occur during that time. Here the duration of contact precautions is prolonged. So only in cases where the patient is immunocompromised, the contact precautions to be followed long. Thank you. So can we have some questions? If you wear gloves while providing care, hand hygiene is not required. Why? Because the gloves do not provide 100% protection. So this one, if your infection control department tells you that a patient can be managed using routine practices, he just told routine practices, what does that mean? Is it A, B or C? I can't read out options, even I am hungry. Sorry for being late. So it's the answer C, where you need to assess the risk and then follow. If your hands are visibly soiled, hand hygiene using alcohol-based hand rub is preferred method. Why? Because alcohol-based hand rub cannot penetrate the dirt to kill the organisms. Hand must be clean of visible soil and organisms by soap and water. So again, which of the following is not considered a portal of entry for the bacteria? Not. And why others? Why others? What is the important thing to be mentioned? Sorry? Because there is an exposure with the mucous membrane. MRSA and other multi-drug resistant organisms can be transmitted by all of the above. If there is no sign on the patient's door or chart indicating that the patient is on additional precautions, where most of the thing is a common situation, then PP is never required when providing care. Because a risk assessment must be done before providing care, and PP worn as an appropriate for the risk and the care being provided, because it comes under a standard precaution. So we are considering in mind that each and every patient, even we are also a source of transmission to others. So now you're working on a Friday night and several patients became symptomatic with vomiting and diarrhea. You should C. A, B or C? Oh, we are giving, yes, A. So that's why hand hygiene is given the importance, the premost importance to overcome all these problems. So contact precautions does not include. Contact precaution does not include all of the above, because we did not go with the N95, where you can use for the surgical mask, and we did not go with the negative pressure rooms. So standard precautions include? Yes, you are alert. What 3 elements are needed for an healthcare associated infection to occur? Yes, it's A. So standard precautions are work practices required for the basic level of infection control. Which of the following do they apply to? Yeah, all patients regardless of their infection. Cohort isolation means what? Cohorting. Yeah, it's A. When are additional transmission precautions are required? Additional. Yes, it's C. Sorry, it's B. When standard precautions alone are not sufficient to prevent the transmission infectious disease. So, thank you.
Thank you, Dr. Bushra, for your excellent presentation and good questions. Sir, shall we break for lunch, or one topic is there for this session, sir? Or can we continue and go for lunch?
Just 20 minutes?
Droplet precautions is left over for this session. It's 20 minutes. Even audience can tell us whether we can continue. It's your interest. We can disperse for lunch otherwise. Lunch. If majority are preferring lunch, we'll disperse here.
Yeah, before we disperse for lunch, I think majority are opting for lunch, I think. So,
yeah.
So one comment actually what I would like to make is, ఇంతకుముందు మంత్రి గారు వచ్చి చెప్పినప్పుడు మీ అందరిని పిలిచింది the two names were given to you. One is infection control officer and other infection control nurse. అంటే ఇది ఒక నామకరణం చేయడం జరిగింది. ఎందుకు చేసామంటే మీకు రెస్పాన్సిబిలిటీ ఇద్దామని చెప్పేసి. ఎందుకంటే హాస్పిటల్కి వెళ్తే మెడికల్ సూపరింటెండెంట్ ఉంటారు, లేకుంటే ఆర్ఎంఓ ఉంటారు, బట్ దెర్ ఇస్ నో టర్మ్ కాల్డ్ యాజ్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్ ఆర్ ఇన్ఫెక్షన్ కంట్రోల్ నర్స్. అంటే ఒక ప్రత్యేకమైన బాధ్యత అప్పగించే ముందు ఒక ప్రత్యేకమైన నేమ్ ఇచ్చేసి, ఆ నేమ్కి ఒక ప్రత్యేకత ఏంటంటే ఈ ఇన్ఫెక్షన్ కంట్రోల్ మీరు నేర్చుకున్నది కొత్తగా ఏం కాదు. ఐఎమ్ సీయింగ్ లాట్ ఆఫ్ పీపుల్ హూ ఆర్ సీనియర్ టు అస్, హూ ఆర్ సీనియర్ టు దెమ్, హూ ఆర్ స్పీకర్స్ ఆల్సో. Speakers, what they have done is actually they excellently put up the topic in a nice way and trying to reorient. మంత్రి గారు చెప్పారు కొత్తగా ఇచ్చేది ఏంటంటే రీఓరియంటేషన్ చేస్తున్నారు. సో ఆ రీఓరియంటేషన్ తీసుకొని ఫర్దర్ మోర్ సింప్లిఫై చేసి ఇంప్లిమెంటబుల్గా, అంటే మనం చేయాలి, ఇంప్లిమెంట్ చేయడానికి వీలుగా ఉన్నటువంటి సింప్లిఫై చేసేసి మనం మళ్ళీ తమ హాస్పిటల్కి వెళ్ళిన తర్వాత దీన్ని ఇంప్లిమెంట్ చేసే విధంగా ఎలా తీసుకెళ్ళాలనేది డిస్కషన్ ఇదంతా. అంటే అన్ని టాపిక్స్ అయిన తర్వాత, రేపు అయిపోయిన తర్వాత యూ ఆల్సో ఫైండ్ హౌ బెస్ట్ వీ కెన్ ఇంప్లిమెంట్ దిస్ ఇన్ అవర్ ఓన్ హాస్పిటల్స్. అంటే ఎందుకు వచ్చిందంటే ఇది ఉంది అంతకుముందే, కానీ రీసెంట్లీ వీ హ్యాడ్ సమ్ ఇన్సిడెంట్స్ ఇన్ ది గవర్నమెంట్ వేర్ యాక్చువల్లీ ఇట్ evoked a response from the government to conduct this sort of a reorientation programs, specifically focusing on the infection control practices. మా నిమ్స్లో కూడా ఉంది పద్మజ గారు ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్. రీసెంట్గా నేను మా డయాలసిస్ యూనిట్కి నేను కూడా పిలిపించాను. ఐఎమ్ నాట్ ఓన్లీ ది ఓఎస్డి టు సీఎం, బట్ ఐఎమ్ ఆల్సో హెడ్ ఆఫ్ ది డిపార్ట్మెంట్ ఆఫ్ నెఫ్రాలజీ హియర్. నేను వారిని పిలిచాను, మా డాక్టర్ని కూర్చోబెట్టాను, మా నర్సెస్ని కూర్చోబెట్టాను, మా డిపార్ట్మెంట్ మొత్తం కూడా షీ ఆడిటెడ్ అస్ థర్డ్ పార్టీగా. ఎందుకంటే నాకు నేనుగా నేను చూసుకోలేను, ఒక్కోసారి థర్డ్ పార్టీగా ఆడ వచ్చారు. షీ విజిటెడ్ ఆల్ మై డయాలసిస్ యూనిట్, ఐసీయూ వార్డ్స్, చూసి ఇక్కడిక్కడ ప్రాబ్లం ఉంది సార్, ఇవన్నీ చేస్తే బెటర్ అని చెప్పి షీ గివెన్ ఇన్ రైటింగ్ టు మీ. So that actually I am trying to implement those recommendations given by infection control officer, who is Dr. Padmaja here, and also she came along with the nurse. So when she came here, when she came to my department, I called my all faculty there and also my nurses and technicians there. We had a meeting and we are trying to implement this. Same thing is expected from you all who are listening to these lectures. You should go back and take the area wise, theatre wise కావచ్చు, ఐసీయూ వైజ్ కావచ్చు, మీ సిఎస్ఎస్సి కావచ్చు, ఇంకెక్కడైతే మనం పేషెంట్ కేర్తో టచ్లో వచ్చే అవకాశం ఉంటుందో అన్నిటి కూడాను మీరు అసెస్ చేయండి, గ్యాప్ అనాలిసిస్ చేయండి, చేసి కమ్అట్ విత్ ఇన్స్టిట్యూట్ స్పెసిఫిక్ ప్రోటోకాల్స్. దాని అన్ని కూడా దీని కాస్ట్తో ఇన్వాల్వ్ అయింది. మ్యాన్ పవర్ కావాలి, కాస్ట్ డబ్బు కూడా కావాల్సి వస్తుంది వీటన్నిటికీ. వాట్ ఎవర్ వీఆర్ టెలింగ్ ఇట్ ఇన్వాల్వ్స్ మనీ. దట్ ఆల్సో ఐ థింక్ హానరబుల్ మినిస్టర్ ఆల్రెడీ చెప్పారు. దానికి కావాల్సిన ఎక్విప్మెంట్స్ కానీ, ఇప్పుడు నా ఎగ్జాంపుల్ డయాలసిస్ నుంచి చెప్తాను. వీఆర్ డూయింగ్ 500 డయాలసిస్ పర్ డే. ఇనీషియల్గా నేను పీజీ ఉన్నప్పుడు డయాలైజరు, ట్యూబింగు దాన్ని రోజు కడిగి మళ్ళీ నెక్స్ట్ ఆ పేషెంట్ నెక్స్ట్ డే వచ్చినప్పుడు వాడేవాళ్ళం. కానీ అది హ్యూమన్లీ ఇంపాసిబుల్ అని తెలిసిపోయింది అది. సో మేము ఏం చేసాం, రికమెండేషను ఇది డిస్పోజ్ చేద్దామని డిసైడ్ చేసాం. నో పాయింటింగ్ రీయూజింగ్ ద డయాలైజర్ అండ్ ట్యూబింగ్. ఇఫ్ ఇట్ ఆల్ హై వాల్యూమ్ సెంటర్ లైక్ నిమ్స్ టు డూ, we written a letter, we took the government permission, and we have come with a no reuse policy in dialysis now. With that, we are able to reduce the hepatitis B, hepatitis C infections, HIV infection తగ్గించగలిగాం. అలాంటి రికమెండేషన్ కూడా మీరు కన్సర్న్ డిపార్ట్మెంట్స్తో మాట్లాడి అది కూడా ఇవాల్వ్ చేయొచ్చు. దానికి కొంచెం కాస్ట్ పెరుగుతుంది, బట్ యూ కెన్ ఈజీలీ కన్విన్స్ ది గవర్నమెంట్ ఇఫ్ ఇట్ ఆల్ యూ ఆర్ ట్రయింగ్ టు యూజ్ దట్ పాలసీ. లైక్ క్యాత్ ల్యాబ్, న్యూరో సర్జరీ, మన ఇప్పుడు సార్ కూర్చున్నారు ఇక్కడ, సో వారు కూడా ఈ కెన్ కమ్అట్ విత్ వన్ రికమెండ్, విజయసారథి గారు, ఈ కెన్ కమ్అట్ విత్ రికమెండేషన్ వేర్ రీయూజ్ ఈజ్ నాట్ రికమెండెడ్. అలాంటిది కొంచెం కాస్ట్ పెరిగితే అలాంటి నో రీయూజ్ పాలసీ కూడా తీసుకురావచ్చు, తప్పేం లేదు. ఎందుకంటే ఇన్ఫెక్షన్ వచ్చిన తర్వాత ట్రీట్మెంట్ ఇస్తే 30-40 వేలు ఖర్చు అవుతుంది. దాంతో ఖర్చుతో పాటు మార్టాలిటీ ఉంటుంది, మార్బిడిటీ కూడా ఉంటుంది. దానికన్నా ఎక్కువ ఇఫ్ ఇట్ ఆల్ వీ టేక్ సమ్ ప్రికాషన్స్ బిఫోర్, దట్ ఈస్ మచ్ బెటర్. సో అలాంటి రికమెండేషన్స్ కూడా మీరు కన్సర్న్ డిపార్ట్మెంట్స్తో మాట్లాడి మీరు ఇవాల్వ్ చేయొచ్చు. సో వీఆర్ ఎంపవరింగ్, గవర్నమెంట్ ఈజ్ ఎంపవరింగ్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్స్ అండ్ ఇన్ఫెక్షన్ కంట్రోల్ నర్సెస్. ముందు డిస్కస్ చేసినప్పుడు అందరు టీచింగ్ హాస్పిటల్ పిలిపించి ఒక మీటింగ్ పెట్టి వదిలేద్దాం అంటే, బట్ వాళ్ళకి నామకరణం చేయకుండా ఎట్లా? ఇప్పుడు నాకు పేరు ఉంది, నాకు డెసిగ్నేషన్ ఉంది, కాబట్టి నేను మాట్లాడగలుగుతున్నాను మీతో. మీకు కూడా ఒక పేరు ఉంది, నా ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్ కానీ ఇన్ఫెక్షన్ నర్స్ కానీ, దానికి హోదా ఉంది, మీరు ఆ కమిటీలో మెంబర్స్ ఉంటారు, మీరు డెఫినెట్గా మీరు ఇచ్చే రికమెండేషన్స్కి వాల్యూ ఉంటుంది. ఆ వాల్యూను డెఫినెట్గా వీ ట్రై టు మీట్ ది బడ్జెట్ ఆల్సో. మీరు నర్స్, ఇన్ఫెక్షన్ నర్స్ కంట్రోల్ నర్స్గా నాకు ఇంత పీపీ కిట్స్ కావాలి, ఇంత బ్లీచ్ కావాలి, ఇంత స్టెరీలియం కావాలని మీరు రికమెండేషన్ ఇవ్వండి. డెఫినెట్లీ విల్ ట్రై టు మీట్ ఫ్రమ్ ది బడ్జెట్. బడ్జెట్కి ప్రాబ్లం లేదు. ఓన్లీ థింగ్ రిక్వైర్మెంట్ హ్యాస్ టు కమ్ ఇన్ అ ప్రాపర్ ఫ్యాషన్ సో దట్ వీ కెన్ కన్సాలిడేట్ అండ్ గివ్ దట్ బడ్జెట్ టు యూ. సో వీటన్నిటి కూడాను, అండ్ చాలాసార్లు దే ఆర్ వెరీ ఇంటరాక్టివ్ ఇన్ నేచర్. నేను కూర్చొని విన్నాను, ఎందుకంటే చాలాసార్లు క్వశ్చన్లు అడుగుతున్నారు, క్వశ్చన్స్కి ఆన్సర్ మీరు బాగా ఇంటరాక్ట్ అవుతున్నారు. ఇది ఓన్లీ కాన్ఫరెన్స్ కాదు, ఇది ఇట్స్ అ ట్రైనింగ్ సెషన్. ఎనీ టైమ్ యూ కెన్ స్టాప్ అండ్ ఆస్క్ దెమ్ క్వశ్చన్స్ ఎనీ టైమ్. మీరు అందరూ చాలామంది సీనియర్స్ ఉన్నారు, వాళ్ళకన్నా మైక్రోబయాలజీ హెడ్ ఆఫ్ ది డిపార్ట్మెంట్స్ ఉన్నారు, కొంతమంది అనస్థీషియా ప్రొఫెసర్ అండ్ హెచ్ఓడీస్ ఉన్నారు. సో యూర్ ఆల్ ఎంపవర్డ్ టు ఆస్క్ దెమ్. ఇఫ్ ఇట్ ఆల్ యూ హ్యావ్ ఎనీ ఎక్స్పీరియన్స్ ఆఫ్ యువర్ ఓన్, ప్లీజ్ షేర్, బికాజ్ ఇట్స్ ఏ గ్రూప్ డిస్కషన్ దట్ వీ వుడ్ లైక్ టు హ్యావ్. అండ్ ఆఫ్టర్ దిస్ అన్ని లెక్చర్స్ కూడా మీకు డెఫినెట్గా పీపీటీస్ కానీ వీడియో కానీ వీఆర్ ట్రైంగ్ టు మేక్ సేమ్ యాజ్ అ వీడియో అండ్ గివ్ ఇట్ టు యూ. పీపీటీ నౌ యూట్యూబ్ లింక్ వస్తుంది, దాని తర్వాత మొత్తం కూడా డిజిటల్ అయిన తర్వాత మీకు డిజిటల్ ఇన్ఫర్మేషన్ ఆల్సో విల్ గివెన్ టు యూ, ఆల్ ఆఫ్ యూ. It will be hosted on a website where you can view anytime, and also will be given a handout. If required, we'll also make in a pen drive and give it to you, or link, YouTube link ichestamu that you can train your student. Once you go back, you should train your staff again. Nurses train cheyali, doctors train cheyali, doctors for different category andariki training ivvali. Ee training anadi continuous ga jaragali. జరిగినప్పుడు ఏంటంటే ఇన్ఫెక్షన్ కంట్రోల్ బాగా జరిగితే హెల్త్ కేర్ కాస్ట్ తగ్గుతుంది, మనం పేషెంట్ మీద పెట్టే ఖర్చు అనేది తగ్గుతుంది, హాస్పిటల్ స్టేస్ తగ్గించచ్చు, దాన్ని పెట్టే ప్రతి పేషెంట్ మీద పెట్టే ఖర్చు తగ్గొచ్చు, మార్టాలిటీ మార్బిడిటీ తగ్గించే అవకాశం ఉంటుంది. సో చాలా ముఖ్యమైన ప్రోగ్రామ్. దానికోసమే మంత్రి గారు ఈ చిన్న ప్రోగ్రామ్కి ఎందుకు వస్తారని అనుకున్నారు ముందు, కానీ మంత్రి గారికి ఈ ప్రోగ్రామ్ ఇంపార్టెన్స్ చెప్పిన తర్వాత డెఫినెట్గా మంత్రి గారు అనుకున్నారు, డెఫినెట్లీ ఐ షుడ్ కమ్ అండ్ గివ్ దట్ ఇంపార్టెన్స్ టు దిస్ ప్రోగ్రామ్. That's why, though it's not a big opening or anything, still Honorable Minister came to this program to emphasize how much concern he or government is for this infection control practices. So వీటన్నిటి కూడాను డెఫినెట్గా మనము ఇంటరాక్టివ్ వేలో, ఇది 1/2 day అయిపోయింది, ఇప్పుడు లంచ్కి బ్రేక్ కావచ్చు. సో ఆఫ్టర్ దట్ ఆల్సో వాట్ ఆర్ ది లెక్చర్స్ ఆర్ దేర్ అవర్ ఓన్ పీపుల్, వీ కెన్ ఇంటరాక్ట్ mutually. If at all you want to give suggestions also, please be proactive in all the lectures which are being given. And we'll continue till tomorrow. So మధ్యలో ఇంటరాక్ట్ అయిదాము. ఆఫ్టర్ దట్ ఆల్సో ఇన్ఫెక్షన్ కంట్రోల్ ప్రాక్టీస్ చేయడానికి హాస్పిటల్కి ఒక బడ్జెట్ అవసరం పడుతుంది, అది కూడా హాస్పిటల్ వారికి ట్రై టు ఇవాల్వ్. డ్రగ్ బడ్జెట్ ఎట్లుంటుందో, సర్జికల్ బడ్జెట్ ఎట్లుంటుందో, ఇన్ఫెక్షన్ కంట్రోల్ ప్రాక్టీసెస్ కావాల్సిన బడ్జెట్ కూడా ఇవాల్వ్ అవుతే డైరెక్ట్గా మంత్రి గారికి చెప్పి దాన్ని కూడా మనం విల్ ట్రై టు ఇంప్లిమెంట్ దట్ ఆల్సో. సో దిస్ is purely a practical session that we are trying to conduct, so that this sort of a program can be conducted in your own hospitals and by the way across the state also. So ee comments toti endante we can make with lunch, and we appreciate all the effort which is put by Dr. Padmaja and his team and microbiology department for their continuous, and Teja sir unnaro ledo kanabatledu, Teja sir was there, so he was also very instrumental in the entire microbiology department, hospital administration department of NIMS has taken, because 1 week back ee program anukoni idem pedda pre planned kaadu, idi వారం కింద మంత్రి గారు చెప్పారు, వెంటనే ఇది ఆర్గనైజ్ చేసి మన అందరం ట్రైనింగ్ ఇద్దాము, మనం ఇన్ఫెక్షన్ కంట్రోల్ ప్రాక్టీస్ రాష్ట్ర వ్యాప్తంగా పెడదామంటే వెంటనే దే ఆస్క్ నిమ్స్ టు కండక్ట్. వెంటనే మనం నిమ్స్ అడ్మినిస్ట్రేషన్ కాంటాక్ట్ చేయడం జరిగింది. తర్వాత మైక్రోబాలజీ డిపార్ట్మెంట్ కాంటాక్ట్, దే ఆర్ ఇవాల్వ్ విత్ గుడ్ లెక్చర్స్. ఇది ఫర్దర్గా కూడా ఇంప్లిమెంట్ చేద్దామన్నారు. ఇది ఓన్లీ డిఎంఈ హాస్పిటల్స్కి, తర్వాత వైద్య విధాన పరిషత్ హాస్పిటల్కి, డిహెచ్ హాస్పిటల్ కూడా ఫర్దర్ ట్రైనింగ్ ఉంటాయి. ఈ స్టాండర్డ్ లెక్చర్ సిరీస్ అయితే ఉన్నాయో డెఫినెట్గా విల్ ఫర్దర్ ట్రై టు ఇంప్రూవైజ్. మీ ఎటువంటి సజెషన్స్ ఉన్నా వెంటనే చెప్పండి. దీని లెక్చర్ ఆపి కూడా మధ్యలో కూడా చెప్పొచ్చు. సో థ్యాంక్ యూ వెరీ మచ్. Yes, sir. Yes, sir. అంటే గైడ్లైన్స్ ఉంటాయి సార్, దాన్ని మనం ఇంప్లిమెంట్ ఫేజ్డ్ మేనర్లో చేద్దాం సార్. నేను ఐఎమ్ నాట్ టెలింగ్ దట్ 100% మన 7% ఉందని చెప్పారు మంత్రి, 7 to 10%. వీఆర్ నాట్ ట్రైంగ్ టు బ్రింగ్ డౌట్ టు 0%. అది ఫేజ్డ్ మేనర్గా మనం డెఫినెట్గా దాన్ని, ఇప్పుడు నేను యాజ్ ఎ నెఫ్రాలజిస్ట్ ఐఎమ్ టెలింగ్ ఇంక్రీజ్ అవుతుంది సార్. నెంబర్ ఆఫ్ బెడ్స్ కూడా ఇంక్రీజ్ అవుతున్నాయి, నెంబర్ ఆఫ్ హాస్పిటల్స్ కడుతున్నారు. డెఫినెట్లీ దిస్ ఈస్ గోయింగ్ టు అడ్రస్ ఇన్ ఏ ఫ్యూచర్. సో ఓన్లీ థింగ్ వీ హ్యావ్ టు హ్యావ్ ఎ ప్లాన్ ఉంటే డెఫినెట్గా ఇది ఇంప్లిమెంట్ చేయొచ్చు సార్, నో ప్రాబ్లం. అయితే దాన్ని కూడా అడ్రస్ చేయడానికి నేను కూడా చెప్తాను సార్. ఇప్పుడు మంత్రి గారు చెప్పారు 24 న్యూ ఎంసీహెచ్ హాస్పిటల్స్ కమింగ్. ఇంప్రూవ్ అవుతుంది నెంబర్ ఆఫ్ హాస్పిటల్స్ కమింగ్, మదర్ హెల్త్ సెంటర్ పెరుగుతుంది. మనం జరిగే 3 లక్షల డెలివరీస్ కూడా ఎక్కడెక్కడ చేయాలనేది ప్లాన్ చేస్తున్నారు. అలాంటప్పుడు పెట్టబుర్జ్ ఒక్కదాని మీద లోడ్ తగ్గించి మిగతా హాస్పిటల్ కూడా మనం డిస్ట్రిబ్యూట్ చేయడానికి ప్లాన్ చేస్తున్నాం. ఉస్మానియా కానీ డెఫినెట్లీ సార్. లేదు అంటే మీరు అన్నారు సార్, అన్నీ కూడా డిస్కస్ చేద్దాం సార్. మీరు అన్న మాట వాస్తవము. డెఫినెట్గా ఇవన్నీ అడ్రస్ చేయడానికి ఇలాంటి మీటింగ్ పెట్టారు. డెఫినెట్లీ విల్ ట్రై టు అడ్రస్ ఆల్ దోస్ ఇష్యూస్ డెఫినెట్గా. వచ్చాయి కదా, ఇట్స్ గుడ్. నో అంటే నేను కూడా అంటే ఐఎమ్ ఆల్సో ఫ్రమ్ ది గవర్నమెంట్ హాస్పిటల్. నాకు కూడా తెలుసు ఎంత ఇబ్బందులు ఉన్నాయో. బట్ ఇవన్నీ కూడా మనం కన్స్ట్రక్టివ్గా తీసుకొని పాజిటివ్ దృక్పథంతో పోతే డెఫినెట్గా అవుతాయి సార్. నేను ఐఎమ్ ట్రైంగ్ టు ఐ టోల్డ్ మై ఎక్స్పీరియన్స్ ఇన్ నిమ్స్ వేర్ డయాలసిస్ అనేది ఇప్పుడు డయాలసిస్ రీయూజ్ అనేది స్టేట్ వ్యాప్తంగా ఎక్కడ లేదు. ఇప్పుడు మీ దగ్గర సంగారెడ్డిలో డయాలసిస్ సెంటర్ ఉంది, అక్కడ రీయూజ్ చేయట్లేదు. అన్ని చోట్ల ఇప్పుడు 30 హాస్పిటల్లో మీ దగ్గర అన్నింటిలో డయాలసిస్ సెంటర్ ఉంది, ఎక్కడ కూడా రీయూజ్ చేయట్లేదు. అక్కడ ఎందుకు ఒక పాలసీ లెవెల్ తీసుకున్నాం. మీరు ఒక పాలసీ ఇవాల్వ్ చేద్దాం, వీల్ కన్విన్స్ గవర్నమెంట్, దీనికి సెపరేట్ బడ్జెట్ ఇద్దాం. ఒక ఇన్ఫెక్షన్ కంట్రోల్ ప్రాక్టీస్కి బడ్జెట్ ఇద్దాం సార్ అన్న. ఉన్నాయి కానీ వాళ్ళు ఖర్చు పెట్టడానికి వాళ్ళ మెకానిజం తెలియకపోవడము దాని మీద ఉంది. వాళ్ళకు కూడా గైడ్ లైన్స్ కోసం కావాలంటే ఇట్లాంటి ఒక ట్రైనింగ్ సెషన్ ఇప్పిద్దాం. సూపరింటెండెంట్స్ కూడా హౌ టు స్పెండ్ ది మనీ దాని గురించి ఒక ప్రోగ్రామ్ ఇప్పియాలంతే, ఇద్దాం. ఉంటాయి అడగండి. డెఫినెట్లీ వీఆర్ ఇన్వైటింగ్. లేదు మాట్లాడతాను సార్, అంటే అట్లాంటి స్పెసిఫిక్ ఇష్యూస్ మాట్లాడదాం. బట్ యాజ్ యూ సెడ్ ది ఎక్స్పెండిచర్ ఆఫ్ ది మనీ అది మాట్లాడదాం. పాపం ఇండివిజువల్ హాస్పిటల్స్ ఉంటాయి, బట్ డెఫినెట్లీ హౌ టు స్పెండ్ మనీ అన్నది కూడా వీ నీడ్ టు ట్రైన్ ది సూపరింటెండెంట్. దట్ ఆల్సో ఏ ప్రోగ్రామ్ కెన్ బి టేకెన్ అప్. సో మనీ ఎస్ ముందే చెప్పాను కదా, దానికి మనీ అప్రాప్రియేట్ లేని చెప్పడానికి లేదు. సో వీ కెన్ బ్రేక్ ఫర్ ది లంచ్ అండ్ డ్యూరింగ్ లంచ్ టైమ్ వీ కెన్ టాక్. ఐ థింక్ లాట్ ఆఫ్
So if you are present here, just raise your hand. We'll just come to your place so that you can write your mail ID in the form which we give you. So I'll just call out the names. If you are present here, just raise your hand so that a person will come near you and you can write your mail ID in there. Dr. Shobha, Assistant Professor Anesthesia, Sultan Bazar Hospital. And Srimati N. Dhanlakshmi, Staff Nurse, Sultan Bazar Hospital. Dr. Ravi from Petla Bhuj and Mr. Ravi, male nursing Petla Bhuj. If both of you are there, could you please raise your hands so that
Anybody who haven't given your mail IDs, you can please make a note of your mail ID in this paper. Form is being circulated. Can you please enter your mail IDs so that we can send the PowerPoints to you later? Okay? Yeah. Yeah. Next lecture, I invite Dr. Ambreen to present on droplet infections.
Good afternoon, everyone. I'm Dr. Shaheen Siddiqa Amreen, Senior Resident in the Department of Microbiology at NIMS Hospital. Today, I'll be continuing with transmission-based precautions, which were already taken up by Dr. Bushra. I'll be continuing with droplet and airborne precautions. So as we all understand, a chain of infection consists of a reservoir or any other patient having an infectious agent which is transferred to the susceptible host via a portal of entry through a particular mode of transmission. This is where we are trying to bring in picture the transmission-based precautions by preventing this particular mode of transmission. So as we already saw, transmission-based precautions are designed to supplement standard precautions in patients or residents with documented or suspected infection or colonization of transmissible or epidemiologically important pathogens. So why do we need transmission-based precautions when we have, since morning we have been seeing so many sets of precautions, the so-called standard precautions. Despite of that, why do we need a separate set of precautions? This is because the route of transmission is not completely interrupted using standard precautions. So this is basically a two-tier approach. It is a most cost-effective, simple, and feasible way to prevent transmission of pathogens, wherein the standard precautions, which we have been going through since morning, are invariably followed for all the patients, and the so-called transmission-based precautions are followed in selected patients depending on the transmission routes. One of the main reasons why these are followed only on specific set of patients is in order to avoid burden on healthcare workers, on the financial healthcare facilities, and most importantly, to avoid inconvenience to the patient. So the various modules under which transmission-based precautions can be covered are the personal protective equipment required for transmission-based precautions, how the patients should be placed if they are on a transmission-based precautions, the movement, how it should be limited or how they should be allowed to transfer from one place to another, and the engineering controls of a particular place where these transmission-based precautions following patients are kept. So as we all already are aware, the basic routes of transmission are droplet, airborne, and contact. And now, continuing with droplet precautions, these are infectious particles greater than 5 microns in size, which are produced when a patient coughs, sneezes, or talks, or during certain procedures. They can be directly transferred or indirectly transferred to the mucosal surfaces of a healthcare workers or any other patient. Airborne infections, on the other hand, consist of small particles which are lesser than 5 microns in size. They are aerosols which are created during breathing, coughing, or there is a set of procedures which we'll be dealing with later, which can also produce aerosols. And they are dispersed over long distance, both spatially and both temporarily also. They're present for they suspend in the air for longer periods. So the various diseases which are covered under under droplet precautions are COVID-19 disease, pertussis, diphtheria, group A streptococcal pharyngitis, Haemophilus influenzae, Neisseria meningitis, influenza, adenovirus, rhinovirus, mumps, and rubella. So the placement of patient, as we already saw in contact-based precautions, it is always preferred to have patients in single rooms. But that is what is ideal, and that is not possible in our setups. So it's, if at all single rooms cannot be provided to the patients, then cohorting can be done, wherein the patients infected with the same infectious agents are grouped together to confine their care to one area. So here, if at all they have to be kept together, the spatial separation between two beds or two patients should be a minimum of 3 feet or 1 meter, and the privacy curtain should be drawn in between in order to avoid cross-contamination. But as we already saw, cohorting should be specifically avoided with immune-compromised patients or patients who are anticipated to have long lengths of stay in the hospital. In this, for droplet precaution, a special air handling or ventilation is not required. In ambulatory settings, if we encounter patients who should be kept on droplet precautions, then they should be separated into an examination room or a cubicle, and they should be instructed to follow respiratory hygiene or cough etiquette. So what are the various personal protective equipments which should be followed when a patient is on droplet precaution. Any healthcare workers who's supposed to enter the room of a patient on droplet precaution should and must wear a surgical mask. Apart from following the standard precaution, the one most important PPE which has to be worn by any healthcare worker who's entering the room of a droplet infection or droplet precaution patient is a surgical mask. In addition, if we are suspecting aerosol generating procedures, then we can go for goggles as well as face shield. And the other set of standard precautions like the gloves or gowns should be worn. And when we are suspecting that there's going to be a potential contact with any infectious material. But then again, when the patients are cohorted together, we should make sure that we remove our gloves or gown when we are going to the next set of patient and we are donning a new gown and wearing a different set of gloves. How should the patient be transferred to other, ideally, patients should not be transferred from one place to another, but that again is not possible. So what can be done when there is an important diagnostic procedure and a patient has to be taken to another department? First of all, the incoming department, the department where the patient has to be taken, should be informed so that they can also follow the droplet precautions. And the healthcare worker who is taking care of the patient should wear a surgical mask. The other standard precautions, if you're suspecting that there can be an aerosol generating procedure or there can be soiling or there can be contact, then gloves, gowns, other things come into play. But surgical mask is must at all times. In addition, even the patient should be allowed or asked to wear a surgical mask, a correctly fitted surgical mask as was described by Dr. Neha. Respiratory hygiene and cough etiquette should be taught to the patient before he's being transferred in order to avoid cross-contamination to other patients. The respiratory hygiene and cough etiquette, as was already described earlier, the patient should be advised to cover the nose or mouth and use single-use disposable tissues to contain the respiratory secretion. They should not use their hands. They should use the elbow if at all they have to sneeze and there are no tissues available. Hand hygiene should be practiced after contact with respiratory secretions, and contaminated hands at all times should be kept away from eyes and nose. So the duration for which a droplet isolation can be practiced. So in most cases, this is for the entire duration of illness. So in seasonal influenza, it is done for almost until 24 hours after the resolution of fever and respiratory symptoms, or 7 days. In pandemic influenza, it was done for 5 days. In meningococcal diseases, meningitis, pneumonia, it is done for 24 hours after the treatment has started. For mumps, it is after the fever and swelling has come down. MRS pneumonia, the entire duration of illness, and also contact precautions should be followed. In streptococcal pharyngitis, again, for 24 hours after the treatment has started. And in rhinovirus, or in cold, as we understand, for the entire duration of illness, this should be followed. One very important thing is, although as healthcare workers, we may be aware, but we are always overburdened with the number of cases we have under us. So instead of reminding a doctor or another person who is coming to see the patient every single time, we can put up signages. These signages should be put up in front of any rooms which are under droplet precaution or airborne, as we'll see later on. So these are some of the signages which have been provided by CDC, by WHO, by ICMR. We have many of them available. So we can use these, or in case if these are not available, we can even have our customized ones according to our hospital, whatever would work, which clearly indicate what a healthcare worker who has to enter. For example, in a droplet infection case, they should clean their hands before and at the time of leaving the room. They should make sure their eyes, nose, and mouth are fully covered, and follow face protection. Sorry, the face protection should be removed. A mask should be discarded immediately after exit from the room. These are some more signages which can be used, a customized one or a printed one, whichever goes for our hospitals. Now moving on to airborne transmission. Airborne transmission can again be divided in obligate airborne transmission, which occurs in tuberculosis, preferential airborne transmission, which is seen in varicella and measles, where it occurs through multiple routes, but predominantly by aerosols, and opportunistic airborne transmission, which is seen in influenza, SARS, variola, and norovirus, where in high risk procedures, aerosols might be produced. So as I told earlier, according to WHO and SHIA guidelines, these are the aerosol generating procedures: open suctioning of airway secretions, resuscitation involving emergency intubation, cardiac pulmonary resuscitation, endotracheal intubation, bronchoscopy, intubation under controlled or emergent situations, and open airway suctioning, airway induction. So let's understand the personal protective equipment which is required in case of a airborne transmission precaution. So if a patient is on airborne transmission precaution, in addition to the standard precautions which have to be followed, the healthcare worker must be wearing a powered air purifying respirator, or as we all commonly understand, the non-powered air purifying respirators, that is N95 mask. And every time we wear that, or rather before we wear it, a fit check should be done. Transfer of patient, ideally, once again, the patient should not be transferred, but if at all they have to be transferred from one area to another, then they should be wearing a surgical mask if they can tolerate, and it should be correctly fitted in order to, and they should be also, again, educated in respiratory hygiene and cough etiquette. One of the very important part of airborne transmission, because the aerosols tend to suspend in the air for longer time. They can be taken away by the air currents, and they can be inhaled directly into the smaller airways. So environmental controls are a very important part. So what do we understand by environmental control? From the beginning of the time when tuberculosis, as we all understand, is an endemic disease in our country. So before the CDC guidelines and the WHO guidelines were followed, we had these huge sanatoriums where we had a lot of ventilation. So traditionally, conventionally, natural ventilation in order to avoid cross-contamination was preferred for airborne transmission. Also, we can go for mechanical ventilation to circulate and move the air within a building. Or exhaust ventilations can be used. But now, currently, CDC recommends having an airborne infection isolation room or a negative pressure room. This is created this actually controls airflows in areas adjacent to the source and cleans the air. It controls the airflow to prevent contamination of air in areas adjacent to the source. It cleans the air by using high efficiency particulate air filtration, or in cases where HEPA filters are not available, we can go for ultraviolet germicidal irradiation. So this is how we can have unidirectional flow, a laminar flow in with a negative pressure being created inside a room. So how do we create a negative pressure inside a room? Basically, the exhaust, the air exhausted, the quantity of air exhausted from the room is usually, the volume is higher than that being sucked in. That is how a negative pressure is created. So other things are, healthcare workers should always be seated in such a way that the direction of airflow is from the healthcare worker towards the patient, so that the contaminated air does not flow back towards us. The same way, exhaust should be properly fitted into the walls when we are having airborne isolation rooms. So let's deviate a little bit and understand what kind of air exchanges are needed in various healthcare settings. Although this may not be ideally possible in a lot of setups, but this is what is recommended by CDC, that in all the low-risk areas, we should have at least minimum 6 air exchanges per hour, and in high-risk areas and areas with airborne precautions, there should be more than 12 or at least 12 air exchanges per hour. So airborne infection isolation rooms are the so-called negative pressure rooms, where the doors should be closed at all times. It is preferred to have self-closing doors, and the pressure inside the room should be around 2.5 pascals. The pressure difference with the corridors or the outside should be around 2.5 pascals. The exhausted air should be directed outwards, and the exhaust should be closely fitted into the windows. Airflow should always be from clean to dirty areas and then exhausted out. There should be at least 12 air exchanges per hour, and HEPA filter maintenance should be done regularly. See, another, in places where HEPA filters cannot be installed or it's financially a burden, ultraviolet germicidal irradiation can be done. These are maximally germicidal at a wavelength of 254 nanometers, and they are almost equivalent to 10 to 20 air exchanges per hour. 30 watt UV lamp power for every 200 feet, 19 meter cube of floor area can actually irradiate 99% of Mycobacterium tuberculosis in a matter of maybe 2 to 3 minutes. So the only disadvantage is that these can be harmful for the patients. So they must be fitted at more than 8 feet, and to protect the eyes of the occupants. Non-reflective paint may be needed to add it to the ceilings and walls. And it only provides an equivalent to air exchanges, but does not provide fresh air or directional flow. So the duration of airborne precautions, as we understand for chickenpox, that is varicella, it should be until the lesions are dried and crusted. In case of shingles, if it's just a localized region, then only standard precautions are sufficient. If it is a disseminated disease, then throughout entire duration of illness, they should be followed. And localized disease in an immune compromised patient, then we may have to go for additional 1 or 2 months, because immune compromised patients tend to harbor the organisms for longer. The non-immune healthcare personnel should not care for patient with chickenpox or shingles. These, again, some of the signages which must be put up in front of the patients who are on airborne precautions, and they, as we understand, that the hand hygiene should be done, fit tested N95 or higher level respirator should be used, and the door must remain closed at all times. These are some other signages which can help us, which can help the healthcare workers or the visitors to understand what they must or how they must enter the rooms. Another important thing about airborne isolation is once the patient is discharged, the room must be kept empty for at least 1 hour. In order to avoid enough air exchanges so that any contamination which might be present inside the room is completely cleaned up. And after that, even for cleaning up, the any other healthcare workers should be allowed inside the room. To sum up, for droplet infections as well as airborne infections, a single room is essential. If we cannot have single rooms, then we can do cohorting. Airborne infections or airborne transmission, we need negative pressure rooms. Gloves are required when we are likely to touch the blood, body fluids, and contaminated items. Gown is required if we are expecting soiling or if any other procedures which can cause splashes. Then mask is required. Surgical mask is absolutely essential for droplet precaution. That is the one thing which we have to remember. And N95 respirator is essential for airborne transmission. Eye protection, again, is only required when aerosol generating procedures are expected, and handling of equipment, that is cleaning up of equipment or in providing equipment which is customized to each patient is preferred, or we can clean up in between 2 patients. Visitors should be strictly restricted, but if at all the visitors have to be there, then the precaution should be same as that of the staff. Some of the signages which are available and which we can use for droplet as well as airborne precautions. These are my references. Thank you.
Thank you, Dr. Amreen, for your excellent presentation. Any questions? For any kind of these droplet infections or even contact infections like MDROs, especially MRSAs or VREs, you need to try to place a signage board just near the bed. At least that is a basic thing which we can do in our own setups. Like you can try to isolate the patient, though we don't have isolation rooms. At least we can put to one corner of the room. We can isolate them to one corner of the room, place a board there. These are the small things which we can do with our own limited resources. So everywhere there may not be an isolation room in your setup also. So at least we can try to follow these kind of things. So you have to go to rounds, instruct the clinicians, check for MDROs are there or not in particular AMC or ARCU, and then you need to advise, give this as a guideline. What are the precautions you need to take when MRSA is isolated or any other droplet infection occurs? You need to give guidelines basically by a microbiologist, which will be voluntarily should be done, few things. so that everybody will have idea what precautions you have to take. Or you need to approach an infection control committee members at least to have a discussion, ask for a committee meeting. All these kind of things can be done in a simple way. Yes. So the next topic is by Dr. Amrish. He is a surgeon, unit head and professor in cardiothoracic surgery. Sir will give us, enlighten us on bundle care preventions for surgical site infections. Yeah. Whoever have filled the questionnaire, can you please hand over to the MHM students?
Good afternoon, everybody. Good afternoon, everybody. Yeah, it's always the toughest session is to do after the post lunch, because because the speaker is half asleep, and I hope the audience is awake as well. And especially after the previous slide by Dr. Amreen, she had so many colors, she had so many graphics. So mine is a relatively drab presentation. But I'm given to understand that there's a mix of doctors, surgeons, there's a mix of nurses as well. So I just want to know how many in the audience are nurses here. Can you please raise their hands? Yeah, thank you. There are two reasons. One is I wanted to know actually how many are nurses here, because there is a significant thing for them. And second, I wanted to wake up half the audience as well. So the topic is of course the bundle care for prevention of SSIs. SSIs then is surgical site infection. And bundle is not Hindi bundle ki bundle maar raha hai wo karke. It is supposed to be these recommendations are bundled so that they are short, concise formats, so that when you go back to your places, you can implement these things. These are supposed to be practical recommendations, and these are supposed to be recommendations which you can, once you go back to your place, can implement it safely. Now that COVID has come, everybody is worried about infections, droplet-borne infections, and respiratory infections and all that. Otherwise, for all practical purposes, hospital-acquired infections means infection of the surgical wound. There was nothing, we always used to say, the difference between medical and surgical practitioners is, even if a medical practitioner will inject poison, KCl or whatever, and patient dies, the patient party thinks that the disease has killed the patient. But for a surgeon, if a patient who is gasping and about to die, he even does a cut down, they say the surgical procedure has killed the patient. So that way we bear a lot of burden. And of all the hospital-acquired infections, surgical site infection is one of the most devastating in terms of repercussions to the hospital. They are also the most costly hospital-acquired infections. Not for nothing are they called high mat jati hai whenever you have. And surgical acquired site infections account for almost 20% of all the hospital acquired infections. So many of them are utterly preventable with simple practices you can follow. We all know that they delay the hospital discharges by such a long time. You have to, and once a patient is, once you find it difficult to discharge a patient from the hospital, there's nothing worse than a patient who is recovered but in the hospital for these minor things. Because then he'll constantly complain, fan is not working, geyser is not working, water is not there, nurses have not checked my temperature. So it is best if the patient heals and recovers fast and goes home. Once he's out of anesthesia, he's out of the critical drugs, he has to go home as soon as possible. Otherwise, life is miserable for everybody. So that's why there is such a huge cost to these, and they are such eminently preventable conditions. So that's why they become very important, and there are very simple things which we can do to actually address these concerns. Of course, there is always a risk. There are always certain patients who are more at risk of infection than others. Whenever there is a bacterial inoculum, especially with a high virulence, and whenever the host resistance is impaired, and then if there are foreign bodies or presence of implants, all these add to the risk of infection. There are various wound scores. This is not we are not going to appear for exams after we go here. So I don't think we need to really know, but we should know that at some point there are certain scores which objectify the infections and how a wound is healing and whether it's likely to give problem or not. But we have to know that there can be superficial wound infections, deep surgical site infections, and organ or deep space surgical site infections. The superficial ones are morely near the skin and subcutaneous tissue. We all are experienced healthcare people. We know how to identify them. The deep ones, one thing is we calculate the superficial skin infections to be at around till about 30 days. We have this tendency that in India patients will come 1 year after surgery or 2 years after surgery and say, आपने मेरा 2 साल पहले ये सर्जरी किया था, उसके बाद ये हो गया और अभी यहाँ पे खुजा रहा है, मैं खुजाया तो अभी इन्फेक्शन हो गया, तो वो सर्जरी के कारण हुआ है. So that's not attributable to that. When you are counting of what is the surgical site infection, at the same time it's the other way around as well. You discharge the patient in 3 days and say, हो गया, तुम घर चले गए, what you did after that is none of my concern. It's not that. Within 30 days is what we count as surgical site infection superficial. And when it comes to implants, when it comes to deep organs, maybe collection of intraperitoneal abscesses, then they can be up to 90 days and sometimes even up to 1 year. Of course, we all know that not all wounds have a propensity to get infected. The clean wounds have less propensity. Clean, contaminated and dirty wounds. Just on the lighter side, when we read the textbooks, there are so many things we realize that these are under ideal circumstances. But when we are trying to go into real-time practice, we realize that all these things are not very ideal. For example, when my sweat droplet falls into the wound, what kind of a contamination is it? Is it clean, contaminated, or dirty? I quote an example how breaches occur. This may not be true anymore, but when I was doing general surgery, we used to have the OR, and for 3 different ORs, we used to have a common gowning area as well. So we were just standing just like that, and suddenly my boss came and fired at everybody. What is this nonsense? Patient anesthesia lag gaya, patient लेटा हुआ है और कोई भी surgeon नहीं है वहाँ पे, ये क्या चल रहा है करके. So we're, oh my God, what's happening here? So suddenly the guy next to me, quick-witted, suddenly put his hands up. Where is the gown? Where is the gown? I'm waiting for the gown. He has not scrubbed. He has not washed his hands. He has not scrubbed. And how can there be such a blatant breach of protocols? All this happens. You look back in your careers as nurses, you look back in your careers as when you have spent time in the OT, and see how many, this might be an extreme example, but look back at how many extreme examples of breaches you have seen. It's thanks to programs like these we have reached a stage where nurses, infection control people, where senior surgeons, we are all willing to usher in an atmosphere where this kind of attitude won't be accepted, and surrounding people are empowered to call out these kind of bad actions. So of course we all know that there will be risk factors in patients who have malnutrition. Is not necessarily like the marasmic patients which we see, which we are used to in our mind. Even obesity is a kind of malnutrition, is abnormal nutrition. And then Hyderabad is the diabetic capital of the world. You have immunosuppression, then colonization of gastrointestinal tract. We have patients who present to us with shock, who present to us late in the stage of the disease, and then there is so much of foreign body which we may keep, be it implants in orthopedics, in cardiac surgery, or be it suture material in other conditions. But there is so much of foreign material we keep. Before we actually go on to the prophylaxis, we now know that we know what's the problem. We know why we need to address it. Now we need to know how to address it. We know how to recognize what's an infection. Then we should have a system in place where you can detect these kind of infections. I think there may be separate lectures on surveillance, but as infectious disease in charge personnel, definitely there will be you would be one of the key things is to identify. Suppose you go and ask a surgeon, what is your rate of infection? I guarantee you he'll say 0%. My infection rate is 0%, but it is a patient who is causing the infection because of whatever reasons. It is the nurses who are giving infection to my patient. It is the attenders who are walking in and out who are giving infection to the patient. But my infection rate is 0%. Therefore, the gold standard is go and see it yourselves. That is always the gold standard. You see for yourselves what is the infection rate. But that is not always possible. So there are some indirect ways. And one of the ways with a high incidence of high specificity and sensitivity is the nursing records. Nurse records that dressing has been done and such and such infection has been. I don't know how many actually nurses record that so many pads of soakage was there, or so much of discharge was there, or nature of the discharge was there. But you should encourage your nurses to make those kind of notes. So these kind of notes are the important indicators of surveillance. And then when these samples are sent to microbiology records, microbiology people should tell us that these are your infection rates. See, we'll see and we'll discharge and we'll send the patient. But these medical records, the codes which we put for dressings, these are the records which will give us an indirect indicator of how deep our problem is or how big our problem is. Then, of course, nowadays we have all accreditations, JCI accredited hospitals, NABH accredited hospitals, and you have all these with EMRs and automated medical records. Probably they might be finding it easier to detect it, but I am a part of that ecosystem, and trust me, they also can't figure out what is the rate of hospital infection. It is you as infection nurse professionals, infection control professionals, who has to sensitize them that if these codes are put into the system, then only you can get the data of hospital infection into your system. So you have to be very careful, and whenever there is a electronic system being integrated into your hospital, make sure that all the infection control advocates incorporate these kind of codes into your hospital information system. And then again, post discharge surveillance of asking questionnaires or asking interviews to patients or surgeons don't really give much of a picture. Ambulatory setting where patient comes, gets a dressing done and goes away. Half the cases which I treat, I don't even make an entry that they have an infection because they may have to pay money. So I just do a dressing free of charge and send them off. So these are very poor ways of surveillance, of knowing things. But there are so many systems in the hospital by which you can have a data of how to address these issues, collect data on this. So then what are the various strategies? This is the bundle. What are the bundles? What are the things? Keys, of course, first thing. I will come to the hand washing. Whenever we used to have infection control meetings, it used to start and end with hand hygiene. So I'll come to that a bit later. But let us see what are the obvious ways of preventing surgical site infection. One is, of course, the antimicrobial prophylaxis. You give antibiotics, right? But there is a way to which we give antibiotics. the way to give antibiotic to a surgical patient is whenever we are giving an incision, that is the time the concentration of the antibiotic has to be maximum inside the body. So whenever I am doing, so I have to plan it accordingly. So if I am doing, like for example, when I am doing a CABG, it takes me a little bit of time before neckline is placed to my cleaning, draping, preparing and other things. So during that it takes around half an hour to 1 hour. So that's why after induction they give the antibiotic, so that by the time I'm ready to give an incision, it is half an hour to 1 hour and the antibiotic level is the maximum. That is the best possible protection, antibiotic protection you can give. Some surgeries may take a much shorter time, like a hernia surgery may take a much shorter time. Probably when we are doing tubectomies in a camp, there is virtually, by the time the antibiotic is in the body, surgery is over and patient might be in recovery. So the best time is, so we can give this a bit ahead of time. So generally half an hour to 1 hour when before the incision, so that the concentration is the maximum. Then we have to realize that we have to give the optimal antibiotic, which is of course suggested by the microbiologist. We always keep requesting our microbiologists to give us data on which antibiotic is good. Prophylactic antibiotic we often rotate once every 6 months to have to prevent resistance, and adequate dosages have to be calculated, especially in cases of highly obese patients and pediatric patients. It is very important to see that they get the right dosage of antibiotic. And then intraoperatively, whenever there is an excessive blood loss or if the surgery takes a long time, there should always be a repeat antibiotic. Bowel preparation, Dr. Venu might tell us better if it works or not, because of course we prepare bowel for a lot of abdominal conditions, but there are certain studies which say that addition of oral antibiotic may prevent infection, especially in colorectal surgeries. Some say it doesn't make much of a difference, but irrespective of the bowel preparation, irrespective of the antibiotic given for bowel preparation, injectable antibiotic which you give should be in the body at the maximum concentration whenever we give an incision. Another practice which I observed which makes a big impact is the removal of hair. Even in an institute like Nizam's, whenever we do cardiac surgery, we are still using razors. We are unable to break that practice. Despite so much of advocacy, we are unable to break that practice because razors will create microabrasions. They will cause seeding of infection. Therefore, they are not good things to use. Use clippers, epilatory creams. You can use clippers, and better still, don't remove the hair at all. Even that is perfectly acceptable. But it becomes messy, especially because we put plasters and other things which are painful for the patient to remove. It's fine if we remove the hair, but make sure we use clippers. Clippers are even economic. If you look at economics wise, probably they are economic. If you keep them in a sterilizer, they are quite good. But somehow there is so much of resistance against giving up of razor. Razor is recommended maybe if for some scrotal preparation or scalp if you need to operate. Otherwise, you can just avoid it. Another thing which we fail to do is optimal control of glucose, sugars. Ideally, sugars should be less than 200 to 180 preoperatively. That's what we call control of blood sugars, especially in today's age and era where there is a lot of pressure to perform surgeries given the time constraint, where patients are not willing to wait longer. Or if we say that if we don't operate on him today, he might probably go to some other surgeon who might operate, and then we'll miss out on a patient. If this kind of a culture is there, then definitely we have to rethink, because it is very important to get sugars under control. And not only preoperatively, but in the first 18 to 24 hours after surgery, we should keep it quite low. Now we might be thinking, why don't we keep a tight control of sugar? Let me make it 100, 110. No, let it be so low that he is not hypoglycemic but just euglycemic. It doesn't really work, because it is not known to reduce the incidence of infection. In fact, it is known to increase the incidence of dangerous strokes. So these are dangerous things to go by. Keep comfortably under 180, you will be happy. One of the key things in surgical site infection which is often overlooked is hypothermia. Especially in patients who are in shock, who are sick, and who are children, they are very prone to hypothermia. Hypothermia will immediately cause vasoconstriction, the blood won't reach the tissues, and so your antibiotic won't reach there, your neutrophils won't reach there to fight the infection, and immediately they catch up with the infection. It is very important to maintain normal temperature. Nowadays there are beautiful bear huggers, patient warmers. I have seen people use table lamps to warm children and even burn babies, but you don't need to go to that extremes, but they are very beautiful measures to keep a patient warm. Please make optimal use of them and make sure that the patient is adequately warmed. And obviously there was this concept that if the tissues of the body have adequate oxygen, then it is the body's ability to fight infection is more. So there were a lot of studies on that where they gave 80% oxygen. They used to keep giving high doses of oxygen. But then they soon realized that it's not the higher doses of oxygen which is important, but it is that the tissue perfusion should be maintained. So even with normal room air, if you maintain the tissue perfusion, how will you maintain the tissue perfusion? By maintaining hemodynamics, by maintaining the blood pressure and keeping the patient warm. The use of extra oxygen is not really needed. Then of course, one interesting thing I have done, how many of us use betadine, povidone iodine? Can you raise hands for preparation of a patient? Okay. How many use Savlon solutions for surgical preparation? How many of us use alcohol for preparation? Alcohol, spirit, alcohol. I think this is a surgeon's cohort. Of course, I need not teach the surgeons. I have learned so much from surgeons. Alcohol of all the skin preparations is the best. It is most rapidly acting. It acts against virtually all the things, and it works really quick. But the downside of alcohol is that it is very short acting and there is no residual effect. Once you have wiped off the alcohol, there is no residual effect. You can't use it in areas where you may have mucous membranes. So mucous membranes for us mainly would be maybe vagina, so in and around the groin, and these or oral cavity, they are not of much help. And another risk, though I have never seen it, sir, anybody has seen fires with alcohol? Though I have never seen, but there are definitely people who have experienced fires with use of alcohol, and apparently in places where we can't wipe it off, like hair and all, so it's not a good preparing agent. So, but it has its own use. Most effective, the most important being that it is very rapidly effective. And then we have iodine and chlorhexidine. Chlorhexidine, a lot of surgeons have it in their mind that it is a culture medium for Pseudomonas. So that's why there is an inherent bias against it. But it is supposed to be better than povidone iodine in terms of lasting residual action. When we prepare a patient with betadine, it works only while it is in the body wet. The moment you wipe it off, there is no effect of betadine. So you apply betadine and wipe it off, the effect is gone. There is no residual effect. Whereas if you let it dry, at least there is some effect, but Savlon or chlorhexidine will have a longer effect. So people have tried that the best combination is that of alcohol with chlorhexidine or alcohol with povidone iodine, and they realized that olden days they used to use iodine with alcohol. Sir, you have experience with iodine with alcohol? Not povidone iodine, the old iodine where it used to turn blue and all that. I don't know, I think it is past our generation where people never used to have, where people used to use iodine with alcohol. That was better than povidone iodine alcohol combinations, which is actually better than chlorhexidine and alcohol combination. But if you want to use a single agent, chlorhexidine is definitely a better thing with a longer residual action. and wound protectors, use of betadine impregnated steri drapes and all. Though it looks good and it's marketed that way, they don't really help. So if you're thinking that my wound infection is because I don't have a steri drape which keeps the rest of the skin separate from the incision site, that's not what works. Good skin preparation is the key. Then surgical safety checklist. This has now become a standard practice in most hospitals. This is one thing which I want to see. Again, these are the things where we deviate from what the textbook norms are. I don't know how many. I worked in Sri Chitra, which was where the level of nursing was unusually high in Trivandrum. So that's where I trained. So it used to be a standard practice when a patient is taken into the operation theater. The ward nurse used to hand over the patient to the theater nurse. There used to be a corridor there used to be a designated area where the nurse used to hand over to the theater nurse. And then, of course, after the customary identification, and this handover used to be in the presence of a patient's relative and surgeon and anesthetist. So then they used to, of course, after the customary identification and other things, the nurse in the theater would make sure that this patient is prepared well. They are prepared, they are given the proper gown, hospital gown. Patients are wearing the hospital gown. The hair is neatly combed and tied and put in a bun. And all nails are clipped, and the patient has been given a wash and other things. Somewhere down the line, we have realized that we give up on these protocols, and we see that these things which are supposed to be pretty basic don't happen. Similarly, when a patient goes from the OT to the ward, it was supposed to be a great insult if you send the patient back to the ward with blood-stained clothes. But so many times we see you mop the same patient with betadine, you mop the same patient, some secretions will be there, some urine would be spilled, some blood would be spilled. Arey yahi tak to hai, you just have to go a short distance, you cover the patient with that only and send. These are bad practices. These are bad practices which we should not allow to creep into the system. If they are already crept into the system, I think it is our special duty to see that these are weeded off. There are senior surgeons here. There are a lot of experienced nurses here. Everybody here has come with because they are empowered to make certain changes in what they are once they go back home. The message from me is not, these are nothing new to any of us. These are absolutely nothing new. But I think we are gathered here to reinforce in ourselves that we have been given this special authority to make things change in our system. So while we recollect what needs to be done, I think more importantly, it's not lack of knowledge of what needs to be done, but it is to have that special resolve that we need to change the things and practices which we have. So once we go back, definitely we can, we should create ourselves a certain surveillance database where we collect the patient details, the surgical team details, the procedure details, antimicrobials used, microbiology details, and so on and so forth. I think surveillance, there's a separate lecture altogether. So what are the modifiable factors? As I told you, our infection control meetings used to start with hand hygiene and end with hand hygiene. I'd like to tell a small story. Ignaz Semmelweis was a Hungarian doctor who started this concept of hand hygiene. You know how he actually discovered it? There used to be two units of midwifery units, one which was managed by surgeons and the other which was managed by nurses. So the difference in the mortality rate used to be so high amongst those operated by surgeons that the patients used to fight to go to the nurses' side, nursing unit. They would fight that it would almost be a condemnation to go to a surgeon's unit, and you could be saved only if you go to a nurse's unit. Why was that? Because the surgeons used to perform autopsies in the morning and then conduct deliveries in the afternoon and evening. So surgeons used to conduct autopsies in the morning, and in those days it was supposed to be a matter of pride if you had that apron which was caked with blood, with all those things. It showed that you were an experienced surgeon. It showed how much work you had done. So those aprons used to be caked and become stiff with blood, fluid and all other things. and those were worn with great pride by the surgeons, and they used to perform the surgeries on the, they used to conduct deliveries and perform surgeries on the woman, and they just used to pop off. Whereas nurses, not because nurses were not doctors, they were prohibited from touching the cadavers. They were prohibited from doing dissections. They were prohibited from conducting those autopsies. So that's why they would directly deliver the babies. And because they were nurses, they used to take pride in their starched white aprons and clothes. So they were very clean. And whereas the surgeons were supposed to be full of contamination. And then they realized, and then Ignace Simmelweis realized that there is so much of difference just because of hand hygiene and the cleanliness they maintain. And you won't believe it, you know how he died? He died in a mental asylum. He died in a mental asylum because people thought he was crazy to expound such ideas that hand washing would solve infection. That's why he was taken to the mental asylum and he died there. Ironically, he died of sepsis out of wounds which he received when he was beaten in the mental asylum. So definitely there are things which we can all change once we go back at home. One is the cleanliness of our operating theaters. I'm sure we would have all had lectures covering those things as well. Hand hygiene, reduction, proper workflow and reduction of unnecessary traffic in the ORs. The care and maintenance of equipment, especially a lot of reused equipment is there nowadays. Proper disinfection, proper re-sterilization. It is so common, you take a forceps, put it into Sidex for 5 minutes, get it on. All these cases where we see infections in camps, infection in multiple surgeries at one, and all these things find their way because of these bad practices which we follow, which we accept, and which we take, which these are considered to be a norm. Once you go back, it is your authority and prerogative to put a stamp and end all these bad practices. You should go in and usher in an era of good practices. So there are certain special considerations, especially in cardiac surgery and orthopedics, where people would screen for staph aureus. They would take axilla swabs, nasal swabs, and all. But those routines are not indicated anymore. So I think once we all go back, everybody can form teams in their hospitals to control, especially in the surgical side, establish a baseline, what is our infection rate and how we can eliminate at least 60% of it, and then have directly observe what are the practices which we follow, what are the processes which we follow, and what is our environment. There is a term called elephant in the room. Elephant in the room means there is an elephant in the room, but everybody behaves as if it doesn't exist and go on around our work. So it is a very common attitude for us that if I say there is an infection in my OR, I say it is only because the OT air conditioner is not good, and unless that is addressed, it won't sort out. Somebody will say it is only because that corridor, people are walking in that corridor, unless that is observed, that won't do. Somebody will say it is only because there's something else happening in the post-operative recovery room. We have to realize that it is a sum of all these things. So at every stage, be it our environment, be it the processes which we follow, or be it the practices which we follow. Some will say because betadine is diluted. Somebody will say because our spirit is contaminated. Somebody will say you don't give proper, our antibiotic is second grade, whatever. But we have to realize that it is the sum of all these things and not just one of the reasons. Though that one reason may be important, we have to pay attention to all these things. What is not a part of surgical site infections, which are not known because it's our tendency to overcome these shortcomings, we tend to give higher antibiotics. Arre vancomycin denge, linezolid denge. These will not prevent. It will just encourage resistant organisms to grow. Sometimes we'll say our patients are weak, let them supplement them with parenteral nutrition. Let me use antibiotic impregnated sutures. There are new ones coming. Let me use Steridrape which has betadine in them. They are known to control infection better. These are not, there is no evidence to support all of these. There is no evidence to support all of these. very, very basic practices which we all know, but we all know at some point or the other in the course of a patient are being breached. Those are the ones which are there are certain unresolved issues. Should we give gargles of chlorhexidine, or should we use sponge, gelatin impregnated sponge and all? In fact, recommendation, this lecture itself is supposed to be of doubtful value whether it really prevents. I mean, I saw it such a paradox that if you listen to these lectures, do they really reduce the incidence of infection? Why there's a query about the value of these is, the value will all depend on everybody going back and implementing these things. So implementation is the key, and people here are much experienced and they all know how to reduce this. It's not for lack of knowledge, but it is definitely they should feel empowered to implement these things, on a more firmer ground once they are back into their. So once again, I request you to kindly ensure proper compliance with hand washing, with with rational antimicrobial prophylaxis, hair removal with clippers, proper glucose control, maintenance of temperature, and finally optimal hemodynamic and tissue oxygenation. We all know how to measure the outcomes of surgical site infections, and with this very obvious message, I conclude and I wish you all the best. Thank you very much. I re-emphasized again and again that these are things which we all know. It's just a reinforcement, and this is just empowerment to implement them once they go back. Thank you.
Thank you, Amrit sir. It was very wonderful presentation. And now I request Dr. Venumada. Sir is a surgeon from Surgical Gastroenterology Department. Sir is going to give his lecture on bundle care prevention of CLABSIs, central line associated bloodstream infections.
Good afternoon, everyone. My talk is on bundle care for prevention of CLA BSIs. So, how many of you use central lines in your routine practice? Can you raise your hand, please? So, central line is a very useful. First, I will define what is a central line. It is defined as an intravascular access device or catheter that terminates or close to the heart or in one of the great vessels. If you see the heart, if the catheter terminates somewhere here, either in the jugular vein, subclavian vein, these are called central lines. And for down, even the external iliac veins, common iliac veins, femoral veins, these are the veins which are, when the catheter lies in this one of these great vessels, it is called central line. So, what are the examples of central line? Any central line inserted into jugular vein or a subclavian vein. Sometimes what is called a PIC catheter is there. It's a peripherally inserted central catheter. You access the basilic vein and then go as far as to the superior vena cava. So this is called peripherally inserted central vein. So these are examples of central vein. So my talk is on CLA BSI. What is CLA BSI? It is central line associated bloodstream infection. So this is central line venous line has got a very rapid role in modern healthcare with increasing ICUs and modern care. It has become an integral part of our care. It is used for administrating IV fluids, blood products, medication, parenteral nutrition, hemodialysis, and in sick patients for hemodynamic monitoring as well. Central line is very useful. However, because the line is in the major blood vessels and once infection occurs, it causes significant bacteremia, and the infections associated with this central line are associated with significant mortality and morbidity. And some products like total parenteral nutrition, which is high in glucose and lipids, these and blood products, if they are administered to central line and if there is an infection, this can cause significant bacteremia and lead to loss of life. how this risk occurs is it can caused by microorganisms which colonize anywhere the microorganisms are there. They can colonize either the external surface of the device or the fluid pathway. So these infections can very well be prevented, provided when the device is inserted, you take precautions, and as long as the device is there, if you take care of it, you can prevent these infections. And if you do all this, it can cause significant decrease in morbidity, mortality, and most important, healthcare costs. The most ICU settings, the problem is due to infections, patients dying of infections, and central line associated bacterial bloodstream infections are very significantly seen in our setup. So preventing this can cause a significant decrease in mortality, morbidity, and healthcare costs. And most of these are largely preventable when we follow evidence-based guidelines when we insert and maintain the central venous catheter. So it's very important to follow these dictums. So there are two things. One is central line associated bloodstream infection. The other is catheter related bloodstream infection. So to define, central line associated bloodstream infection is a primary bloodstream infection. There should not be any apparent infection at any other site which can explain the cause of bacteremia, and the central line should have been placed more than 48 hours before. So this if this is satisfying, then we call it as a central line associated bloodstream infection. It is used mainly for surveillance purposes to identify bloodstream infections. So to label a patient as central line associated bloodstream infection, you don't need the culture of the catheter tip or peripheral blood. So this definition may overestimate the true rate of central venous infections, but in our setups, especially if central line is there in ICU more than 48 hours and if it's not handled properly, if it's not inserted properly, in 80% of the cases the complements is breached somewhere because of lack of education among various staff working with the central line. This is not an overestimate. Usually the central line associated bacteria are underreported in our setups, what I observe in my routine clinical practice. The other one is catheter-related bloodstream infection. It requires a more rigorous clinical definition. It requires a culture of the catheter tip, and it requires also the time for the positive culture. So one culture is sent through a central venous line, the other one is sent through the peripheral line, and also the catheter tip may be sent sometimes. And there are semi-quantitative and quantitative methods to diagnose what is a catheter-related bloodstream infections. So this is a more authentic way, and it is used for monitoring purpose as well. So as I said, central line related catheter infection it can be very common if you don't use appropriate practices, as highlighted very appropriately by Dr. Amrish in my previous speaker. So there are various methods where the central line can cause contamination. As you see, this is a central line and it's inserted into the great vessel. This is the skin. And these are the ports and hubs, and this is the infusate. So when the contamination is within the infusate, either it's due to manufacturing problem or contamination within the hospital, it can directly enter the blood through the central line into the great vessel. Then if the inlet is malfunctioning, or if there is a contaminant, if you use too many pokes and allow bacterial migration, this can be one of the source for central line infections. Then when you when you insert the set itself, when you are changing the infusion bottle, if your hand hygiene is not good, then again the central line infection is more likely to occur. Then these inlet filters, which all have this may trap bacteria and shed toxins if it's not properly taken care of by the nursing staff and other who are using by healthcare personnel. Sometimes these central lines are also used for monitoring. They say central venous pressure monitoring or manometry. If these stopcocks and these are not properly handled, these can cause infections. Then to maintain this central line infection and ports, sometimes you may have to flush all the ports with heparinized solution. If that heparinized solution is contaminated or used for days together, not freshly prepared, then this can be a source of central line infections. Then the most important thing is when you insert, if the skin is not properly cleaned, then that is the most common site of central line infection. And sometimes an infection elsewhere in the body can can spread by blood and infect the catheter tip. So this may also cause central line infections. So for a central line to be infected, it can be by hematogenous spread coming elsewhere from the body, which is very rare. Intraluminal spread, if it is not handled properly by the nursing staff and the healthcare personnel, even doctors, it can cause infection. Extraluminal spread and contaminated infusates are also very common. So extraluminal spread occurs when skin organisms, most commonly these are staphylococci group of organisms. They, if the skin is not properly cleaned, they can come into the insertion site and catheter hubs. And this is the most likely source of an infection if the catheters are in place for less than 14 days. If the patient is long-standing, gram-negative infections may be more common. So I will just highlight what are the high-risk groups where the central line infection and low-risk groups. If the central line is inserted in emergency, it's a high risk, more chance of infection. If it is inserted by a specialist, there is low risk of infection. Depending on the insertion site, if the femoral vein, because of contamination there is high risk of, if femoral vein is selected in the leg, it will be causing more infection. Depending on the skin antisepsis, of late there is data that if you use 2% chlorhexidine preparation, there is the chance of central line infection is significantly reduced compared to 10% povidone iodine and 70% alcohol. Depending on the catheter lumens also, if you are using multi-lumen compared to single lumen, there is high risk of infection. The longer the duration, the more the risk. And the barrier precautions, if they are maximally used, there is very low risk of infection. So it's very, very important that you prevent these infections because these will be life-saving, and it's a life-saving device for in ICUs as well. So they have devised a bundle. What is bundle? It is a set of evidence-based measures that when implemented together, they will give 4 or 5 steps. All of them has to be implemented together, and if they are implemented together, they have been shown to produce better outcomes and have a greater impact than implementation of individual measures. So the central line associated bloodstream infection bundle, this identified a group of interventions, and these are supported by the very highest level of research, and all are very basic things as highlighted by Dr. Amrish sir also. And when they used together would ideally produce better outcomes than if one or more had been used separately. So what are these bundles? So there are 5 evidence-based interventions which can cause significant reduction in infections. First is hand hygiene. The second one is maximal sterile barrier precautions upon insertion. You take maximum precautions when you are inserting, and then when you prepare the skin, it should be chlorhexidine based. Ideally, it should be 2% chlorhexidine skin preparation. Then when you select a site for central venous insertion, it's better to avoid femoral vein. And also important to daily review of the central line, whether it's necessary, and prompt removal if it's unnecessary. So if you couple all this together, there's significant decrease in infection. So this is a pictorial diagram. These are all presented by ICMR in association with AIMS and CDC. So this is copied from that. So hand hygiene is the most important thing. Then comes the maximum barrier precaution. You drape yourself completely, taking maximum barrier precautions. When it comes to skin antisepsis, it's very important that you select the appropriate antiseptic. 2% chlorhexidine, most important. If it's not available, then you can go for povidone iodine. If patient is allergic, you can go for povidone iodine as well. And most important is because you are inserting central line, most people think that it's enough to drape just the neck part or area part with a whole towel. It's not enough. You have to use a full body drape as used in operation theater. The entire body has to be draped by a full body drape. And it's very important. These 4 are very, very important. And then during maintenance, you have to daily review the line necessity. If the line is not necessary, it's better to remove. And of course, the optimal catheter site is very important. And scrubbing the hub, that I will be dealing with later on. So all these together will significantly decrease the central line infections. You can say that there are resource limited situations, so what to do? Even in all the resource limited situations, all this is possible. Hand hygiene is possible. maximum barrier precaution is possible. Skin antisepsis, probably if 2% chlorhexidine is not possible, then you can use 0.5% chlorhexidine with alcohol or betadine. Full body drape, if full body drape is not possible, then the ICMR guidelines is you can select 4 towels and then make a small hole, and then still with whatever available towels in any operation theater nowadays, you can get towels. With that, we can prepare this maximum sterile barrier precautions with full body drape before inserting a central line. It's very important to use this. Of course, we can avoid femoral line unless required, because femoral line insertions are also with higher risk of DVT and higher microbial colonization. Of course, even in resource limiting situation, daily review of necessity of lines and chlorhexidine skin antisepsis has to be followed. So even in resource limited situations, all these steps can be followed and very useful. So the CDC, the American guidelines, they have categorized the recommendations for preventing CLBC into 3 types: 1A, 1B, and 2. 1A and 1A is highest level of recommendation. 1B is also high recommendation, and 2 is also based on expert opinion. So education, training, and staff. Unless you educate the healthcare personnel, everybody knows that these precautions has to be taken. Unless you educate the healthcare personnel about the importance of these precautions, you will not be able to prevent these infections. So education, training is very important to prevent these infections. Periodically, you have to assess knowledge. Not only once education is not gone away, it has to be periodically assessed, and whether they are adhering to all the guidelines. Suppose all the guidelines are being followed or not, you have to compulsorily check with, and it should be reinforced by the administrators. And all personnel should be trained for insertion or maintenance of IVC. It should only designate only trained personnel, and we should also ensure appropriate nursing staff levels in ICU, because if one nurse has to take care of 10 people and of them 2 or 3 are infected, then it's not possible to ensure all these precautions in these patients. So education, training, and staffing is very important. Then coming to the selection of the catheter site, in adults, upper extremity site can be selected. Avoid using of steel needles, especially for administration of fluids and medication. Use a midline catheter or peripheral inserted central catheter, especially if peripheral line has to be used for more than 6 days. Then once the catheter is inserted, it should be inspected daily by palpation through the dressing, or if the dressing is transparent, by inspection. These are very important to prevent infections. And this gauze and opaque dressing should not be removed if the patient has no clinical signs of infection. If the patient has local tenderness, then you have to remove the dressing and then inspect it visually. So it's better to use a subclavian site rather than jugular or femoral if possible. And when you are to avoid infection, you should use the minimum number of ports. If you are using not using all the 3 ports and using, then the chance of infection is more. And most importantly, you have to promptly remove any intravascular catheter that is no longer essential. When especially sometimes in medical emergency, or when we have to place in all the aseptic techniques may not be followed. In that case, we should strongly consider to replace the catheter within 48 hours if you have not followed all those bundle techniques which I have illustrated. So you should even think of replacing the central line catheter within 48 hours if it's placed in emergency, not following all the steps. Then coming to hand hygiene and aseptic technique, you should perform hand hygiene procedures either by washing hands with conventional soap or alcohol-based rubs. Hand hygiene should be performed before and after palpating catheter insertion, very important, and also before and after inserting, replacing, accessing, repairing, or dressing an IVC. And you should not palpate an insertion site without application of antiseptic. You should maintain aseptic technique for insertion and care of intravascular catheters. You should use sterile gauze for insertion of arterial, central, and midline catheters. And you should use new sterile gloves before handling the new catheter when guide wire exchanges are performed. However, just for dressing or changing the dressing, you can use clean or sterile gloves for this purpose. Coming to maximum sterile barrier precautions, use maximum sterile barrier precautions, including use of cap, mask, sterile gown, sterile gloves, full body drape for insertion of central venous catheters, peripheral inserted central lines, and guide wire exchanges. There's no compromise on that. Then coming to skin preparation, you can use skin with antiseptic 70% alcohol or tincture of iodine before peripheral venous catheter insertion. Clean skin with 0.5% chlorhexidine preparation with alcohol before central venous catheter and peripheral arterial catheter insertion and during dressing changes. However, our Indian guidelines now for central line placements, ICMR guidelines suggest 2% chlorhexidine if available. Antiseptics should be allowed to dry. Most importantly, once you apply the antiseptic, you should not be in a rush to insert the central venous line. The antiseptics is allowed to dry properly according to manufacturing recommendation before placing the central catheter. For this, to ensure the clinical infection nurse control in charge should be very important, especially when I was working in UK in Birmingham. The nurse stopped the doctor, said that point number 20 is mentioned that this has to be followed. I didn't follow, please stop the procedure. So that authority is there for infection control nurse or any supervising person. So we should be strictly, all the guidelines and objectives should be strictly followed. Then coming to side dressing regimens, use either sterile gauze or sterile transparent semi-permeable dressings to cover the catheter site. If there is excessive ooze or bleeding, then you may use gauze dressings until that is resolved. There is no role for topical antibiotic ointments because it can promote fungal infections unless the catheter has been used for many days, like dialysis catheters. And these dressings should be replaced periodically. So for short-term CVC sites, at least every 7 days for transparent dressings, you have to change the dressing. And you have to monitor the catheter sites visually. Especially this can be possible if it's a transparent dressing is palpable, placed. If it's non-transparent, then by palpation if there is any pain or any tenderness. You should be following these patients. And in long-term ICU patients, thorough bath of the patient with 2% chlorhexidine for daily skin wash should be used to reduce these infections. So the ICMR has given some guidelines, and all the articles required for central venous catheter insertion has to be procured beforehand, because in between if something is not there, then there may be breach of secretion. So you have to take help of all these things. All those articles required should be properly documented and then assembled. Then only you should start the procedure, and it should be in a very sterile manner as we used in OT. So all the items should be collected. Then it should emphasize that you should wear maximal personal protective equipment, including caps, masks, shoe covers. Then all the steps of hand washing has to be followed if you are inserting a central line, like surgery, like whatever. All the steps of hand washing has to be judiciously followed, because we all know all these steps of hand washing, and this should be judiciously followed. Then when you are donning a sterile gown also, it's very important that you don't have any breach. And when you are wearing glove also, you should make every precaution that you use the sterile flap of gowns to open the gloves and then wear the gloves. So all these precautions has to be taken before a central line insertion. Of course, once you identify the site, most probably it's the internal jugular or subclavian, you have to clean the skin in circular motion, and then it's better to use 2% chlorhexidine or 10% powdered iodine as disinfectant. So this is about insertion. What about maintenance bundle? There's also guidelines for maintenance. One is hand hygiene, is very important. Again, aseptic technique for accessing and changing needleless contractors. Every time you access, you should access the central line ports, everything. It has to be used by aseptic technique. It's very important. And when you change tube, you should follow all the standard guidelines when you are changing the IV sets, everything. And daily review of catheter necessity is also very important. So for hand hygiene, every time then it's better to discard the tube. However, the flow is there continuously, you can use for more than 48 hours also. But if for intermittently used IV fluid tubing, that the clear guidelines are not clear, but it should be used very aseptically when you are using intermittently, because that is chance when you insert infection into the catheter. And it's very important to daily review the catheter necessity during rounds, and whenever it's deemed unnecessary, the line should be removed. So when you are handling the hub, it should be very meticulously followed. You should perform hand hygiene, use sterile glove, use a scrubbing device, usually chlorhexidine or alcohol-based preparation. And for one hub, you should use only one pad. You should not contaminate that pad before, and it should rub for at least 10 to 15 seconds each hub, and allow the hub to dry. So whatever access ports are there, injection ports are there, you should handle only by a sterile technique. So it's very important when you handle these hubs, and it's very important to scrub the hub you are accessing every time you access it. So that not that I've just accessed it 5 minutes back and then you can't. You have to scrub the hub. You should be very vigilant in scrubbing the hub and to prevent these infections. So there is a separate class on surveillance. Not only this, how many of these aforesaid mentioned, these have to be documented in a monitoring form, which are available. It's very important and should be documented by a NASCARE infection control person, and it should be, all the things should be recorded. What is the reason for insertion, what's the insertion site, and whether hand hygiene was completed, and which of the following barriers were used. All this has to be used, and this should be audited. It's very, very important that you have these audit forms in your ward. So to summarize, these bundles are all evidence-based practices with ample literature supporting them. They all look simple, but if you practice them in cohesion, then it causes significant reduction in these infections. You have to educate on all the bundle elements, and each element of bundle requires special tests of change, because sometimes some practices may be adhered, because may not be adhered, like using sterile glove while handling these hubs. So how much is the compliance with all the elements should also be ensured using an audit form. So these are the references. Thank you very much. Yeah, what the advice is, if one of the port is blocked, then it no longer should be used. So if it is blocked, means if it is because of this mechanical problems, you can change via guide wire into a new site, because once it's blocked, then it must be some source of infection is there. So the second thing is, if it's you are suspecting infection, there's no role for changing over the guide wire. You have to place in a new line, because already the surrounding skin also may have been infected. So it's better to not to change the same site. So if it's blocked, it should. That's why it's very important for maintaining a central line. You have to flush it with heparin flush, which may itself be a source of contamination. So all those things, whether it's contaminated, how it is handled, aseptical way, is very important. So the number of, first we have to be educated, and then you have to reinforce, because somebody is not reinforcing, then you may not follow all the steps. Sometimes may just handle it without all the aseptic techniques. So it's very important that you reinforce all those things. Sir? Yeah. That's what, sir. So that means you have to periodically, you have to, if 3 ports are not required, it's better not to place 3 ports first, because most of the times it's not, the other 2 ports are not used. So most of the times we are placing extra ports, causing extra infection. And second thing is handling, periodically flushing of those things with sterile way. And then if it's blocked, the recommendation as per CDC is to exchange it over a sterile guide wire to a different thing. That is the recommendation. You want to show some? So the full body draping, which is not followed, it is not adhered to even in the best of the settings also, as even in our hospital also some complements is lacking. So madam is one who reinforces all the full body draping. So this custom made full body draping thing. You want to speak, madam?
This is the full body drape which we have created in our hospital. You can design your own. It may be a diamond slit or a square slit, where only that part where you are inserting the central line will be exposed. So from the head to toe, this is an intervention to prevent the CLABSIs, central line associated bloodstream infection. And the only thing is, you need to have additional cloth. You need to put up indent for all these things and try to implement in your setup. And one more which sir was showing repeatedly was 2% Bacto Prep that can be used for cleaning the skin before inserting the central line. It is recommended by CDC guidelines. So usage of 2% Bacto Prep, we want to show you what that is. Actually, it is a recommended one based on the trial studies. It was proved that rather than using the alcohol or povidone iodine, please go for the usage of 2% Bacto Prep, which is a combination of 2% chlorhexidine with 70% ethyl alcohol. Okay. Betadine. Okay. Was it? It's good you are saying. Yes. Yeah. Okay. Okay. Yeah. Yes, even now we don't say that whenever there is a contradiction or any allergic to these 2% Bacto Prep, then you can go definitely for the use of povidone iodine. But as per the recommendation by the guidelines of ICMR and CDC, it is advised to use 2% Bacto Prep, which leads to reduced incidence of healthcare associated collapses.
Still, I have one doubt about chlorhexidine.
Fine.
Chlorhexidine is a sporicidal or not?
Chlorhexidine is sporicidal.
Sporicidal.
Yes. Why? Because see, morning I have taken a class and I have said to you, especially excellent activity is against gram-negative and gram-positive pathogens. But whereas in case of few pathogens like Mycobacterium tuberculosis, there was a single plus sign, isn't it?
Yes,
If you have remembered the class. So against the Clostridium difficile spores, it has less activity.
Yes, yes.
Okay, alcohols will not work. They will remain resistant to this kind of diarrheal pathogens.
Okay.
Oh, that's why you need to use soap and water to wash your hands.
Okay, thank you.
One more comment I want to make. Most of the times, as surgeons also, we paint with povidone iodine, and immediately before drying, they just wipe it off. Its problem is not with all this bactericidal. It's problem with the guidelines how we are using. So these solutions, if as per recommended chlorhexidine, you should wait till the skin is dried. Then only you can insert. If betadine is there, you wait for the contact time. If you're not waiting for the contact time and before that you wipe it off, it's not going to work. So everything we know, but what the infection control practices should ensure that all these practices has to be followed and all the bundles should be followed and there should be no breach. Because any small breach in any practice can lead to infection, not only during insertion, during maintenance. So all these practices should be very reinforced, and we should also reinforce ourselves. Somebody should monitor ourselves because sometimes we may also breach. So the main problem is in our center, it's not underestimated. The central line infections are very rampant in our ICUs because one thing, the staffing. One sister has to cater to at least 4 or 5 patients, and among them 1 or 2 are some ESBL producing organisms, and the workers should be well educated. Everybody is handling the things, so the not with the solution with it's important what we follow. So it should be reinforced. Everybody should educate ourselves, educate others, and then it should be reinforced. That should be the guidelines.
Thank you. Any more doubts? So we are trying to show what interventions we are implemented at our institute, and so these kind of small things also can be done and practiced at your institute also. Thank you very much. And next I invite Dr. Zumana to give her lecture on bundle care precautions for preventing the QATIs, catheter associated urinary tract infections.
A very good afternoon to all of you. I know we have been discussing bundle care this, bundle care that. For so many different types of infections, it must be becoming all a little confusing. But okay, my topic is bundle care practices for prevention of catheter-associated urinary tract infections. Now, this becomes very important because for surgical site infection, CLABSIs, mainly it's the doctors and the nurses who are handling. But when it comes to a urinary catheter, we come across it in all the wards, in all the ICUs, and it is not just the doctors and the nurses who will be handling. Sometimes it's the ward workers, even the patient attenders as well. So if you are aware of the bundle care practices at all times, you can constantly, as infection control officers, you can constantly keep correcting. And it would be a good idea to have them put up in all wards as well. So I know we are running a little bit behind time, so I'll try to go through quickly. In my presentation, basically, I'm just going to give you a brief introduction, and then I'm going to discuss, according to the CDC, they have some prevention strategies. So we are just going to discuss those, and at the end of my presentation, I will give you the bundle. The bundle, just to review, are those set of interventions that, if all practiced together, will improve patient outcomes. So this bundle has been given by the Ministry of Family Health and Welfare, and according to the National Infection Prevention Control Practices. So at the end of my presentation, I'll discuss that bundle with you, which is just 2-3 slides. But in the beginning, we'll just go through the CDC prevention strategies. So now urinary catheters, as we all know, are placed for a number of reasons, for either for diagnostic, for therapeutic, or just simply for convenience. I'm sure we all have known patients in our own families who have been bedridden on a Foley's catheter for months on end. So it becomes very important to know how to prevent infections here. Because bacteriuria in these patients with an indwelling catheter, the rate approximately is 3 to 10% per day. So as each and every day goes by, the chance of getting bacteriuria in that indwelling catheter goes up by 3 to 10% per day. And out of these, 10 to 25% develop a symptomatic urinary tract infection. Now, a catheter-associated UTI occurs when bacteria enter the urinary tract through the urinary catheter. And this can be divided into a symptomatic bacteriuria, where you need only a 10 to the power of 3 colony-forming unit per ml of this uropathogenic bacteria with signs and symptoms of UTI. When we call it asymptomatic bacteriuria, when 10 to the power of 5 CFU per ml is grown, but patient remains asymptomatic. So here these are just pictorial representations, sagittal section of female and male, to show how the catheter looks when it is placed. So as you can see here in the female, the urethra is much shorter. So the chance for infections are much higher because it is easy for the bacteria to ascend. Whereas in the male, still a little convoluted path. But if again proper practices are not followed, it is very easy for the bacteria to ascend here as well. So risk factors for developing this bacteriuria and then infection. For bacteriuria, if at all there is a disconnection of the drainage system, if a person who is not trained well enough has inserted the catheter, if the catheter has been placed outside a sterile environment, a patient having incontinence or diabetes, if there is meatal colonization with these bacteria, if there is not proper preparation of the meatus when you are inserting the catheter, if there is any renal dysfunction or any orthopedic or neurology services. Now this bacteriuria can lead to a symptomatic UTI. So risk factors for that are bacteriuria, prolonged catheterization, females of course, as I showed you in the previous picture, elderly people, and impaired immunity due to any reason. So as you can see here, these are the pathways for entry. This is the urinary bladder. This is the Foley's catheter which is inserted here. So the bacteria may enter the urinary tract here during insertion, or bacteria may move up along the catheter like this. If there is a break in the tubing, with the collection bag, then bacteria can enter through here as well. If the collection bag itself is contaminated, again bacteria can ascend up to the urinary tract. So now we will be discussing the prevention strategies that have been suggested by the CDC. Okay, so they have divided that into 6 categories. Now these categories are, first of all, number 1, appropriate urinary catheter use. Don't just use it for any and every patient. It should be used in an appropriate setting. Number 2, the insertion of it. It should be properly inserted by a trained professional. Third is, then once you have inserted it, to maintain it properly. Okay, so these are at the level of the treating people, the nurses, the doctors, or whoever is doing the actual, person-to-person insertion of the catheter. Then there are things at a larger level, your quality improvement programs, for example, this training session is part of that, administrative infrastructure, and surveillance. I think there will be a separate class on surveillance. So we will be concentrating on these 3 strategies. So what is appropriate urinary catheter use? We should insert catheters only for appropriate indications and leave in place only as long as they are needed. Because as I told you, every day the chance of getting the bacteria increases 3 to 10%. Then avoid urinary catheters for management of incontinence. Usually they say that, you know, just because the patient is bedwetting or whatever doesn't mean you need to put a catheter in there. A diaper can be used. In males, condom catheters can be used. Okay, use urinary catheters in operative patients only as necessary. Remove as soon as possible post-operatively, preferably within 24 hours. Consider using external catheters, as I said, that is a condom catheter for male patients who, when you're keeping it there only for incontinence. If there is no bladder outlet obstruction or there is no urinary retention, then you may as well have the condom catheter and not do an invasive procedure on that patient. Consider intermittent catheterization in patients with bladder emptying dysfunction. So neurological patients with a neurological bladder, they can be trained to intermittently catheterize themselves rather than having an indwelling catheter continuously. Okay, so that is appropriate use of the catheter. Now, proper insertion of the catheter. As everyone has mentioned since the beginning of the session, proper hand hygiene has to be performed before and after insertion, and even if you're going to be manipulating it, not just during the insertion, anytime you want to touch that catheter, before and after hand hygiene is a must. It should be inserted only by a properly trained individual. I think there are practices in many hospitals, I'd say even we are guilty of it, where, you know, the ward workers have, you know, sort of picked up how to put in the catheter and have been practicing it regularly when there is too much workload, especially in the ICUs or the emergency department. We should try to avoid that practice and, you know, inculcate that either the trained nurses or the doctors themselves have to put the catheters in place. Use an aseptic technique, sterile gloves, drape, sponges, an appropriate antiseptic or sterile solution for periurethral cleaning, and a single-use packet of lubricant jelly for insertion. Oftentimes, there'll be in that trolley, there'll be one tube of lignocaine jelly, which will be used from one patient to the other. And you know that, you have touched the catheter here and there, you've rubbed it all over that thing, then it'll be used for the next patient. You're just spreading infection like that. You should make sure that the patient buys his separate lignocaine jelly to be used for the catheter insertion. Then you have to secure the catheter once it has been inserted to prevent movement and urethral traction. Okay, we secure it to the thigh. There are actually devices to secure that catheter in place, but we are just using a plaster or whatever, but still it should be secured properly. Use the smallest bow catheter possible to minimize trauma to the bladder. If intermittent catheterization is used, perform it at regular intervals to prevent bladder overdistension. Okay, so we have discussed appropriate catheter use, we have discussed appropriate insertion. Now, how do you maintain it once you have inserted? You should always maintain a closed drainage system. Okay, if breaks in aseptic technique, disconnection or leakage occur, the catheter must be replaced. The urine outflow should be unobstructed and gravity dependent. I'll just show you a picture demonstrating all of this. And the catheter should be kept free of kinks. So see this here, this is the patient lying here. The tube should not be going under the thigh. Sometimes what we see, the catheter is taped on one thigh and then it crosses over to the other side to be hung over on the other side of the bed. It's under the patient, over the patient. It should not be like that. And here see how it is coming down this way like that and attached to the frame of the bed. Okay, keep the collecting bag below the level of the bladder at all times. Do not rest the bag on the floor. Often what we see sometimes when patients are admitted and then being shifted, so casually the attender will pick up the Euro bag and throw it on the patient's abdomen like that. And the patient will come into the ICU with that Euro bag on his abdomen. That's not to be done. It has to be hanging from the side of the trolley. The trolley also has a place where that Euro bag can be tied. Okay. As post-op, when they're shifting from the OT, they'll come in like that with that big bag of urine lying on them. That is not to be done, but it should not be dragging on the floor either. It has to be attached to the bed. The collecting bag has to be emptied regularly, okay, in a clean collecting container for each patient. We should avoid splashing and prevent contact of the drainage spigot with the non-sterile collecting container. So this is very, very important because here, these Euro bags, often the patient attenders are emptying them. Otherwise, the ward workers are emptying them. The ward worker will come with one big bucket and go around the ICU emptying out everybody's Euro bags into that thing. You're passing infection from one patient to another. Every patient should have their own container that is labeled and is clean and meant only for their Euro bag. But that is not happening here. The same, or the patient attender will bring one mug from the bathroom and pour in that, splash it everywhere here and there. That is extremely unsterile. So we have to be very careful about that. So as infection control officers, these are things that when you go for your rounds, you will constantly keep seeing, and it's very easy to implement and say, no, don't do that, no, this is not allowed, and keep on reinforcing, and that will automatically reduce the incidence of these SCOTs. We should use standard precautions, including the use of gloves and gown as appropriate during manipulation of the catheter or collecting system. Now, once the catheter is inserted, many times, the doctors will come and write, send urine for culture, send urine for this. So at that time, how do you collect the sample? You will have to, again follow aseptic precautions, make sure that you are disconnecting only at where the Eurobag is connected, and collect straight from the catheter itself, not from the Eurobag. The only time you would collect a sample from the Eurobag was if you need a large volume of urine, for example, a 24-hour urine collection. Okay, changing indwelling catheters or drainage bags at routine is not recommended. So you don't need a fixed interval that, okay, now 1 week is up, now we need to change. It's not that. If there is any disruption or if there is any, contamination, then you change. And no need for a prophylactic antibiotic. If you follow the standard bundle care practices, then this prophylactic antibiotic is of no use. Do not clean the periurethral area with antiseptics to prevent clotting while the catheter is in place. Oftentimes you think that, okay, now the patient was shifted from here to there, we touched this by mistake, we'll clean this area with betadine that will prevent the infection. No, that is not to be done. But in the bundle care practices, they recommend that you can wash with soap and water, but not to be cleaned with an antiseptic. If obstruction is anticipated, you can do a closed continuous irrigation to prevent obstruction, but this is not, usually in our setup, we are not able to do all this. And another practice that we commonly do once the doctors come for rounds and say, okay, now you can remove the Foley's, we clamp and then we remove. But just to see if the patient is getting the sensation. But that is not recommended because that is causing a stagnation of urine, and then again the bacteria can ascend up into the urinary tract. So clamping the catheter before removal is not recommended. Now, what catheter materials can we use? Here we don't have too many options. The only thing we can keep in mind is if a person is using a catheter for a prolonged time, these silicone catheters can come in handy. These antimicrobial, antiseptic, impregnated catheters I have not seen being used here at all. If you at all you find that there is an obstruction in the catheter, change the catheter. There is some studies showing that continuous irrigation of the catheters and all, but again it is very difficult to practice here. So if you suspect an obstruction, don't try to flush and do all those things, because again you're just pushing the bacteria back into the bladder. Remove the catheter and change it. Specimen collection, as I already mentioned, collected straight from the catheter itself. The best time to collect is when you insert the catheter. That time the urine that comes out, send that for sampling immediately. Okay, and don't collect from the Euro bag. Okay, so this is just to show you the maintenance of the catheter and the Euro bag. See that the catheter, the Euro bag has to be attached here to the bed below the level of the bladder but not touching the floor. See, this is wrong here. See this loop, this gravity dependent loop should not happen. It should come straight down like that or something like this. This stagnation of urine is not allowed. Okay, here there is a clean container here that is labeled and used only for emptying for this patient. Okay, here I just wanted to show you, this is that device that they use to fix the catheter to the thigh, although I've never seen one here, we're just using a piece of plaster. This is a special port on the catheter for drawing samples, but again the Foley's catheters that we have in our setup don't have this. Okay. So we have discussed the three main things that are applicable to the people inserting the catheter. Appropriate insertion, insertion with using the correct techniques, and the proper maintenance. Then these quality improvement programs and all are at a larger level. Okay, the purpose of these is to assure appropriate utilization, to remove catheters when it is not required, and to ensure adherence to hand hygiene and proper care of catheters. Your administrative infrastructure becomes important for providing guidelines, education and training like we are doing now, providing the appropriate supplies proper documentation and surveillance resources. Okay, so now this is now published on the website of the Ministry of Family Health and Welfare. These are the National Infection Prevention and Control Bundle Guidelines. Okay, so it's divided mainly into two categories, the COTI Insertion Bundle and the COTI Maintenance Bundle. Now, under the COTI Insertion Bundle, you have the first point is verification of need prior to insertion, as I discussed in the CDC guidelines, that it should be an appropriate indication for insertion of the catheter. So either for urinary retention or obstruction, an immobile patient, lack of bladder control, patient request for an end-of-life patient, perioperative for selected surgical procedures, and assisting with pressure ulcer healing for incontinent patients. The next point is insert the urinary catheter using an aseptic technique. We already discussed all of this, the sterile lubricant being important here. Then maintain the urinary catheter based on recommended guidelines, as we already discussed, the CDC prevention strategies, securing the catheter properly, maintaining an unobstructed flow, maintain the drainage bag below the level of the bladder but above the floor, hand hygiene before and after each patient contact, individual labeled collection container at the bedside, and review the urinary catheter necessity daily and remove catheter promptly when not needed. Okay, then the second point is the COTI maintenance bundle. In this, you have daily documented assessment of need. So whenever you see the patient, keep it in mind. Is the catheter required? Is the catheter required? You have to ask yourself every day. Catheter secured, device to secure catheter in place, hand hygiene again, daily meatal hygiene performed with soap and water, but not an antiseptic, drainage bag emptied using a clean container, and unobstructed flow maintained. Okay, so I think these bundle guidelines can be pasted in any ward, and if you keep reading it every day, then you can keep reminding everyone who is working in that ward also to keep on practicing. So the take home message here is proceed with caution. Okay, these are my references. Thank you. Are there any questions?
Thank you. Dr. Zumana is Associate Professor from the Department of General Medicine. And actually tomorrow you have a class on surveillance of QWERTY and also CLABSIS. So in that surveillance you will come to know very clearly that how you can perform surveillance in your own areas. And so there are certain forms which have been given by the ICMR, and we are doing the project of the same ICMR even at our institute. So we have done phase 1 CLABSIS and QWERTYs, and now we are entering into the phase of surgical site infections also, where already Amrish sir has shown the format of SSI surveillance format. So we are using the same.
Here I want to give one advice.
Sure.
Most of the gynecologists, they will put behind the thigh, that
Okay.
tubing. They don't keep Sumalata, if I am right, because sorry to say, and because I know her since so many years, so that's why I am called by name. And so many gynecologists outside practice hours, all gynecologists, they will keep behind the thigh tube. All surgeons, neurosurgeons, they will paste above the thigh. So as he said, so what is the difference between if you put like that, what is going to happen?
So once the catheter is there under the patient, sir, automatically it is near the perineum and it's on the bed. The catheter will get colonized and the bacteria will ascend up through the urethral tract.
Soiling incidents, because of soiling incidents. Most of the gynecologists know if they put upside, they don't get urine flow. They in their mind, they will think like that. They are most of the times outside also, most of the gynecologists cesarean sections are performing like that only.
Maybe it is just to keep their view clear, sir.
No, not like that. Not keeping view.
Keeping under the thigh, sir? Yes, okay.
They will think that there won't be any flow obstruction, because if they keep upside, so there won't be much flow in their right. So what is your this one? You are telling that gravity. Am I right or not?
Yes, sir.
So it is a gravity dependent. So if you keep the police catheter above the thigh, so the gravity is not going to affect it.
sir, in the female, the urethra is there only, so it will just go straight over the thigh. It will not go up like that.
They will keep behind the thigh, madam.
But then that's what, sir. Then
Their concept is, that's what, which is right. So, they are right or you are right. See, they are using
according to the CDC guidelines.
they are using since so many years.
Yes.
They are practicing like that only. So they don't have any, they will say that we don't have any this one infections and all. After 2 days we will remove the catheter. So far we didn't get any complications.
But
why
as
do you
per
want
the
to advise like that?
guidelines,
See, the same, that's what I am asking.
The guidelines are based on evidence-based medicine, no sir. So they, and
So
according to the CDC,
gynecologists also, they see, they have also so many quantitative tests, not even though they are not qualitative, they have so much quantity. Experience and evidence based on that is also evidence based. So far we didn't get any this one.
theirs is a short duration of catheterization also,
Yes,
no sir?
exactly. For that reason, because they will keep only 1 or 2 days catheterization. For that, no issue if you keep whatever the position is.
But as per the guidelines, they say that it should go over and it should not be under the patient.
Because they are not in a position to ask, because I have observed them, so I am asking.
Okay, sir. Yeah, no problem.
You want to break for a tea, and after the tea only 2 sessions are there. No? You want us to continue? Tea, after tea break you can come and join, only 2 sessions. Inside it is not allowed to serve, that's the only reason. All are tired with sessions, I believe. Yeah. So continuously we are saturating with a lot of subjects. That's why we are asking you to break for a tea, and then we will continue.
Are there 2 classes?
Only
Just
2.
Finish it off.
2 sessions are there.
Finish it off.
Fine.
The next talk will be by Dr. Parvati. Ma'am is the talk is on OT protocols during surgeries. I invite ma'am to please start her talk.
Good afternoon, everybody. Shall I start or 5 minutes break? I'll wait, no problem. Okay. So I want to say 2 things. One is I'm not a good speaker, but most of the things are repetitions. Please bear with me. I'll try to finish fast. So surgery-associated complication is a major global concern because half of the surgery-associated complications and deaths are preventable. The team of members in operation theatres working together effectively can avert a considerable proportion of life-threatening complications and morbidities. So the surgical safety has become a significant global public health concern. The most common cause of surgical site infections is a serious surgical complication. The teamwork's safe anesthesia, prevention of surgical site infections are the fundamentals in improving the surgical safety and saving the lives. WHO has given a list of surgical safety checklist. It has 10 essential objectives with a surgical safety checklist. It is to be followed by all the persons in the operating room to reduce the risk of such complications. So among these 10 essential objectives, one of the most important is the care must be taken to minimize the formation of surgical site infections by using proper measures. We'll just go through the operation protocols. So Joseph Lister introduced the principles of antisepsis that decrease the postoperative infections morbidity substantially. The advances in infection control practices, improved operating room ventilation, sterilization methods, barriers, surgical technique, and antimicrobial prophylaxis. All these things have contributed to reduce the morbidity, but still the SSIs remain a substantial cause of morbidity and mortality. What is surgical site infection? You must have been repeatedly listening to that. It is the infection that occurs in surgical patients at the site of operation that occurs within the 30 days of operative procedures. In some surgeries, all deep infections related to the post-operative site and to the implant within 1 year of an operation should be considered as a post-operative infections. The problem is sometimes very serious, and it is costly. It is associated with increased morbidity and mortality, as well as with the prolonged hospitalization. Now recently it has become a marker for the quality of surgeons and as well as the hospitals. Approximately 2 to 5% of all surgical patients tend to acquire surgical site infections. In developed countries, it is the second most common cause of healthcare associated infections. In India, it is up to 25%. So the 2/3 of surgical site infections are incisional infections, and 1/3 are deep organ space infections. This leads to an average increase in the length of hospital stay of up to 4 to 7 days. And as much as twice the infected patients may die, and twice of them may need intensive care units, and 5 times more likely to be readmitted after discharge. That is the burden of surgical site infections. So these infections are primarily acquired during operative procedures when the wounds are still open. So the stringent protocols need to be followed at this point to minimize the surgical site infection. The effective infection prevention and control is essential to ensure the safety of the patient as well as the people who are working in the operation theatre. The main source of surgical infections, surgical site infections, is endogenous flora. Usually, the aerobic gram-positive cocci of the patient that are present in the skin, mucous membrane, or the hollow viscera. The exogenous sources are usually from the members of the surgical team, the surgeons, nurses, anesthesia team, and all those things, all those people, and the environment of the operating theatre. The tools, materials, instruments which are used in the sterile zones during the procedures. What are the strategies? The strategies to prevent and control the occurrence of infection is by reducing the contamination by microorganisms on the surgical instruments and body of the patient, prophylactic preoperative antibiotic coverage, carrying out the surgical procedure carefully, and proper handling of the operating room. So there are many factors which contribute to the risk of surgical site infections, and their prevention is complex. It requires implementation of complex measures before the surgery, during the surgery, and after the surgery. It is influenced by the characteristics of the patient, the operation itself, the personnel who are around in the operation theatre, and the hospital also. So I am going to give the recommendation based on the national guidelines for infection prevention and control that are given by Ministry of Health and Family Welfare. These are based on the WHO 2016 recommendations. It is almost similar with the CDC guidelines also. The characters that may influence the risk of surgical site infections are basically the patient characteristics and operation characteristics, pre and intra and post-op, as I said. The patient characteristics play an important role. There are so many characteristics, but few are very strongly associated with the surgical site infections, like diabetes, obesity, where the body mass index is more than 30 kg per square centimeter, and prolonged duration of surgery, and the wound classification itself. The other things are coincident remote site infection, colonization, especially the nose, and other areas. Cigarette smoking is also associated, but it is not a strong recommendation as per the recommendations given by the WHO. And the systemic use of steroids, extremes of age, the children and old people, poor nutritional status, and perioperative blood transfusions, and prolonged preoperative stay in the hospitals. So all these have shown to be associated with increased risk of surgical site infections. The operative characteristics: preoperative antiseptic showering, preoperative hair removal, patient skin preparation in the operating room, preoperative hand and forearm antisepsis, management of infected or colonized surgical personnel, antibacterial prophylaxis. The intraoperative issues, it includes the operating room environment, ventilation, environmental surfaces, microbiological sampling, conventional sterilization of the surgical instruments, flash sterilization also. And other things in the operating room includes the surgical attire and drapes, asepsis, the surgical techniques followed by the surgeons, and of course the post-operative issues also will also influence the surgical site infections, like incision care and the discharge planning and follow-up. Coming to the operating room, the various things that are to be recommended as standards. It is where the procedures are carried out in aseptic environment. All the personnel concerned must have proper understanding of the working of the operation theatre, abiding by the certain rules, regulations and professional guidelines. So the infection control in the operation theatre is the key to decreasing morbidity and mortality among the patients undergoing surgery. The essentials that must be present in the operating room are adequate lighting, proper ventilation with 20 SEH, that is air changes per hour, correct and sufficient instruments needed for the surgery, proper machines, equipment for monitoring the condition of the patient during the surgeries, emergency drugs, and rooms to be present to carry different other procedures. The location of the theatre should be adequately lighted and ventilated away from the busy areas. The recommended size of the operation theatre is 6.5 into 6.5 into 3.5 meters, and it can be modified as per the requirement depending on the number of tables and number of personnel and all those things. That is the minimum standard. Doors and windows should have a separate entry and exit rooms. Most of the theatres will have only one door. That is not the correct. The width of the door should be about 1.2 to 1.5 meters. The doors should be sliding doors to minimize the generation of air currents during opening and closing during the surgical procedures. Windows from glass and to be planned on one side only. The surface and flooring non-slippery with minimum joints to decrease the accumulation of dust and any other tiny particulate matter within it. The walls should be washable and soothing painting should be present. Ceiling again should be hard, impervious, plaster painted ceiling should be presented. There are different zones in the operation theatre complex. The 4 zones are there. It based on the type of cleanliness present and the presence or absence of microorganisms and different procedures to be carried out in each zone. The protective zone includes changing room for all the concerned persons, transferring passage for the materials and equipment and the patient, and a room for administrative staff, storage and record maintenance, pre and post-operative areas, and ICUs in case of cardiology units, and storage rooms to keep the sterilized objects. Next is the clean zone, where it links to the protective zone to the aseptic zone. There you have clean rooms, storage room for the equipment, designed for surveillance and maintenance, and exit areas for in case of emergencies. The aseptic zone is the area where the actual operations are done, and the disposable zone. This is separate. This should have a separate exit for disposing contaminated linen and used material, and also the instruments. This is the pictorial diagram where you have 3 different corridors: protected corridor, clean corridor, and disposable corridor. And each one has to be allocated appropriately in the given place. This is a 3-dimensional view. I don't think I can. Yeah. This is at one corner. This is the pre-op area, and it should be the most inside from the entry of the pre-op area. Coming to the details of the operating room environment, it is operating room air is it may contain microbial laden dust, lint, skin squams, respiratory droplets from the personnel who are moving around in the OT. The levels of these microbial agents is directly proportional to the number of people moving about in the room. So appropriately circulated, clean, filtered air will remove the airborne organisms. So one should be very careful about ventilation of the operation theatres. The OT should be maintained at a positive, actual surgical area should be maintained at a positive pressure through high efficiency particulate air filters, that is HEPA filters, with respect to the corridors and adjacent areas. These can remove the particles greater than 0.3 microns. Most of the bacteria are removed by these filters as the size of the bacteria is about 0.5 to 1 microns. So these should be monitored for efficiency on regular basis and changes whenever it is required. This positive pressure airflow will prevent air from less clean areas into the more cleaner areas, that is the operating areas. As I told, the air exchanges should be about 20 per hour, and the direction of flow should be from ultra clean or aseptic zones to less clean zones. This can be achieved by the pressure gradient. Highest pressure in the ultra clean areas, and within the room, that is in the operating area, the room air inlets should be at a higher level, and the outlet should be at the lower level, that is at the floor level, so that the air moves downwards through the room and towards the contaminated floor where it is exhausted through the outlet. The temperature in the OT should be maintained between 18 to 24 degrees Celsius with the central air condition. The window air conditions are not advisable. It is a source of contamination, and it has no place in the OTs. And surfaces and floors, as I told, it should be non-porous and smooth. There should not be any cracks or crevices. Epoxy paint is particularly suitable for the walls of the OT. The joint between the walls and floor should be curved for easy cleaning. It should not be like a straight ends. Operation table should be placed away from the entrance. The doors should be fitted with the swing doors, and airflow, as I told. And most of these standard things may not be possible in all the places, but one should try to be adherent to the standard principles that are given, so that the incidence of prevention control can be taken care. The environmental surface like tables, floors, walls, and all those things are rarely implicated as a source of pathogens. The routine cleaning is adequate for after each surgery. Regarding the microbiological sampling, it is not justified because there is no standardized parameter which we can compare to. And the conventional sterilization of the surgical instruments, these things will be dealt in detail tomorrow. Flash sterilization. This is a routine practice in most of the OTs. It is the process designated for the steam sterilization of patient care items for immediate use for emergency during the surgery. Where it is needed for emergency sterilization of equipment, but it is not intended for the reason of convenience or as an alternative to purchasing additional instruments or anything. And it is also not recommended for the implantable devices because of the potential for serious infections. Coming to the preoperative issues, as already discussed, preoperative hair removal, the standard is it should not be removed. If at all it is to be removed, it should be clipped in less than 2 hours before the operation. Shaving is not at all recommended. So it increases the risk of surgical site infections as there may be microabrasions. Regarding the antiseptic showering, antiseptic showering or bath decreases the skin microbial colony, thus the risk of surgical site infections is can be reduced. 80% of the bacteria and surgical site infections originate from the skin of the patient. So one should emphasize on preoperative bath or antiseptic shower, whatever is required as per the kind of surgeries done. Patient skin preparation in the operating room. Most of the areas scrub paint technique is used, but even the spraying is sufficient. I don't think any one of us do it, but this is also recommended. As a general rule, 3 applications are sufficient in areas with high densities of bacteria. The technique is circular motions. It is applied with sterile supplies, wearing gloves and using the barrier technique, and you have to follow the no-touch technique. And the application is moving from the incision area to the periphery. This can be done 2 to 3 times. And they recommend it should be done using pressure, because the friction increases the antibacterial effect of an antiseptic. This is the diagram how we do the preparation, skin preparation. A surgical antimicrobial prophylaxis. The standard is it should be administered before the surgical incision wherever it is indicated, according to the hospital antibiotics policy. This I am not sure how much of hospital antibiotic policy is practiced in the peripheries, but this is routinely done in our hospital. So that should be ideal. And it should be the initial dose of prophylactic antibiotic should be administered in IV route. And it is timed such that the bactericidal concentration of the drug is established in the serum and the tissues when the incision is made. And it should be within 120 minutes of the incision. So we have to plan it accordingly. It should not be prolonged after the completion of the operation. It depends on the kind of surgeries what we are doing. Intraoperative characteristics, the surgical attire, which includes the gloves, gowns, caps, masks, and eye protection, aprons, and footwear. I will not discuss in detail all these things because it is a repetition. The barrier techniques. Most important thing is masks. Use of masks significantly reduces contamination of the surgical site. It should be disposable in nature. It is always preferred. And it should have 3 plates, and it should have a filter of polypropylene or polyester. The scrubs, suits, and cover gowns. The cover gowns should be less permeable than other to other fluids and moisture or bacteria. This is what we are practicing most of the times after COVID probably. That is the preferred way of wearing sterile robes. The aseptic protocol, basically the in relation to the personnel, hand and forearm antisepsis. This is the most crucial important point in the management of OT. So again I will repeat, the nails should be kept short. All the jewelry, artificial nails, nail polish should be removed before surgical hand preparation. Hand should be washed and debris should be removed from the from underneath fingernails using a nail cleaner, not brushes, preferably under running water. Sinks should be designed to reduce the risk of splashes. Surgical hand sepsis should be performed using either a suitable antimicrobial soap or antibacterial hand rub before donning sterile gloves. It should be done at least 5 minutes using appropriate antiseptic scrub, and the hands and forearms should be clean up to the elbows. This must be followed at least for 2 minutes. The standard is 5 minutes. After performing the surgical hand scrub, hands should be kept away and kept up and away from the body, so that the water runs from the tips of the fingers towards the elbows and not vice versa. So there are some other recommendations. If running water is not there, one can use a bucket and with a mug, but these are not practiced. It is not advisable. The another thing is antibacterial hand rub. Sufficient amount of antibacterial hand rub should be applied to dry the hands and forearms for the length of time recommended by the manufacturer. Typically, it is about 1.5 minutes. So at least 2 minutes we have to do the hand rub, and we must allow it to dry before donning the sterile gloves. The steps of surgical scrub, I think I can skip this. Probably it is a repetition of it. Wearing gowns. This is the technique. We have to dry the hands, pick up the gown, let the gown unfold, and open to locate the sleeves or armholes. Slip arms into the sleeves, hold the arms out and slightly up, and the circulating nurse will pulls the gown on and ties it. I think most of you know it. Just as reinforcement, I am depicting this. Gloves. After wearing the sterile gowns, the sterile gloves are worn. The outer package of the gloves is opened by assistant without touching the inner wrapper. Open inner glove wrapper is exposing with cuffed gloves with palm up. Pick up one glove by the cuff of the cuff touching only the inner portion of the cuff of the gown. While holding the cuff in one hand with the fingers pointing downwards, slip the other hand into the glove. Pick up the second glove by sliding the fingers of the gloved hand under the cuff of the second one. Do not contaminate the gloved hand with the ungloved hand as the second glove is being put on. Keep the hands at waist level in front of the body with fingers clasped. Do not touch any other things. Do not keep into your axillas or around the abdomen or on the waist. Just keep the fingers clasped and keep it at the level of the waist. This is the pictorial depiction. It is preferable to don the gloves with the cuffs of the gown. And removing the gloves is also important. The gloves should be removed before touching anything. The rinse gloved hands is rinse gloved hands in a disinfectant solution to remove blood and body fluids. Partly pull off the gloves by grasping it near the cuff. Keeping the first glove partly on, remove the second glove partly to avoid touching the outer surface of either glove. Both the gloves are now turned partially inside out and can together be removed completely while avoiding touching the outside of the glove with bare hands. I think most of you have learned this technique when you are doing the COVID duties probably. Wash hands after removing gloves, since gloves may contain nicks and tears which could allow blood and body fluids to contaminate the hands. The role of drapes to protect the contacting of the unprepared surfaces, areas, maintaining the sterility of the environmental equipment and surrounding patients. The different drapes are available. I will not go through this. The sterile field. It is important to maintain the sterile field to prevent contamination of the surgical incision. It is prepared around the surgical procedure site where the sterile instruments and other items needed during the operation are placed. So it is created by placing sterile towels or drapes on the prepared procedure site. Only sterile objects and persons in the surgical attire are allowed within this surgical field. The areas above the chest and below the waist of the scrubbed team are considered non-sterile. Only the hands and around the waist are considered to be sterile. Items outside and below the draped area are considered non-sterile. The field is considered non-sterile if a non-sterile object or non-scrubbed person comes within the sterile field. Maintenance of the sterile field, again the same thing, place only sterile items within the sterile field. Open, transfer and dispense the items without contaminating them. The outer cover of sterile items is considered unsterile and should not be placed within the sterile field. I think most of the nurses and people who are sitting here, I guess they are working in OT. How many of you are in the OT, working in OT? Okay. So, scrub person should not touch non-sterile objects. Non-sterile items or personnel should not enter the sterile field. Never touch a sterile item with bare hands. If a sterile barrier has been made wet, or it is cut or it is torn, it is considered as non-sterile. It is better to remove and re-drape it. If there is a doubt whether the sterile field has been breached, considered it is non-sterile. Especially when we are operating, if the drapes are wet with blood and saline and whatever it is, we prefer to change it again and re-drape it if the procedure is prolonged for longer times. We do it in double draping, and as soon as something like if excision is there, as soon as the excision part is there, the first draping is removed, the second draping is used for the continuation of the procedure. So that way we can continue to achieve the sterile field. Even the instruments what we use are all blood stains. What we do is we keep the instruments while using, we keep cleaning with the saline, and we will not allow it to get dried with blood and tissue fluids and all those things. So those things should be taken care. Because blood drying up on the instruments itself is a source for the pathogens. The asepsis and surgical technique, all the people who are in the OT and scrubbed personnel should be adherent to the asepsis. And apart from the surgeon and scrubbed personnel, the anesthesia team, they are only separated by a drape barrier. They are also associated with performing variety of invasive procedures like intravascular devices, endotracheal tubes, administration of drugs and solutions and all those things. So each one of them must strictly adherent to the asepsis protocols. The surgical technique itself is most important in avoiding surgical site infections. Maintenance of effective hemostasis while preserving the adequate blood supply to the tissues what we are handling, especially the skin, because while retracting and all those things, we compromise the blood supply to the skin, and we give lot of traction and tension over the incision lines. That should be avoided. That causes a lot of ischemia, and it may cause post-operative fat necrosis and all those things, and it may predispose for the surgical site infections. So the best thing is, if the surgeries are prolonged, it is better to freshen the margins and close the wounds. That is a better way of dealing with the skin incisions in prolonged surgeries. Prevention of hypothermia, as Dr. Amrish discussed in detail about hypothermia. Gentle handling of the tissues, not only the skin and the tissues which we are handling should be in a meticulous way. We should not crush, we should not, that causes necrosis of the tissues and tears and all those things. So avoid inadvertent entries into the hollow viscous, and removing devitalized tissues. This is very important, especially in trauma. The tissues which look devitalized, it is not bleeding well. So all those tissues, and when we use cautery, even sometimes when we use cautery, the tissues are charred. All these tissues should be removed. All these things should be taken care before we close the wounds. Otherwise, these become the necrotic areas, and they predispose for the surgical site infections, even the organ space infections. Use of drains and suture materials appropriately, eradicating the dead space. It is better always try to obliterate the dead space, because that causes the collection of body fluids, and it becomes a rich source of source for the pathogens, and appropriately managing the post-operative incision, as I told you. Any foreign body, including the suture material, a prosthetic or a drain, may promote inflammation at the surgical site and may increase the probability of surgical site infection after otherwise benign levels of tissue contamination. So that is what I have been explaining. In general, monofilament sutures are better for wound closures. They cause lowest infection with better wound healing. Drains should be placed through an away from the incision site. If it is placed through an operative incision, it may increase the incidence of surgical site infections. It is always better to use closed suction drains rather than the open drains. These closed suction drains can effectively evacuate the postoperative hematomas and seromas, but you should also be careful about timing of the drain removal. It should not be prolonged for longer times. That itself can cause ascending infections. Hypothermia is already discussed by the previous speakers, and supplemental oxygen administration is also discussed. Disinfection and sterilization. It is in the OT, it is primarily relates to the processing of reusable instruments. The surgical instruments are being reused to have a greater chances of spreading the microorganisms if any of the reprocessing steps fails. So the steps of reprocessing includes cleaning, repackaging, disinfection or sterilization, and reusing. The sterilization type of sterilization procedures to be carried out depends on the particular classification of instruments. So that is Spalding classification. It's based on the type of material the object is made of, the microorganisms that may present in the object, and availability of the sterilization methods. I'll skip this. This is the classification. The instruments are classified based on these things into critical, semi-critical, and non-critical. Critical are the instruments that have direct contact with the sterile tissues or vascular system. These should be sterilized and made free from all the microorganisms. For example, the extraction forceps, scalpel blades, bone chisels, scalers, surgical burrs, needles, and all those things. Semi-critical ones are, they does not usually penetrate the sterile tissue, but does come in contact with the intact mucous membranes. These items are made free from the microorganisms by high-level disinfection. High-level disinfection is, I think, probably the one which kills the mycobacterium organisms. The examples is endoscopes, condensers, airs, water syringes, impression trays, dental mirrors, and all those things. They just come in contact with the mucous membrane. Whereas non-critical instruments are, they does not touch the patient directly or come in contact with the intact skin. They come in contact with the intact skin only. They are cleaned or disinfected by low-level disinfection, like light arms, handles, chairs, dental X-ray equipment, and all those things, chair switches, etc. This is about sterilization. I'll skip all this. This you have a separate session tomorrow in detail. The important points are sterilized materials are transported from the sterile area to the operation theatre on a covered cart. That prevents any accumulation of dust particles on their surfaces. Before entering the operation theatre, all these supplies and materials should be removed from their shipping or transported containers. After the surgeries, all the blood-coated or soiled instruments and equipment must be transported in a covered wrap or container from the operating room to the decontamination or reprocessing area. Care must be taken that soiled instruments or equipment must not be stored with the sterilized goods. Coming to the post-operative issues like incision care, the care is determined by what type of incision is used, whether it is closed primarily, whether it is left open to be closed later, or it is left open and allowed to heal by secondary intention. For the primarily closed wounds, they are covered with sterile dressings, which need not be removed for 24 to 48 hours unless you want to specifically visualize the wound. There is no standard recommendation about repeated dressings and showering or bathing. I'm a plastic surgeon. We generally recommend patients to wash their face if it is a facial surgery, face on the next day itself. It doesn't matter if it is washed with soap and water. And we advise them to use Neosporin ointment. That is the best way, and it is kept open. And other wounds which should be covered with dressings, we should maintain the moisture which allows the wounds to heal faster. But most of the people, what we notice outside is patients or surgeons who advises, I don't know, but most of the patients, they keep the wounds open. They think that it gets dried up and heals. That is not the case. And another practice is most of the wounds are, the patients are asked to use powders. It is not advisable. The powders usually make a scab kind of thing, and underneath that, all the secretions gets collected and it gets infected. It is not advisable. So maintenance of the operation theatre. Machinery must be surveyed at least every week. Proper ventilation should be checked regularly, and the filters should be changed as required. At the time of maintenance or inspection or observation of any fault in the working of the operation theatre, the members of the infection team control should be informed. The theatre should be thoroughly examined by the members of the team, and appropriate measures must be taken to maintain the infection control protocols. Operation theatre must only be functional after being carefully evaluated and cleared by the infection control team. Backup facility for operation theatre in all aspects should be present in any setup to provide any uninterrupted sessions at the time of maintenance or any fault observed. Coming to the cleaning of operation theatre, these are done daily basis, weekly basis, as a surveillance program. Before start of any first case, at least 1 hour before, damp dust with detergent, disinfect all the equipments, furnitures, lights, and wipe the surgical light reflectors again with the 70% alcohol to remove the film led by the detergent. In between the cases, place soil towels, drapes, gowns in a clean laundry bag and send it to the laundry. Wet linen should be placed in a plastic container so that the bacteria do not pass through the moist material. Soiled instruments must be placed in disinfectant and then sent to the cleaning area. This prevents the occupational hazards to the cleaners. Wipe all the used equipments and furnitures and lights, and empty the suction bottles. Wash the suction bottles and tubing with detergent or disinfectant. Best is to dispose the suction bottles. The terminal daily cleaning after scheduled cases is remove all the portable equipment from the room, wipe window sills, overhead lights, equipment, furniture, water containers with cloth soaked in detergent disinfection solution, wet vacuum or wet mop the entire floor area, clean and disinfect the wheels, casters. What we practice is after the OT, all the OTs are washed with daily. Restock unsterile supplies, check the levels and dates of all sterile supplies and restock, clean the air conditioning grills, clean the scrub sinks and covering powder, empty all the shelves, wipe with detergent, disinfectant and dry them before replacing all the supplies. This can happen only if the OT team works in shifts. The morning hours, all the surgeries are done. The evening team will take care of all these things, cleaning the OT after all the surgeries. This should be maintained, otherwise it becomes a problem. Weekly general cleaning, again clean the lights and fixtures, doors, wipe the walls, scrub the floors, and all those things. All the furniture, operating room table, suction holders, IV stands, foot and sitting stools, X-ray view boxes, all the tables, tubings to the oxygen tanks, waste containers and buckets. And now there is no role for fumigation with formalin. I think we are using, Dr. Padmaja can tell what is the standard recommended for the OT maintenance daily. We are not using fumigation anymore now with the formalin. The hypochlorite based solution is being used nowadays. Thank you. Any questions?
Collection of samples, theaters has no role. Antimicrobial sampling.
Yeah.
But majority of the hospitals are recommending, every day, can you take swab? If you get swab positive, 15 days close theater.
No. This microbiological sampling is done only whenever there is a renovation work going on or there is any septic case. Only in such incidences it is recommended.
Yes.
This discussion happened recently. Dr. Padmaja is probably here. There is no standard recommendation for routine regular microbiological sampling in the OT.
The same thing I told to my superintendent.
Yeah.
If anything goes wrong, you will be held responsible. That's
No, it is not recommended because there is no standard for which we can compare it.
That's what I meant to say is set the protocol, because most of the hospitals are taking swabs, if I am right. I am the only person who is not taking samples.
We don't use the...
Since 2016, I am not taking in even Sarojini Devi Hospital also.
Yeah.
I abandoned according to the CDC guidelines.
Yeah,
since 2016.
Yes, correct.
But my even hospital, ophthalmal superintendent was forcing me, if anything goes wrong, as per your instructions only, because I told I am the in charge of operation theatre, no need of worry like that. So please give standard instructions to all the teaching hospitals. No need of taking any samples unless until it is renovated,
yes,
as you
correct.
said.
Yeah. That is the standard recommendation by WHO or in CDC also. Dr. Padmaja, would you like to add about the microbiological sampling? Yeah, okay.
There is one more lecture. That lecture will show you the surveillance of OTs. Though there is no consensus, but still we need to maintain the environmental sampling, at least to know what is happening. We need to monitor.
Sampling means how you will take environmental sampling?
I'll show you in my presentation. Will you please?
Because he said in one sentence.
Yeah.
So she has shown, because you cannot collect environmental sampling. Outside the OT there is a trolley will be there. How can you collect the sample? The same trolley will come to the operation theatre to ship the patient, and outside there will be so many, our dresses, our chairs. How can you collect?
No, always whenever you have to collect sample in OTs, generally you need to fumigate the OT first. First of all, you have to collect the samples only when there is new construction, new commissioning of OT happens, renovation. These are the two important points.
Okay.
But when you start fumigation process, it should be done under a closed environment. You cannot bring in the trolley or anything. In that such conditions, you are not going to collect the sample. First of all, you have to close it at least for 1 hour. Once after you do the fumigation, then you put up the plates, or air sampler or a settle plate method is used to collect the samples.
See, if the same thing happens, you have done fumigation and everything is over. Okay? Patient is operated and then trolley comes from outside into the theatre. How can you?
No, in which case you are asking? It's closed and the patient has come into the
Yeah,
with the
naturally,
trolley.
patient will come in the trolley, the polytrauma patient.
That's why we are not recommending that this routine sampling is required. It's only a consensus, but still monitoring is important to collect the environmental monitoring is important. So otherwise you will never understand how the OTs are functioning. So for that purpose, at least we need to cross check, is there any in the air or there bacteria or not. So you need to fumigate, close the OT at least for 1 hour, place the air sampler, and then you have to assess the colony count. Based on that, you can have intervention strategies with the surgeons, what are required.
So if you give sampling, no, what you give? Tetanus sports positive.
No, we
actually what microbiology, no.
see, culture plates will be placed to the open air. Culture plates will be exposed in the 4 corners of the room. Okay, and then we place one plate in the center of the room with the plate exposed, and then after you can assess 2 to 3 hours, you can take back the plates and incubate them in an incubator, and then look into the colony count based on a formula.
Yes,
so
exactly.
there will be a limit for the colony.
Yes. You are telling in your institute which are following.
Yeah.
In our so many hospitals, they will collect swabs from corners.
Yeah.
They will
See, surface swabbing is really a not recommended thing, because at one point you will have the dust accumulated, at other point the site might be very clean.
Exactly.
So it will not serve the purpose.
Yes. As you said, the plates are.
Yes. So the air sampler is
nowhere
the
in
best
Telangana
recommended
other
method.
than NIMS, they are following this.
Okay.
So they are collecting always surface.
Yeah, these kind of educational programs will help mostly to have awareness.
That's what
where
I was.
and when you have to do.
I was insisted by superintendent, and please collect the surface swabs.
At that
I
time, at
denied
least
for that. I
we
denied
should
for
be
that.
convincingly. We should explain them what is the status, and then you should go for sampling. If it is,
in Suryapet, they are providing plates. Yeah.
yes, very good. So you can use that. Yeah, today my topic is on surveillance of operation. Thank you, madam. Today my topic is on surveillance of operation theatres. Harboring of potential pathogens in OTs of hospital pose a great risk to patients. Strict asepsis is necessary in OTs as the patients undergo invasive procedures. So for that we need definitely surveillance of OTs, which will helpful in controlling the nosocomial infections. Why standards of environment a priority in OTs? According to National Nosocomial Infection Surveillance, environments in the OTs are dynamic and subjected to continuous changes. So good infrastructures do not mean a safe environment, as humans make a greater difference in making the environment unsafe. Sometimes the environment become unsafe, so you need to have a monitoring, even though it is said that why environmental sampling is preferred or not. What is the role of healthcare workers in safe OTs? All healthcare professionals need to set a standard by which to practice, with a focus on clinical effectiveness and evidence-based care. Theatre staff must be able to demonstrate the ability to audit care and theatre practices. What is the significance of surveillance in OTs? Microbiological surveillance provides data about the factors contributing to infection. High level of microbial contamination indicates the needs for periodic surveillance aimed at early detection of bacterial contamination levels and prevention of hospital-acquired infections. So what is the definition of surveillance? It's an ongoing, systematic collection, analysis and interpretation of health data essential to the planning, implementation and evaluation of public health practices, closely integrated with the timely dissemination of these data to those who need to know. So constant surveillance is essential to know, at least to interpret the data in our hospitals. So do we need surveillance regularly as a part of commissioning of an OT, as earlier I mentioned, where there has been substantial modifications to the ventilation systems or fabric of the area? After any major structural refurbishment like changes to the duct works, AC ducts will be there in the OTs. So that may affect the airflow to or within a theatre. So even at that point of time, you need to do surveillance regularly. So the areas covered include conventionally ventilated OTs, ultra clean ventilated OTs. So conventionally ventilated OTs has a supply of air to dilute airborne contamination by minimizing the transfer of airborne contaminant from less clean to cleaner area. Okay. An ultra-clean ventilation system is a means of significantly increasing the dilution effect by providing a large volume of clean filtered air to the zone in which an operation is performed and sterile items are exposed. So air is discharged above the operating zone. The air flow in and around the clean zone also serves to prevent particles originating outside the zone from entering. What are the recommended conventional and ultra clean operating theatre values? So this is according to Asian Healthcare Worker Handout by Pacific Society of Infection Control, where in a conventional theatre, in an empty operation theatre, the bioload should be less than 35 colony forming units, whereas during operation the bioload can be less than 180, the acceptable limit. Whereas in ultra clean theatres, the bioload should be in an empty theatre, it should be less than 1 colony, whereas during operations it should be less than 10. These are all given according to the literature guidelines which we have verified. So air is an important source of infection. Bacterial air count is a suitable index in predicting post-operative infections but not cost effective. So bacterial counts in OTs are most of the time they are influenced by number of individuals present, ventilation and airflow. But quality of indoor air depends on external and also internal sources like ventilation, cleaning procedures and surgical team procedures. So what are the routes of transmission of these airborne contaminants? Airborne contaminants may enter the room via the following routes: through the supply of air shed by operating staffs, skin fragments with bacteria, through surgical activities, and sometimes they are transferred from adjacent spaces also. So these are all of various routes of transmission. Active surveillance of healthcare associated infections. High risk areas under various settings includes ICUs, especially neonatal ICU, pediatric ICUs, cardiothoracic vascular surgery, respiratory infection units, OTs, dialysis units, burns units, transfusion services units. All these units should be done active surveillance. So where high risk areas are preferred. Environmental monitoring, air, surfaces and equipment should be monitored to detect changing trends of microbial counts and microflora. Especially for this sake, at least we need to monitor. Environmental surveillance will be restricted to areas of need such as theatres and also ICUs. In case of outbreaks or on completion of construction work or repair work, environmental surveillance will be carried out only if the infection team will identify a need for such a surveillance. Until then, you need not go for it. So what are the methods of surveillance? Settle plate, air sampler, surface swabbing, aerobic and anaerobic. So settle plate technique, blood agar plates are exposed at different areas of washing room, OT tables, OT corners, doctor's room, at least for 30 minutes to 3 hours. Incubated at 37 degrees centigrade for 48 hours. Microbial air contamination is determined based on the growth observed, area of the plate exposed and duration of exposure, and the acceptable limit in this case will be 35 colony forming units per cubic meter. So air sampler, this is what I want to say. Air sampler is a very important kind of instrument where you can use these blood agar plates are placed in Reuters centrifugal samplers, and the microbial air sampler is operated at an airflow rate of 100 liters per minute. There will be a sieve-like structure inside once you open the lid. So that's why on the plate you can see that small pores of sieves will be there. So through that sieves the air will be sucked at 100 liters per minute, and sampling time will be 5 minutes at different areas of OT with 4 feet height above the OT table. Incubated at 37 degrees centigrade for 24 hours once the plates are collected. And microbial air contamination is measured by counting the number of colony forming units per cubic meter, and acceptable limit is 180 colony forming units per cubic meter. So air contamination standards, how they can be monitored. So once you put up these settle plate method, the technique is used, the number of microorganisms can be counted by using the formula A into 1000, P into T into 0.2. So A denotes the number of colonies on the Petri plate, P denotes the surface measurement of the plate used in centimeter square, and T denotes the time of exposure of Petri plate in minutes. So using this formula, you can assess how much your colony count is and then compare it with the standard limit of the colonies that have to be there. So this is slit sampler method, which is already I have explained you about the air sampler. It's a very effective, highly sensitive, fixed volume of air is sucked and bacterial counts are made. And bacterial colony count of more than 10 per plate and fungal colony of more than 1 per plate are considered unacceptable. So measuring bacterial air load using this air sampler, theatre should be sampled, should be left vacant for a minimum of preferably 1 hour. I think I mentioned this point earlier. Ensure that the sampler is charged. So you need to have full charge whenever you want to use this air sampler. And the sieve to be sterilized daily or alternate days. And the sieve to be cleaned with alcohol. You cannot directly take it and use it next day in another OT. So it should be cleansed thoroughly before you use in another place. And the equipment is to be placed at a height of 4 feet. And the equipment is to be carried in a designated box. Sterility of the sieve to be maintained till the point of usage. And the flow rate, as already I have mentioned, should be maintained at 100 liters. Once sampling is completed, remove the agar plates aseptically and label it clearly and send it to the incubators. So heating, ventilation and air conditioning systems. These systems should be thoroughly monitored, maintains indoor air temperature and humidity, control odors, remove contaminated air, minimize the risk of transmission of airborne organisms. All these things should be monitored in OTs thoroughly, which we will not go further into these things. So monitoring this heating, ventilation, air conditioning system also will help you to control these environmental pathogens. Transmission of fungal spores is also possible. See how bioaerosols of fungal spores present in hospital environment transmitted through air, surfaces of articles, visitors, healthcare workers, cross infections from other patients, as well as ejected through the vents of ACs. So never we concentrate these areas. So we need to think over these also. Filters of contaminated AC units, they provide a niche for proliferation of fungal and production of fungal spores. These fungal spores can get inoculated as surgical wounds, resulting in post-operative infections. And sometimes they may be inhaled, leading to healthcare associated infections also. So duct cleaning is very essential. Routine sterilization practices in OTs often fail to address the organisms that persist in the filters of the AC units, especially the fungal spores. Air conditioners in the various OTs and ICUs of the hospital should be checked in order to estimate the level of fungal contamination with the help of biomedical engineers. So we need to have them. And surface sampling, which already we have discussed, not recommended, but still swabs collected from different points, you need to explain them why it is not important, and then you should go for it. Otherwise, surface sampling is not recommended. Okay. Then a typical surveillance report should have the following headings: site of collection, date of collection, name of the person collecting the samples, colony count of the aerial flora, and predominant organisms isolated along with their colony counts, and water potability and coliform count, autoclave efficiency by biological indicators. All these points should be inserted whenever you give the typical surveillance report to the surgeon. And operation theatres, it comes to what earlier Parvati madam said. No routine fogging is recommended, but any civil or engineering works should invite fogging of OTs. If culture swabs and air sampling plates are sent from OTs for investigating surface contamination and air quality. Fogging of OTs may be done on basis of these reports particularly. Like fumigation now, it is not recommended. Please remember that fumigation is a word no more that exists, because for earlier formaldehyde is a carcinogenic agent that is now not recommended to use in OTs. Please remember this and stop using fumigating with formaldehyde. And now the new word exists, that is fogging. Fogging in OTs is recommended. Here I have given the measurements how you have to calculate your room volume, and then according to length into breadth into height, prepare the required amount of disinfectant for fogging at 2% dilution, and then you have to use your respective disinfectants what are available in your work area. We have Facin combo, which we are using an agent with hydrogen peroxide. And these are the type of disinfectants that are used at NIMS. So I have given very clearly their hand disinfectant, what is the composition. It consists of 2-propanol and mesotronium sulfate. And the skin disinfectant, which I have mentioned earlier for CLABSIs, wherever you prepare the skin to draw the blood cultures or before inserting the central lines, this is a recommended 2% Bactoprep with a combination of chlorhexidine and also ethyl alcohol. And next comes the environmental disinfectant. This is salicylocid, or it is available as bacillocid. We have displayed outside the few disinfectants. You can have a look at them, what we are using in our OTs, and the recommended dilution also I have displayed there. If anybody are interested, you can use these kind of fogging dilutions in your own OTs. And this is also one more environmental disinfectant, SaniShield. This has a stabilized hydrogen peroxide with silver nitrate is the composition. So the recommended dilutions also have been given there. And these are the general instructions. So don't use sodium hypochlorite on any metallic surface, or for skin only, for floor, on the floor only you have to use, okay? And on the stone surfaces, PET pans only single use, and also cleaning with soap solution and sodium hypochlorite. Use hand rubs at every bedside, and a standard microsterile or sterilium should be used. As we have shown in the morning class, ensure that when you are monitoring your ICUs, ensure that the sterilium or any hand rub is available at the site near the patient bedside. And you have to maintain a log book also for documenting the cleaning at least thrice a day. So documentation is very important. Even now, today also you can start documenting in your own work sites. Without documentation, we cannot accredit that our hospital is an accredited hospital. So documentation will help us, everybody, to know what we are doing and what protocols we are following. So maintenance of the air conditions in the OT is very much important. Regularly, they have to be maintained through your biomedical engineers. And OTs are hot zones for emergence and spread of antimicrobial resistance because of invasive procedures, high antibiotic usage, transmission of bacteria between patients due to inadequate infection control measures, and lack of adherence to established standards and also guidelines. So conclusion, although there are no uniform consensus on either the standards for surveillance, methodology for monitoring, or the levels of acceptable contamination, still we need to have some criteria to monitor the air quality in at least the critical areas like OTs. Okay? And engineering parameters are to be regularly monitored. So operation theatre safety is the responsibility of cheerful, dedicated staff, makes a great success. So these are the references that I have verified. Thank you. Yes, in NIMS we are using air sampler. In Department of Microbiology we have, it is company of Biomary. That's what, we go for a rounds where we need to monitor. Nowadays we made a practice to use air sampler now and then to check for the AC vent systems, how they are. So based on that, depending on that duration of time, we are preferring to use air sampler. Otherwise, if any unit of ICU calls us, depending on outbreak or a new refurbishment of the OTs or commissioning of OTs, we take it immediately and perform. No, ICU's regular monitoring means you have to go for a rounds and ask for thorough environmental cleaning. You need not use there in ICUs because ICUs can never be shifted. All the patients cannot be shifted. So at least you try to monitor by instructing them the classes that please thoroughly perform your environmental cleaning And then if really it is uncontrollable, you need to shift the patients to another ICU, and then you can do the fogging. That is recommended. Surface walls cleaning is not regularly recommended. Once in a month. I think madam has shown that point also. So regularly don't disturb the walls and ceilings every day, wiping them off. Monthly once you should touch the walls and ceilings. It's you can go with the sodium hypochlorite for cleaning. It depends on how which your hospital what it procures for using the disinfectant. See, now I have shown the bacillocid concentration. So for bacillocid fogging, one concentration will be there. You can go with 0.5% at a minimal if the walls are not really soiled. So you have to decide at that point of time what is the concentration. No, we have to use distilled water. Okay, so don't go with normal saline because always distilled water is suggested even when you mix with any recommended dilutions, distilled water is the recommended thing. Don't go with normal saline because guideline doesn't say that. Maybe without knowing that point, are you using the normal saline? No, it's not, it should not use. No. See, even tap water carries certain bacteria. Please try to know that. Yeah. So that is also not recommended. Yeah. So you need to have awareness constantly. You should choose a person to come and give them lectures, increase their awareness. This should happen further. Otherwise, these things will keep on continuing. Sure. Yes. So you. Yes. Okay. Fine. Sir is there. Sir, last session, sir. This is. Thank you. Mike.
Please go ahead, Amma. You want to ask some question?
Yeah, I can. If you want, I can give you the papers also of this fogging which we have prepared. We are using face in combo. It depends on your institute what you are using. Area. You have to measure the volume of your room, length into breadth into height, and then you need to use these calculations. So bacillocid, which is a combination of 1,6-dihydroxyglutaraldehyde. So you need to use this. Yeah, but we are using right now this in our institute. Okay. Fine. Yeah. Yes. So now no more, please don't use the word fumigation and start doing usage of formalin. Please stop formalin usage. If you want to note this, make a note of this point and you can recommend the same reagents at your work site. Yes. No. Yeah, but still you should be able to convince them. Yes. Yeah. That's why sir told no, even pharmacists also should be taught these kind of things. Otherwise, they have to know the guidelines, sir.
So one comment is on actually we are discussing about the prevention of hospital acquired infections. So దానిలో మనం ఓన్లీ ఎయిర్ క్వాలిటీ కాకుండా 2-3 థింగ్స్ ఉంటాయి. We should know air quality is important. As a nephrologist we do transplants also. ఒకసారి ఏమైందంటే చాలా మందికి ఫంగల్ ఇన్ఫెక్షన్స్ వచ్చాయి మా పేషెంట్స్కి. ఆ టైంలో మా ఎయిర్ శాంపుల్ నా ఓపీలో పెట్టాను యాక్చువల్లీ. ఓపీలో సమ్ ఫంగస్ గ్రో అయింది. దాని తర్వాత వి క్లీన్ అండ్ వి ఆస్ ద పేషెంట్ టు వేర్ అ మాస్క్. దాని తర్వాత కొంచెం ఇమ్యూనో సప్రెషన్ తగ్గించాము. ఎయిర్ క్వాలిటీ పెంచడానికి అది బెటర్ చేయడానికి కన్స్ట్రక్షన్ అవుతుండే పక్కన, అక్కడ నుంచి షిఫ్ట్ చేసి దగ్గర పెట్టుకున్నాం. అంటే హౌ ది ఎయిర్ శాంప్లర్ విల్ హెల్ప్ అన్నదానికి ఎగ్జాంపుల్ చెప్తున్నాను. సో నేను ట్రాన్స్ప్లాంట్ ఓపీ ఒక దగ్గర నడిపించేవాడిని. ఆ టైంలో కొంతమందికి ఇన్ఫెక్షన్స్ రావడము, దానిలో ఫంగస్ ఉండడము, ఎందుకు వస్తుందని ఆలోచించి అక్కడ పక్కన కొంచెం దూరంలో ఒక డిపార్ట్మెంట్ రెనోవేషన్ జరుగుతుంది, ఎందుకు వచ్చిందని చెప్పి డిపార్ట్మెంట్ ఆఫ్ మైక్రోబయాలజీ ఎయిర్ శాంప్లర్ ఓపీలో పెట్టి కలెక్ట్ చేస్తే దానిలో ఫంగస్ గ్రో అయింది. దాని తర్వాత ఆ ఏరియాని అబాండన్ చేసి వేరే దగ్గర ఓపీ స్టార్ట్ చేసి దాంతో పాటుగా పేషెంట్ని మాస్క్ పెట్టుకోమని చెప్పాను. ఎందుకంటే అక్కడే కాదు, పేషెంట్ ఈస్ ట్రావెలింగ్ ఫ్రమ్ హిస్ హౌస్ టు ఓపీ, మధ్యలో ఎక్కడైనా రావచ్చు. బికాజ్ మనం హైదరాబాద్లో మీద పెడితే డెఫినెట్గా ఫంగస్ ఉంటుంది. ఇప్పుడు నా ముక్కులోంచి తీస్తే కూడా ఫంగస్ వెళ్తుంది. అది ఫంగస్ విల్ బి దేర్ ఎవ్రీవేర్. ఇఫ్ ఇట్ ఆల్ యువర్ ఇమ్యూనో సప్రెస్ ఇండివిజువల్, డెఫినెట్గా అది ఇన్ఫెక్షన్ కాజ్ చేస్తుంది. సో అంటే ఒక ఇన్ఫెక్షన్ రావడానికి మల్టీ డైమెన్షనల్ థింకింగ్ ఉండాలి. ఒక ఎయిర్ శాంపిల్లో సమ్ ఫంగస్ వచ్చింది ఓటీ క్లోజ్ చేయాల్సిన అవసరం లేదు. దాని క్లినికల్ కొరిలేషన్ ఉందా లేదా అది మనం ఆలోచించాల్సిన అవసరం ఉంటుంది. దాంతోపాటు నేను అంటే నా ఎగ్జాంపుల్ చెప్పేదంటే నేను దెన్ ఆఫ్టర్ దట్ ఐ చేంజ్ దట్. దాంతోపాటుగా ఇమ్యూనో సప్రెషన్ తగ్గించాను, పేషెంట్ని మాస్క్ పెట్టుకోమని చెప్పాను. అంటే 2-3 రకాల చర్యలు తీసుకోవడం వల్ల నా ట్రాన్స్ప్లాంట్ పేషెంట్లో ఇన్ఫెక్షన్స్ తగ్గాయి. అదొకటి. రెండవది, మా థియేటర్లో మేము వీల్ ఆల్సో డూ లాట్ ఆఫ్ ప్రొసీజర్స్ లైక్ జుగులార్ వేయడము అట్లాంటి వాటిలో కూడా. సో ఎంఆర్ఎస్ఏ అన్నది ఒకటి సరిగా క్లీన్ చేయకపోవడం వల్ల ఆ ఎయిర్లో ఉండాల్సిన అవసరం లేదు. అందరిలో చర్మంలో ఎంఆర్ఎస్ఏ ఉంటుంది, మన ముక్కులో ఉంటుంది. సో జుగులార్స్ వేసేటప్పుడు చాలామందికి ఎంఆర్ఎస్ఏ వచ్చినప్పుడు ఏం చేశారంటే మా హెల్త్ కేర్ వర్కర్స్ ఇంక్లూడింగ్ మీ వీ గివెన్ శాంపుల్స్ ఆఫ్ అవర్ మైక్రోబియల్ స్టేటస్ ఆఫ్ అవర్ నోస్. ఎవరికైతే ఎంఆర్ఎస్ఏ ఉందో కొంచెం మిప్రోసిన్ పెట్టుకొని ఆ ఎంఆర్ఎస్ఏని తగ్గించుకున్నాం. అంటే హెల్త్ కేర్ వర్కర్ అసోసియేటెడ్ ఇన్ఫెక్షన్స్ కూడా ఉండొచ్చు. సో ఎంఆర్ఎస్ఏ ఎందుకు వచ్చిందని అంటే ఈ రకంగా ప్రతి దగ్గర కూడా ఇండివిజువలైజ్డ్ అప్రోచ్ ఉండాలి. యూనిఫామ్గా ఉండాల్సిన అవసరం లేదు, బట్ యూనిఫామ్ సమ్ స్టాండర్డ్స్ ఉండి తర్వాత ఇండివిజువల్గా అప్రోచ్ ఉంటే డెఫినెట్గా హాస్పిటల్ అక్వైర్డ్ ఇన్ఫెక్షన్ తగ్గించవచ్చు. ఎంఆర్ఎస్ఏ అనేది మన దగ్గర నుంచి కూడా పేషెంట్కి వచ్చే ఛాన్స్ ఉంటుంది. ఆ పేషెంట్ స్కిన్ మీద కూడా ఎంఆర్ఎస్ఏ ఉంటుంది, సరిగా క్లీన్ చేయకపోవడంలో రావచ్చు. తర్వాత మనం ఓటీకి వాడేటువంటి ఎక్విప్మెంట్స్, ఇప్పుడు నా దగ్గర ఇప్పుడు డయాలసిస్లో వీ డూ లైక్ అరౌండ్ 8 to 10 పర్మాక్యాస్ చేస్తాము, 20 దానికి జుగులర్స్ చేస్తాము. నేను మా థియేటర్ నర్సెస్ ఏం చెప్పానంటే 20 ప్రొసీజర్స్ పర్ డే ఉంటే ఒక 60 సెట్స్ పెట్టుకోమని చెప్పాను. అంటే 3 సెట్స్, ఒకటి అక్కడ ఉంటుంది, ఒకటి సిఎస్జికి వెళ్తుంది, ఒకటి స్టోర్లో ఉంటుంది. సిఎస్జి దగ్గర లేట్ అయినా కానీ ఇంకొక సెట్ వాడుకోవచ్చు. మార్నింగ్ కూడా మంత్రి గారు చెప్పారు అడిక్వేట్ ఇన్స్ట్రుమెంట్స్లో పెట్టుకోవాలని చెప్పారు. ఎందుకంటే అడిక్వేట్ ఇన్స్ట్రుమెంట్స్ లేకుంటే హై వాల్యూమ్ ప్రొసీజర్స్ ఉన్న దగ్గర ఎస్పెషల్లీ సీజన్ సెక్షన్స్ అవుతాయి, డెలివరీస్ అవుతాయి, నెంబర్ ఆఫ్ ప్రొసీజర్స్ ఎక్కువ ఉన్నప్పుడు మనకు సెట్స్ తక్కువ ఉంటే కూడా సమ్ టైమ్స్ సిఎస్జికి వెళ్ళి రావడం లేట్ అయితే ఎమర్జెన్సీ ఉంటే మనం డాక్టర్ వీ హ్యావ్ టు సేవ్ ది లైఫ్. ఇన్ఫెక్షన్ గురించి లేట్గా ఆలోచిస్తాం మనం, ముందు పేషెంట్ లైఫ్ కాపాడడం ఇంపార్టెంట్, అదే సెట్తో ఇన్ఫెక్షన్ వాడేస్తాం. సో కాబట్టి అడిక్వేట్గా ఇన్స్ట్రుమెంట్స్ పెట్టుకోవడం ఒక నేను నేర్చుకున్నది చెప్తున్నాను. వాట్ ఈజ్ మై ఎక్స్పీరియన్స్ యాజ్ నెఫ్రాలజిస్ట్ ఐఎమ్ ట్రైంగ్ టు టెల్ యూ. సో ఓటీలో కానీ మేము కూడా ఓటీ వాడతాం కాబట్టి ఓటీలో అడిక్వేట్ ఎక్విప్మెంట్స్ పెట్టుకోండి మీరు. నెంబర్ 1 పాయింట్, అడిక్వేట్ సెట్స్ ఆఫ్ ఎక్విప్మెంట్స్. ఒక ప్రొసీజర్కి ఒక ఎక్విప్మెంట్ వాడితే అలాంటి ఆ రోజుకి ఎన్ని అవుతుందో ఎస్టిమేట్ చేసుకొని 20 ప్రొసీజర్ 20 సెట్స్ ఉండాలి ఆ రోజుకి. ఇంకొక ఆ సెట్స్ అన్నీ క్లీన్ చేసిన తర్వాత మార్నింగ్ వీ హ్యావ్ టు సెండ్ ఇట్ టు ది సిఎస్ఎస్డి. అక్కడ వెళ్ళిన తర్వాత అక్కడ లేట్ అయినా కానీ మన దగ్గర ఒక అడిషనల్ ఎక్విప్మెంట్ అంటే 3 times సెట్స్ మీరు పెట్టుకోండి. దానికి ఎంత ఎక్విప్మెంట్ కాస్ట్ అయితే డెఫినెట్లీ వీ కెన్ ఫండ్ దట్. సో ఆ రకంగా మీ దగ్గర ఎన్ని ప్రొసీజర్స్ చూసుకొని దాని సంబంధంగా మన ఎక్విప్మెంట్ సెట్స్ పెట్టుకోవాలి. తర్వాత ఈ ఎన్విరాన్మెంటల్ శాంప్లింగ్ మేడం చెప్పినట్టు అది కూడా ఇంపార్టెంటే. బికాస్ సమ్ టైమ్స్ మా దగ్గర ఫంగల్ ఇన్ఫెక్షన్ నాకు తెలియలేదు, బట్ ఎయిర్ శాంపిల్లో తెలిసింది మనకి. అలాంటివి కూడా చూసుకుంటే ఏసీ డక్ట్స్ చాలా ఇంపార్టెంట్. చాలా రోజుల తర్వాత ఏసీ క్లీన్ చేస్తారు. ఒక్కోసారి మనం స్కిన్ ఓపెన్ చేసిన తర్వాత అక్కడ ఎయిర్లో వచ్చినటువంటి బ్యాక్టీరియా ఆల్సో కెన్ ఇన్ఫెక్ట్ ది వూండ్. సో దాన్ని కూడా మనం దృష్టిలో పెట్టుకోవాలి. డెఫినెట్గా స్వాబ్ అన్నది మనం వాల్ మీద తీయాల్సిన అవసరం లేదు, బట్ ఎయిర్ శాంప్లింగ్ అప్పుడప్పుడు మనం చేసి అన్యూజువల్ ఇన్ఫెక్షన్స్ వస్తే మనం కనుక్కుంటే డెఫినెట్గా మనం డక్ట్స్ క్లీన్ చేయొచ్చు. దాన్ని మేడం అన్నట్టు దాన్ని ఫ్యూమిగేట్ చేయొచ్చు ఎన్విరాన్మెంటల్ బ్యాక్టీరియా తీసేయడానికి. బేసిక్గా ఎయిర్ కండిషనింగ్ డక్ట్స్లో క్లీన్ చేయాల్సిన అవసరం ఉంటుంది. ఇవి కూడా చూసుకుంటే డెఫినెట్గా మనం ఎయిర్ క్వాలిటీ పెంచితే ఇన్ఫెక్షన్ రేట్ తగ్గుతుంది. మనం శుభ్రంగా ఉంచుకోవాలి, పేషెంట్ శుభ్రంగా ఉంచుకోవాలి, ఎక్విప్మెంట్ శుభ్రంగా ఉంచుకోవాలి. ఇవన్నీ ఉంటే డెఫినెట్గా ఇన్ఫెక్షన్ తగ్గొచ్చు. ఇన్ఫెక్షన్ తగ్గడం అనేది ఒక మైక్రోబయాలజిస్ట్ జాబే కాదు. పేషెంట్ని శుభ్రంగా ఉంచుకోమని చెప్పాలి, మనం శుభ్రంగా ఉండాలి, మనం వాడే ఎక్విప్మెంట్ శుభ్రంగా ఉండాలి. ఇవన్నీ ఉంటే డెఫినెట్గా. అండ్ ఎయిర్ క్వాలిటీ కూడా ఇంపార్టెంటే. ఎయిర్ క్వాలిటీ, వాటర్ క్వాలిటీ, వాట్ సర్ వాజ్ మెన్షనింగ్, ట్యాప్ వాటర్లో డెఫినెట్గా ఇన్ఫెక్షన్ ఉంటుంది. వై ట్యాప్ వాటర్ అంటే మేము డయాలసిస్లో లాట్ ఆఫ్ టైం వి యూస్ వాటర్. మేము ఆర్ఓ ప్లాంట్కి వెళ్ళి ఆర్ఓ ప్లాంట్లో కూడా కల్చర్ చేస్తాం. మేము ఎవ్రీ మంత్ మా దగ్గర కల్చర్ చేస్తాం సార్. ఒకటి ట్యాప్ వాటర్ కల్చర్ ఉంటుంది. ఆ వాటర్ని మేము ఆర్ఓ రివర్స్ ఆస్మోసిస్ ప్లాంట్ ద్వారా క్లీన్ చేసి దాన్ని మనం పేషెంట్కి పంపిస్తాం. బ్లడ్తో కాంటాక్ట్ అవుతుంది. దాన్ని అక్కడ మేము ఆర్ఓ ప్లాంట్కి వెళ్ళేటప్పుడు ఒకసారి వాటర్ కల్చరు, బయటకు వచ్చిన తర్వాత కల్చరు, పైపుల ద్వారా వస్తుంది, పైపుల ద్వారా డయాలసిస్ మిషన్కి వచ్చిన తర్వాత కల్చరు, పేషెంట్ దగ్గర పోయే దగ్గర కల్చర్. ఇవన్నీ కల్చర్ తీసుకొని ఎక్కడైతే కల్చర్ పాజిటివ్ వస్తుందో డెఫినెట్గా ఆ మిషన్ డిస్ఇన్ఫెక్ట్ చేస్తాం మేము. ఇప్పుడు నేను చూపెడతాను రెగ్యులర్గా యాజ్ ఎ హెడ్ ఆఫ్ ది డిపార్ట్మెంట్ ఐ విల్ సైన్ దట్ డాక్యుమెంట్. ఎవ్రీ టైమ్ ఆర్ఓ వాటర్ క్వాలిటీ నేను చెక్ చేస్తాను. చెక్ చేసి దానిలో ఏమైనా ప్రాబ్లం ఉంటే డెఫినెట్గా ఐ విల్ ట్రై టు క్లోజ్ దట్ డయాలసిస్ మిషన్, డిస్ఇన్ఫెక్టెడ్ అండ్ అగైన్ కల్చర్ చేసి పాజిటివ్ ఉన్నది నెగిటివ్ అయిన తర్వాతనే వాడతాం. సో వాటర్ కల్చర్ కూడా డాక్టర్ గారు వాజ్ మెన్షనింగ్ వాట్ ఎవర్ ది వాటర్ వీఆర్ యూజింగ్ డెఫినెట్గా వీలుంటే ఆర్ఓ ప్లాంట్ వాటర్ వాడండి, ఆర్ఓ వాటర్ వాడండి, లేదంటే డిస్టిల్ వాటర్ వాడండి. యాక్చువల్గా మీరు అన్నట్టు సార్ ప్రతి దగ్గర సిఎస్ఎస్లో ఆర్ఓ ప్లాంట్ ఉండాలి. మేడం ఆల్రెడీ మీరు ఒక రికమెండేషన్ ఇచ్చారు. సిఎస్ఎస్డిలో ఒక టీచింగ్ హాస్పిటల్లో సిఎస్ఎస్లో ఏమి ఉండాలన్న ఎక్విప్మెంట్ చూస్తే ఆర్ఓ ప్లాంట్ ఉంది. సో ఆర్ఓ ప్లాంట్ వచ్చిన వాటర్ మీరు వాడాలి. సో దాన్ని కూడా రికమెండేషన్ ఇస్తాము. డెఫినెట్గా గ్యాప్ అనాలిసిస్ గురించి కూడా డిఎంఈ గారు మీకు ఒక ప్రొఫార్మ్ పంపించుంటారు. ఇప్పటికే ఒక్కొక్క హాస్పిటల్లో ఏమున్నాయి ఏం లేవు అనేది ఒక ప్రొఫార్మ్ పంపించుంటారు. ప్రొఫార్మర్ లేకుండా డెఫినెట్గా విల్ ట్రై టు గివ్ దట్ ఎక్విప్మెంట్. లేకుంటే ఇద్దాం సార్. నేనేదంటే ఏదైతే కావాలో ఏది స్టాండర్డ్ ప్రకారంగా ఒక సిఎస్ఎస్డికి టీచింగ్ హాస్పిటల్లోకి ఏం కావాలో ఎక్విప్మెంట్ మేడం ఒక లిస్ట్ తయారు చేశారు. ఆ లిస్ట్ డిఎంఈ గారికి ఇవ్వడం జరిగింది. డిఎంఈ గారు ఒక ఎక్సెల్ షీట్లో అందరి సూపరింటెండెంట్కి పంపించడం జరిగింది. లేకుంటే ఏం కావాలన్నది కూడా గ్యాప్ అనాలిసిస్ చేసి డెఫినెట్గా దట్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్, ఇన్ఫెక్షన్స్ కాదు. యు ఆర్ నాట్ ఇన్ఫెక్షన్స్ ఆఫీసర్, యు ఆర్ ఇన్ఫెక్షన్ కంట్రోల్ ఆఫీసర్స్. లేదు ఇవన్నీ పెడదాం సార్ మేమన్నా ఇప్పుడు. ఎస్ 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 కాదంటే రికమెండేషన్స్ ఆర్ కమింగ్ ఫ్రమ్ ది టాప్ ఎండ్ ఓన్లీ. టాప్ ఎండ్లోనే రికమెండేషన్ ఎలా ఉండాలో మనమే ఇస్తున్నాము. అవి విల్ ట్రై టు ఎన్ష్యూర్. అయిన తర్వాత కూడా అయిందంటే మనం వేరే కారణాలు కూడా ఎదుర్కోవాల్సిన అవసరం ఉంది. అలా హెపా ఫిల్టర్స్ ఉండాలి. ఎయిర్ క్వాలిటీ మేనేజ్ చేయడానికి హెపా ఫిల్టర్స్ ఉండాలి. సార్ అంటే మీరు అన్న పాయింట్ విల్ టేకెన్, డెఫినెట్లీ విల్ అడ్రస్ దట్ ఇష్యూ. రీసెంట్గా కూడా 302 or 340 దానిక లేబర్ రూమ్స్ ఒక 1,00,000 ప్రోగ్రాంలో అంతా ఆధునీకరణ జరిగింది. దానికి 23.5 crores ఎంతో అయింది. అలానే మన తెలంగాణ రాష్ట్రంలో మన హాస్పిటల్లో ప్రభుత్వ హాస్పిటల్ ఎన్ని థియేటర్స్ ఉన్నాయి, ఏ స్టాండర్డ్స్ ఉన్నాయి, దాని గ్యాప్ ఏంటి, ఏం పెడితే బెటర్ అవుతాయి, లెట్ అస్ అనలైజ్. మీరందరూ వీఆర్ పార్ట్ ఆఫ్ ఇట్, నో వీఆర్ పార్ట్ ఆఫ్ ది ప్రోగ్రామ్. మన అందరం కూర్చొని ఒక్కొక్క థియేటర్కి అసలు గ్యాప్స్ ఏమున్నాయి, ఏం కావాలి అవన్నీ అనలైజ్ చేద్దాం. దానికి కావాల్సినది ఎంతో బడ్జెట్ ఒక ఎవాల్వ్ అయితే డెఫినెట్గా ఇప్పుడు 302 or 340 లేబర్ రూమ్స్ అన్ని ఆధునీకరించడం అంటే ఇవన్నీ చేసినాం మనం 1,00,000 ప్రోగ్రామ్ కింద. అన్ని థియేటర్లు ఒక 300 మొత్తం కలిపి మన హాస్పిటల్ ఎన్ని ఉంటుంది, 150 హాస్పిటల్ ఉంటాయి. 150 హాస్పిటల్ కావాలంటే మనకు 500 థియేటర్ ఉండొచ్చు మ్యాక్సిమం ఉంటే. నో 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 సార్, నో 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 కంప్లైంట్స్ సార్. అవర్ డెఫినెట్గా సార్, డెఫినెట్లీ వీఆర్ దేర్. నో కంప్లైంట్ సార్. నో మంత్రి గారు కూడా పొద్దున ఏం చెప్పాను, మీరే ఇంకెవరైనా మాట్లాడమ్మా. మీ క్రిటిసిజం డెఫినెట్గా ఉంటే చెప్పండి, పెంచుదామమ్మా. వినండి, ఏం కావాలో పెడదాం, రెక్టిఫై చేద్దాం సార్. అంటే మేము అనేది ఇప్పుడు సార్ చెప్పారు వాటర్ గురించి, లీనర్ గురించి లెట్ us have some consensus. లీనర్ ప్రాబ్లం ఉంది. అంటే అది రికమెండ్ బాగానే ఉంటుందా ఎయిర్ ప్యూరిఫైయర్ ఉంటుంది ఏం మేడం
Sir, I'll check and let you know what is the advantage and disadvantage of air purifier.
డెఫినెట్గా ఉండదు
Sir, actually we have aerofogger machine, sir. Gangadhar sir, we have aerofogger. Aerofogger we have in our laboratory, sir. We can clean the environment by using the aerofogger also, which has a composition of hydrogen peroxide.
మంచి సజెషన్స్ ఇచ్చారు ఇవన్నీ లెట్ us tabulate it and let us have a consensus, no problem. లే బాడెన్ అంటే ఏం లేదు సార్ అంటే అంతే కరెక్ట్ 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 ప్రాక్టికల్ సొల్యూషన్స్ ఇద్దాం సార్ అనేది ప్రాక్టికల్లీ విల్ అడ్వైజ్ ది గవర్నమెంట్ ప్రాపర్లీ విల్ టేక్ ది బడ్జెట్ విల్ స్ట్రెంథెన్ ది థియేటర్స్ అంటే ఇవన్నీ పెట్టడం వల్ల ఏంటంటే మంత్రి గారు మంచి ఉద్దేశం ఏంటంటే ఒక దగ్గర ప్రాబ్లం అయింది ఆ ప్రాబ్లం నుంచి పారిపోకుండా ఆ ప్రాబ్లం నుంచి లెసన్స్ నేర్చుకొని ఇలాంటి ప్రాబ్లమ్స్ మిగతా దగ్గర రాకుండా ఏం చేయాలనేది ఒక ప్రోగ్రామ్ పెట్టారు ఇది ఇట్ ఈస్ నాట్ గోయింగ్ టు ఎండ్ ఈ 2 రోజుల తర్వాత మీకు మాకు సంబంధం లేదని కాదు డెఫినెట్లీ వీఆర్ గోయింగ్ టు హ్యావ్ ఎ డైలాగ్ ఎస్ వీల్ డెఫినెట్గా 100% we will take it to the heart, sir. We will take it to the heart and we'll try to solve the issues. Yeah. No. We will not dishearten you. We will not dishearten by ourselves. No problem. No issue. సో మీరందరూ కూడా ఎవరైతే మాట్లాడలేకపోయారమ్మా మీరందరూ ఒక పేపర్ మీద రాసిస్తే మీరందరూ కూడా అంటే అందరికీ ఆపర్చునిటీ రాలేదు సార్ బాగా మాట్లాడారు ఇంకెవరైనా మాట్లాడడం తెలుసుకొని చెప్పలేకపోతే ఓ పేపర్ మీద రాసి మన మేడంకి ఇవ్వండి మేమంతా కంపైల్ చేస్తాము డెఫినెట్గా మీరు ఇచ్చిన ఏ సజెషన్ కూడా మేము వృధా పోనీయము డెఫినెట్లీ విల్ ట్రై టు యాక్ట్ ఆన్ దట్ అండ్ గవర్నమెంట్ దగ్గర బడ్జెట్ కూడా ఉంది ఓన్లీ థింగ్ హౌ టు ఛానల్ ఇంత మార్నింగ్ చెప్పారు 2 కోట్లు ఉన్నాయి ఖర్చు పెట్టట్లేదంటే అది కూడా గైడ్లైన్స్ ఇవ్వట్లేదేమో మేము తప్పు మన అడ్మినిస్ట్రేషన్ దగ్గర ఉండొచ్చు దాన్ని కూడా మనం ట్రై టు రెక్టిఫై అండ్ విల్ గో ఫార్వర్డ్ మంత్రి గారు అంతా ప్రోయాక్టివ్గా ఉండి ఈ ప్రోగ్రామ్ పెట్టినప్పుడు డెఫినెట్లీ విల్ ట్రై టు యూటిలైజ్ దట్ అండ్ విల్ సీ దట్ అవర్ మెయిన్ ఫోకస్ టు ప్రివెంట్ ది ఇన్ఫెక్షన్స్ అని ఎట్లా చేద్దామో చూద్దాం మనం అంతే ఓకే
థ్యాంక్ యూ సార్
ఎస్ మ్యామ్ అది పెద్ద ఇష్యూ అది చేయాలి అది ఇండివిజువల్ హాస్పిటల్ ఇష్యూ డెఫినెట్ నేను మాట్లాడుతున్నాను దట్ ఎవ్రీవేర్ ఉంది నేను మాట్లాడతాను ఐ విల్ టాక్ టు యు
థ్యాంక్ యూ సార్ సార్ ద సెషన్స్ ఫర్ ద డే హ్యాస్ ఎండెడ్ సార్ and we have a small luminescent lamp by Raman and Wheel Company where they can check their hand hygiene practices through ultraviolet light. If anybody are interested, they can come and just check your hands. No, but he will he will not supply, but time being you can check what is your hand hygiene practice. Sir, that's our practices are not good, it implies, sir. So tomorrow the session starts at 9 o'clock.